morning, everyone. On behalf of Yashoda Group of Hospitals, I would like to take this opportunity to welcome you all for this CME program on lung cancer, Changing Paradigms 2023. It's my honor and privilege to welcome you all on this today's day, that is the World Cancer Day. A lot has been happening in the field of cancer in the last, I would say, last couple of decades. And the outcomes of the patient in general about cancer has been improving in the last few years with quite a tremendous numbers. And one of these, I would say, the poster boys as far as the oncology success is concerned is lung cancer. If you really look at the maybe a couple of decades ago, on an average, the survival of advanced lung cancer used to be very dismal, like almost like 6 or 8 or 10 months. And those were the numbers what sometimes we also used to give to our patients, that this is what we are going to expect in terms of the outcomes. But if you currently look at the latest data in this regard, and you can actually make out that almost 20% of patients, even in the advanced disease, they do survive more than 5 years. So there has been a significant advance as far as the science is concerned. And this is all possible because of the advances in the better, I would say, imaging techniques, better pathological diagnosis, better molecular mapping of the tumors, just to understand to get into the genomics part of it, better surgical techniques, robotic surgeries, newer techniques as far as the radiation is concerned, and not to forget the advances in the medical oncology. So we don't only talk about chemotherapy these days, but we do talk about immunotherapies, targets, are more so, I would say, the precision oncology. So today's attempt is all about getting all this information on the board, and we have got an elite panel of our speakers who are going to discuss all these issues and all these aspects or all those facets of lung cancer. My name is Dr. Nikhil. I am the medical oncologist, and I am one of the program directors for today's meeting. So once again, I welcome you all for today's CME. I am sure this will be definitely, especially for students, this will be a definite academic extravaganza. And without further ado, I would like to hand over the mic to Dr. Firdaus, who is my colleague, and she will start the further proceedings, taking us through session 1. Thank you so much.
Good morning, everyone. Moving on to our first session of the day, I request our chairperson, Dr. Navneet Sagar Reddy, sir, Senior Consultant Pulmonologist, to join onto the dais to chair the session. Our first topic for the day is a pulmonologist perspective in thoracic oncology regarding diagnosis, staging, and supportive care. I request Dr. Vishweshwaran, sir, Consultant Pulmonology, Yashoda Hospital, Somajiguda, to join us for the session. Thank you.
Morning. First of all, I would like to thank the organizers, Dr. Nikhil, Dr. Bharat, and the team for this honor to be chair this session. As we are all aware, that today is the World Cancer Day. But choosing the lung cancer, I think I should congratulate the team, because it is one of the commonest cause of mortality, morbidity and mortality in the world among all cancers. 1/3 of the cancer deaths are because of the lung cancer. In spite of technological advancements in the diagnostics, still at the time of diagnosis, the lung cancer is usually picked up in 3rd and 4th stages, advanced stages. It's world over, not only in India, it's world over. The same thing. I think we need to concentrate and think on this aspect. I request my oncology team also, in future, let us do something to pick up the cases in the early stages so that the treatment, a curative treatment can be planned. There are a lot of advancements in the treatment, as Nikhil has already briefed, from 1899, the radiation therapy, to 2023 mRNA vaccines for the cancer. The treatment is tremendously changed, but the delay in the diagnosis is the reason for the increased mortality all over the world. So the pulmonologist plays an important and crucial role in the diagnosis, staging, treatment, and palliation. At all stages, pulmonologist plays a crucial role in the treatment or in the lung cancer care, including he is a core member of medical board, multidisciplinary cancer boards. I think with this brief introduction, I request my colleague, Dr. Vishweshwaran, is a good speaker, good academician. I think he will highlight topic given to him. He will do the justice. Thank you.
Thank you, Dr. P.N.S. sir, and good morning to everyone present here. Thanks to the organizers, Dr. Nikhil, Dr. Harish, and others from the oncology team for giving us this opportunity to present our perspective as a pulmonologist in the management of lung cancer. So we all know that unlike in the Western population, most of the lung cancers in India are generally diagnosed very late, and maybe from our colleagues we can also hear that most of them will be either in the stage 4, or even if they are in stage 4, they will be so emaciated that they may not be even fit for a palliative chemotherapy. And one dreaded thing in India is most of the lung cancers patients would have received an empirical course of a tuberculosis treatment because even amongst the pulmonologists, there is lack of awareness for the need for a histopathological diagnosis to arrive at a diagnosis. All these things results in an advanced stage, poor functional status of the patient, and limited survival. And in India, unlike the Western population, palliative care is not given so much of importance, and it is nearly almost non-existent. And if you see the stage at which the lung cancer is diagnosed, you can see that almost 57% of the patients of lung cancer generally present to the tertiary care center with almost a distant metastatic condition, so probably their outcomes are going to be much lesser in comparison to the Western colleagues. So I'll just take you through a case, and I will try to impress upon how a pulmonologist can really play an important role, where his role is from the stage of diagnosis to the stage of staging and to the stage of providing the palliative care. So we have this patient who is a 40-year-old female housewife. She is a resident of Mathura, a tobacco chewer and a hypertensive for the past 1 year, non-diabetic, and a history of biomass fuel exposure is there. She presented with complaints of chest pain for the past 4 months, which was gradual in onset, progressively increasing in intensity, which worsens with deep inspiration and non-radiating, and fever is there for almost 1.5 months, not associated with chills or rigor, or no history of night sweats. And the patient also has got a history of shortness of breath for the past 15 days, and there is also a history of loss of appetite and loss of weight. There are no other histories of any cough or wheezing or hemoptysis or pedal edema, no palpitations or syncope, and no history of pulmonary tuberculosis in the past, and there's no history of any hoarseness of voice or dysphagia, and no family history. So when your X-ray was done outside, in X-ray you can see that there is a presence of a massive effusion on the left side with the shift of the mediastinum to the right. And CT scan was also done. She was carrying it from outside. That is also suggestive of a massive effusion. And as always like the first line of investigation in such patients with a massive effusion is you do a pleural fluid analysis. So the patient underwent a pleural fluid analysis outside, which was found to be lymphocytic, and ADA, which was in the borderline, which was 38 units per liter, and the cytology was not suggestive of any malignant cells, and unfortunately outside they didn't send it for cell block. And the patient, as always in most of the centers, was started on ATT from outside, but the patient did not have any response to treatment for 2 weeks, and the patient continued to have almost 200 to 300 ml of pleural fluid every day. So here comes the important thing for the pulmonologists who are in the hall. Like ADA is not a very sensitive marker until and unless you have got a very high levels of ADA. Like generally we take when it is more than 60, your pretest probability of having a tuberculosis is high. Whereas in this case it was only 38. So it was a borderline, and any patient who presents to you with a borderline ADA with a massive effusion, with a background status that could suggest a malignancy, they should be evaluated further and should not be started on an empirical ATT. So in this case, what pointed towards a malignancy was there was a massive effusion, there was an indeterminate ADA, and there was a pleural thickening on CT scan. So on arrival, we did a thoracoscopy, and in the thoracoscopy, you can find out there is a presence of extensive pleural lesions, and biopsy is taken, and it turns out to be an adenocarcinoma of the lung in this patient with a TTF1 positive. So the pulmonologist really plays an important role, because here, luckily in this patient, we had lost only 2 weeks of care. But what if this patient was on ATT for almost 6 months, and the patient later presents to you in almost an emaciated state where you could not have offered anything for this patient? So pulmonologist becomes the first point of contact for most of such patients, and suspicion of malignancy should always be high in patients who has got a high pretest conditions. And many things can be offered to such patients, maybe in the form of a bronchoscopy, your EBUS TBNA to arrive at a diagnosis and staging, and medical thoracoscopy, as in this case, can clinch you the diagnosis rather than wasting time to look for response on ATT. In addition to this, the pulmonologist also plays an important role in staging. He also assists the oncologist in the management. He also assists in managing the complications and managing further symptoms. So to do this, we have got a multiple of things where a pulmonologist looks into the radiology. And one important thing that we are always skeptical in India is the solitary pulmonary nodule, and we will go through each of these things in detail. So whenever a pulmonologist sees an X-ray, these are the things that should give you a clue. Probably you're not dealing with a routine infection like a TB, and probably you're dealing with something like a malignancy. For example, when you're seeing a speculated mass lesions as you see it on your left side, then probably it is not a routine infection or a TB, it can be an underlying malignancy. And if you see the X-ray onto your right side, you can see that there is a presence of pleural calcifications. Many a times we neglect it, but this may be the sign that the patient is having an underlying mesothelioma and they need to be evaluated further. So apart from your X-ray, another most important thing that provides an important clue for the pulmonologist is the CT tomography. So CT remains the single most investigation for screening, diagnosis, and monitoring of lung cancer. And CT has got a multiple advantages over X-ray. In fact, in Western countries now we have something called a low-dose CT protocol to actively screen for cancer amongst the high groups. But however, in India, we still don't have access to it. But with the advent of COVID, at least the acceptance of the CT amongst the public is much higher. So CT helps in earlier detection, accurate size measurement, accurate lesion characterization, like the attenuation, the edge characterization, the presence of cavitation, calcification, and the contrast enhancement. It helps to understand probably the stage of the lung cancer also, whether you have got a lymph node metastasis or not, the chest wall or the mediastinal invasion, and also with your upper abdominal cuts, you can also have some idea about the liver and the adrenal mets, so that you know just with your CT scan, probably your patient could be a case of a metastatic lung cancer or not. And whenever do we get a CT scan and it is an approachable lesion, here comes the point whether you are going to do an FNAC or a biopsy. So generally the dictum is your FNAC will not give much yield for diagnosis, and only a biopsy, preferably a CT-guided true-cut biopsy, if it is a peripheral abutting lung lesion or if it is in the liver, can give you the diagnosis. So it has got a more positive yield than the FNAC, and generally the risk of complication is pretty low, and this provides a chunk of a tissue where you can subject it for molecular analysis as well as the genetic testing. And when you are doing a CT-guided biopsy of the lung, you may have a chest pain, hemopsis, as well as pneumothorax. So studies have clearly said that your CT-guided core biopsy is much better than FNAC, both in terms of diagnosis as well as in providing adequate tissue for further characterization of your lung cancer. In addition to this, your CT scan can also have pictures like this where it shows the presence of a mediastinal invasion, and sometimes innocuous non-resolving pneumonia is nothing but probably an adenocarcinoma of the lung. We have seen many patients who presents to you with non-resolving pneumonia treated with multiple courses of antibiotics, and later when you biopsy it, you know that you are dealing with a case of a lung cancer. In addition to this, even such small lesions, which looks like a predominantly a GGOs or the ground glass opacities, and more we attribute it to routine viral infections, these have turned out to be adenocarcinomas of the lung. And in addition to this, your CT scan can also say that whether there is any evidence of any vascular invasion, as in this case, and it can also help us to plan the further line of management. And this is what I was referring to. Your CT scan extends beyond your lung. It shows whether there is a chest wall or a mediastinal invasion. It will also show whether there is a presence of a liver metastasis, as you can see from the picture D, which shows the presence of a liver mets as well. In addition to this, your CT scan can also help in nodal staging to a certain extent, but in India, whenever you see a node in a lung cancer, it is always wiser to biopsy it, because many a times these nodes can turn out to be secondary to a granulomatous inflammation like a tuberculosis, and probably the staging of the lung cancer also entirely changes when these nodes are accessed with EBUS. And in addition to this, it can, as I said to you before, it can show the rib wall erosion, and it can help in planning the management, especially when you're dealing with a case of a Pancoast tumor. Another important thing that we as a pulmonologist face and have a difficulty in approaching and understanding is the solitary pulmonary nodule. So any nodule which is less than 3 centimeters in size and associated with a normal parenchyma, which is not explained by any of the etiologists, then we refer to as a solitary pulmonary nodule. And when the size starts increasing, then probably that is where you need to suspect your patient may be going in for a malignant transformation. And generally, it is said that generally the absence of a detectable growth over a two-year period, then these nodules are considered to be benign. But having said that, we have seen patients who has got a not detectable growth even after 2 years, and when we biopsied it, we had adenocarcinomas as well. And whenever the nodule is rapidly growing, very rapidly growing, then probably it is a benign etiology, and the majority of these nodules have a doubling time between 220 to 400 days. So whenever you look into the solitary pulmonary nodule, you need to look into the morphology, whether these nodules are spiculated or irregular margin or lobulated margin. And whenever you have a spiculated margin, then the positive predictive value for malignancy can be high to as high as 90%. And in addition to this, whenever you are seeing some sort of a cavitations, which is predominantly irregular cavity, then probably that can be a malignant. And sometimes these nodules can be associated with a lymphatic involvement surrounding the nodules, which presents as a lymphangitis carcinomatosis as well. And generally, most of the solitary pulmonary nodule occurs on the right lung, which is again a diagnostic dilemma for a pulmonologist, because even your tuberculosis occurs on the right side of the lung in the upper aspect predominantly. And whenever these nodules are associated with calcification, which may be a central laminated popcorn calcification, then probably that is when we suspect that these nodules to be benign, like in the case of a hamartoma. So in addition to this, in the nodules, we look for the CT attenuation. These days, the adenocarcinomas can also be are characterized based upon the solitary pulmonary nodule. Whenever you got a purely solid nodule, all these nodules are at a higher risk of malignant transformation, and you need to follow them up carefully, and if needed, you need to biopsy them. Whenever you got a part solid, that is a portion of the nodule is solid and a portion of the nodule is GGO, then also there is a high element of malignant transformation. Only when you have got a purely GGO nodules, which does not have any solid component, then probably the chances of having malignancy is less. So this is one such case where we had a 45-year-old male who was a smoker. He had a loss of weight, loss of appetite, and low-grade fever for 2 months, and CT scan was suggestive of a 1.1 centimeter nodule in the left upper lobe. If you look through the nodule, this nodule is not having a rounded margin. It was having more of a spiculated margin, and there is evidence of slight lymphatic extensions beyond the nodule as well. So in such cases, previously we need to go for extensive modalities like a lobectomy to find out whether these nodules are malignant or not, because trying with a CT-guided biopsy in this case would have been a high-risk procedure, because there is 100% chance that you will develop a pneumothorax. So in such cases, we do something which is referred to as a navigation bronchoscope. So these navigation bronchoscopes are advanced platforms which helps us in accessing, providing us the path and takes us to the site of the lesion, and from there we take the biopsy from these lesions. So this is how a navigation bronchoscopy is performed in reality, where I am passing the scope and the software is providing me the exact route map where I should go, and I am passing a radial probe EBUS and I am localizing the lesion, and once the lesion is localized, I am taking a sample from there, and on table my pathologist says that it is a case of a atypical cells in the rows, and we know that we are dealing with a case of a malignancy. In addition to this, we also have something developed which is newly coming into the domain, is the role of the cone beam CT. So here you can see that there is a very small nodule in the left lower lobe. So in such cases, what we do is we do something called as a cone beam CT. Instead of using the C-arm that we traditionally use, we use a CT to localize this lesion. And once the lesion is localized, then as you can see from here, the lesion is mapped. So the lesion is totally mapped. These lesions are not seen on the C-arm, and once it is done, a biopsy is taken under the guidance of a radial EBUS. And we are the third center in the, first center is our counterpart has done in Yashoda, and we are the third center in the country to do a cone beam CT for biopsy of these lesions. So in addition to this, there is also a role of a PET CT scan in the diagnosis of lung cancer, especially when you're dealing with a solitary pulmonary nodule. It also provides the ideal site for localization of a biopsy. It also helps in the staging. And whenever you treat a patient with a chemotherapy, then probably to restage also, your PET CT scan plays a very important role. So we look something into the SUV uptake, and this SUV uptake can give us a diagnosis to a certain extent whether we are dealing with a malignancy or not, but there is a lot of false positivity and false negative values associated with the SUV as well. So, but one thing important to notice, whenever you got a PET avid node, it doesn't mean that it is always a malignancy. Because many of times when we have seen that when we have sampled these nodes, we have got tuberculosis in these nodes, and sometimes we have got both tuberculosis and malignancy in the same setting as well. So whenever you have a PET CT lymph node, suggestive of a lymph node PET avid lesion in the lung, then probably these are the patients who has to be subjected for the EBUS TBNA or for mediastinoscopy for sampling of these lymph nodes before taking them for any curative intent treatment. And PET is also useful for the evaluation of the metastasis. So, but one thing to be noted is PET is not a good sensitive marker for detecting the metastasis in the brain, because there is a high physiological uptake in the brain. And PET CT can also help in identifying the liver lesions, especially because many a times in CT scan you will see a hypodense lesion in the liver. You will be confused whether you are dealing with a metastasis or you are dealing with a hepatic cyst. So your PET can clearly provide whether it is a metastasis or not. And in addition to this, PET plays a very important role in your adrenal metastasis as well. And whenever you got a positive pathological FDG uptake, it doesn't mean that it is always malignant. See, as I said before, it can be fungal infections. We have seen aspergillosis having a PET avid lesions. We have seen tuberculosis having PET avid lesions, and even secondary infections having PET avid lesions. And sometimes your malignancy may be there, but your PET may be still negative, especially in terms of minimally invasive adenocarcinoma or in carcinoid tumors. And before I finish, these are the last few slides. The most important armatorium that a pulmonologist has in his basket is the EBUS TBNA. Unlike before, where patients with mediastinal nodes had to be subjected for extensive mediastinoscopies, which are associated with its own set of morbidity and mortality, these days we have minimally invasive procedures like a EBUS TBNA, which are generally done as a daycare procedure, where we get the diagnosis on table and we also do the staging on table. So this is one such lesions where a patient was having a lung cancer and was having a PET avid lymph node. So you can see from here, we are visualizing the lymph node with the help of the EBUS, and we are using the needle to get the sample from this lymph node under real-time guidance. And what it turned out to be, as I said to you before, was a granuloma. So probably this entirely changed the staging of the patient from a patient who was planned for a palliative treatment. Now the patient becomes a case for a curative intent as well. So recently the guidelines also clearly says that the EBUS is preferred over a surgical staging as a best first line test for patients with intermediate and high suspicion of N2 and N3 lymph node involvement. And EBUS staging may be warranted in non-surgical candidates to confirm N0 disease prior to SBRT as well. And it is found to have excellent sensitivity, specificity, accuracy, positive predictive value and negative predictive value as well. And so there are few lymph nodes sometimes which may not be approached through the EBUS. So in such cases, what we do is we pass the same EBUS scope into the esophagus. This is what we refer to as the USB. So the same EBUS scope can also be used for doing the staging of the mediastinum using the esophagus as a route. And the current evidence suggests that the combined technique is more sensitive than EBUS TBNA or USB FNA alone. So one last thing that has come recently into the our basket is what we refer to as an indwelling pleural catheter. So we may see many patients who has got a malignancy and they may have a trapped lung, and previously these patients used to roam around with their either a ICD or a PC window. These days we have something called as a indwelling pleural catheter. These are tunneled into the chest wall and are placed inside the lungs, and therefore the patient, it provides a lot of relief for the patient, and patient is mobile around, and this also helps in autopleurodesis. So to summarize, lung cancer management is a teamwork, and pulmonologists should be aware and should try and pick up cases very early. Learning the CT scan, and if required, PET should be ordered, and there is no taboo associated with not ordering a PET. And tissue is the issue, and right now we have multiple modalities at our hand to provide the adequate tissue for our pathologist. And palliation and management of complication is a must, and we should learn it. Thank you.
Thank you, Vishweswaran. Thanks for your lucid presentation.
Moving on to now I request Dr. P.N.S. Reddy sir to hand over a memento to Dr. Vishweswaran sir. Vishweswaran sir, please join us on the dais. Thank you, sir. That was a very detailed discussion. Now, our second topic for the day, I request Dr. Bhulakshmi ma'am, Senior Consultant Pathologist, Yashoda Hospital, Somajigoda, to join us for the discussion on diagnostic challenges, a pathologist's perspective. Thank you.
Good morning, everybody. At the outset, I would like to thank the organizers for giving me this opportunity of presenting the pathology view in in pulmonary oncopathology. So the diagnostic challenge, as sir has already said, tissue is always an issue. So we all know that the incidence of CA lung is increasing in the recent past. In 2022, around 19 to 20 lakhs of patients have been diagnosed with CA lung. When it comes to diagnosis, what are the samples which we are getting in the pathology lab is the first and the foremost important sample is the cytology, followed by the histopathology samples. So coming to cytology, the various modes by which these cytology samples are acquired are either the FNAC, which is a CT guided, or EBIS TBNA, or we can have the sputum cytology, the bowel fluids, the bronchial brushings, or the pleural fluid. In histopathology, we get different type of samples like core needle biopsies, the transbronchial lung biopsy, endobronchial biopsies, and all the needle aspirates and the fluids, we are making the cell block so that we can have adequate material for further testing. Now, in short, I'll just take you all through the processing of histopathology samples. The important step is fixation, because as we all know that lung cancer is now integrating lot of molecular testings. So if this step is hampered, then definitely the further RNA and DNA analysis will be affected in future when we are subjecting that block for the molecular testing. So after the sample is taken or the biopsy cores are taken, they have to be fixed in 10% buffered neutral formalin. Now, why I'm very specifically telling this is at the peripheral centers, the buffered neutral formalin is not available. Because of this, the DNA, especially the RNA studies, will have equivocal results, or the results may not be adequate or appropriate. So it is mandatory that the clinician who is taking the biopsy makes sure that the core goes into the 10% buffered formalin. All the major institutions are now having the 10% buffered formalin as their routine fixative. After the biopsy is taken, the sample comes to the pathology lab where we look at the gross appearance of the tissue, where we are looking at the how many cores are received and what is the length of each core. We measure each core separately and then document the length of each core. And if there are more than 2 cores, we are embedding now into multiple blocks. The previous practice was like if I'm getting around 6 or 7 cores, all the cores were embedded in a single block. But because of the lot of molecular assays testing requirement, now we have changed the practice of making a single block or multiple cores into making multiple blocks. So this is a tissue processor where we, after the specimen is grossed and the cassettes are taken, we load it into the tissue processor. This is the instrument where the tissue goes through all the fluids so that it becomes little hard, and then we can cut the tissue to take the proper sections. This is the sectioning, how we do it in the laboratory. Can I have the pointer? No, I can't. As you can see, the left-hand side corner, we can see the ribbons. No, cursor is not visualized. Here there is the ribbons which are coming on to the black station. That is nothing but tissue in the paraffin block. So we take, the routine practice is we only take the proper section onto the slide and then do the H&E staining. But when it comes to a lung tissue, and the rest of the ribbons get wasted or discarded. But when it comes to a lung tissue, we preserve all these ribbons, because if we know that this case is needing an IHC study or any further testings, we preserve those ribbons on separate coated slides, so those slides can be subjected to the immunohistochemistry study, and then the block is not depleted for the molecular studies. Because the moment I remove the block from the tissue, from the microtome and again replace it, again we have to cut it to get a proper plane. So in this process of re-putting and cutting, we will lose the tissue. So that's the reason at the outset only when we are taking ribbons, we make sure that the in-between sections are preserved for the IHC testings. When it comes to cytology, as sir has already suggested, that wherever the feasibility or the possibility of rapid on-site evaluation is available, we should go for it, because there are many advantages with that. First of all, we assess the adequacy of the tissue or the sample, and secondly, we also tell the clinician whether they are dealing with an oncology case or an infectious case. And based on that, we then suggest how the tissue has to be triaged, so that the cell blocks or the immunocytochemistry smears can be taken for ICC, or the tissue can be taken for the infectious studies. So this is just the process map of to show how the cytology lab works. So once a request comes from the clinician that there is a rose, the technician as well as the pathologist, they move on to the theater. Then the clinician gives us the sample, we look under the microscope, tell them that this is adequate and representative, and tell them the provisional diagnosis, whether it is a granulomatous or it is a malignancy case. Once it is malignancy, then we decide whether we can be able to give a definite diagnosis on without doing IHC, or we need IHCs. Basis on that, we ask him to take more material for the cytosmears as well as the cell block and the biopsy. And if it is an infectious case, then we ask for taking it for molecular. But there is a close discussion happening between the pathologist and the clinician about how to acquire the tissues and what are the additional testings to be needed. So basically, the good practice, especially in small biopsy and cytology specimen, is we have to try as far as possible to triage the tissue for the further testing. It is not just only giving a diagnosis and stopping at that. There are a lot of requirement coming from a pathologist or is required from the block. That's the reason we need to triage the tissue. So as far as possible, we are stopping the terminology like non-small cell carcinoma these days, because we have to categorize further with limited use of IHC markers, whether this is a squamous cell carcinoma or it is an adenocarcinoma, basis with the help of limited IHC markers. And there has to be uniformity in the data, so the clinician knows which cases have to go for the molecular testings. And we try to preserve the biopsy specimens. Like I was already told, we take multiple blocks so that one block can be subjected to limited IHC and the remaining blocks can be given for the molecular testing. Wherever required, a multidisciplinary MDT discussions can be taken up to see what best we can do for the patient for ordering the further testings. So the good practice would be whenever we are taking a biopsy, it has to be paired with the cytology specimens, because cytology gives us a hand where we can give diagnosis as well as we can do immunocytochemistry if required, so that the tissue can be preserved for doing the molecular studies. The terminologies like AIS and minimally invasive adenocarcinomas we are not using in the routine biopsies now. These are restricted only for the resection specimens. And whenever the morphology is suspicious for a neuroendocrine on cytology or on biopsy, we do IHC studies for neuroendocrine to see whether it is a small cell carcinoma or not. So this is just a flow diagram to show how we approach a core needle biopsy. The moment we know that it is a case of malignancy, we see what is the morphology. If it is a neuroendocrine morphology, depending upon the size of the cells, we call it as large cell or a small cell. And then we run the immunopanel of neuroendocrine markers like synaptophysin, chromogranin, INSM1 and TTF1, which are positive in neuroendocrine, and then we call it as small cell carcinoma or large cell carcinoma based on the morphology. If there is a clear-cut differentiation of the tumor that it is squamous, we call it as squamous. If it is an adeno, we call it as an adeno, and we don't subject the tissue for any further IHC testing, and straight away the block can be sent for molecular studies. If I'm not sure that the morphology is either an adeno or a squamous, then we call it as non-small cell carcinoma, NOS, where we do a limited markers, limit up to 1 or maximum 3, and then further categorize it whether it is squamous or an adeno. If both are positive, if one squamous marker, that is P40, is positive, because that is the most sensitive and specific marker, we call it as squamous cell carcinoma and sign it off as squamous carcinoma. If TTF1 is positive, we call it as an adeno and sign it off as an adenocarcinoma. If both are positive, then there is a possibility of it being an adenosquamous carcinoma. And if both are negative, which can still be possible because of the tumor being heterogeneous in nature, there we call it as non-small cell carcinoma, NOS, and inform the clinician that both the markers are negative so that they can plan for molecular testing. So as we are seeing in the entire process that there are so many times we are subjecting the block or the sections for multiple testings. So every time the block is getting cut, we are taking sections. In this process, there is high chances that we will lose the tissue. So when we are sending a block for molecular testing, we make sure that there is an adequate amount of tissue, because all the molecular assays, we are defining the cutoffs, what has to be called as positive and what has to be called negative. So if the tissue doesn't suffice to the cutoffs, then there is no point of doing molecular in that biopsy, and a repeat biopsy has to be done. Just to take you all through the some of the photomicrographs, how the histopathology looks in an adenocarcinoma. These are the infiltrating glands. You all can see the arrow is pointing toward the neoplastic infiltrating glands, which are very large, haphazardly arranged in a desmoplastic stroma. That was a case of an adenocarcinoma. This is a case of squamous cell carcinoma. We can see sheets of squamous cells, keratin pearl formation, individual cell keratinization. So it's a case of squamous carcinoma. So these cases were very classical on histology, so we need not do any IHCs and straight away diagnose the case upfront. Here we can see in the upside we are seeing sheets of squamous cells, and below we are seeing the adeno areas. So this was suspicious for an adenosquamous carcinoma. So this definitely needs IHC, because sometimes acantholytic areas in squamous or a poorly differentiated adeno can look like squamous. So we need to know whether it is an adenosquamous or purely adeno or purely squamous. So we do markers for adeno and squamous. The P40 was highlighting the squamous areas. Napsin and TTF1 were highlighting the adeno area, so we called it as adenosquamous carcinoma. This is how the cytology or the on-site evaluation looks, rapid on-site evaluation looks. We can see there are sheets of cells which are atypical large. The middle picture is showing the image of a bronchial cells. You can compare that with the tumor cells, how big and atypical the tumor cells are looking. So the same case was subjected to cell block studies, and this is how the cell block looks, where we are seeing clusters of tumor cells. We can see in the down figure a strip of adenocarcinoma epithelium, and again clusters of atypical cells. This is a case of a very poorly differentiated tumor. We can see that as compared to the previous cytology smear, here the cells are very small, they are dark, hyperchromatic, and we cannot appreciate any morphology. There is a lot of overlapping, streaming artifacts and crushing artifacts. So this is a very poorly differentiated tumor cells. The cell block also didn't give any clue for us what exactly this case is. So we called it as poorly differentiated malignant tumor. Then we did IHC to start with. First we run the epithelial markers. So first adeno marker and squamous markers were put up. The squamous marker was negative, TTF1 was positive. Now being TTF1 positivity, it can be either a neuroendocrine tumor or it can be an adenocarcinoma. So we did further testings and found that chromogranin and synaptophysin were positive in these atypical cells, whereas napsin A was negative. So that's why we favored a diagnosis of small cell carcinoma. So the pathologist has to do optimum utilization of the diagnostic material. So ROSE helps us in taking more material or taking more smears for doing the further testing. Ancillary testings can be done on immunocytochemistry, on the cytosmears. And as far as possible, we try to preserve the histopathology tissue for doing the molecular studies. And if all the above measures fail, then for further testing, we need to go for a repeat biopsy. Now, why all this is important is because there are a lot of biomarkers which are associated with this further classification of the adenocarcinomas or the squamous cell carcinomas. As everybody is aware that adenocarcinoma is associated with so many number of biomarkers, even the squamous cell carcinomas. These are the common molecular markers which are being tested in adenocarcinomas. The most common is the EGFR, ALK, ROS, RET, and these are the newer markers which are coming these days along with PDL1. And the methods of testing, so EGFR we are doing by the PCR method. ALK can be done with IHC, though molecular markers are also being, molecular method is also being recommended, but the sensitivity, specificity and the results with IHC and molecular are same. For ROSE, the recommended method, testing ROSE, the recommended method is doing a FISH, but all settings will not have the facility of doing FISH. So the best screening method for ROS would be doing an IHC. All IHC positive ROS cases have to be confirmed by FISH to see whether they are ROS positive on FISH, so that then the anti-ROS therapy can be given. PDL1 is then we are doing it by IHC method based on what the the epitopes the clinician is looking at. So the clinical significance of biomarkers, everybody is aware that there are targeted therapies available against each biomarker. So there is a lot of integration of this biomarker testing happening in the histology of CA lung. As we can see in 1970 to 2000, we were just classifying whether it is a small cell or a non-small cell carcinoma. Later on in 2004 to 2009, we were classifying the non-small cells into either squamous or adeno and testing for EGFR and ALK. But these days, along with this, we have a battery of biomarkers being tested like ROS, BRAF, MET, HER2/neu, and PDL1. So the role of pathologist starts right from acquiring the tissues, where we are looking at the adequacy, then we preserve or triage the tissue for doing further tests so that the rebiopsy to the patient is avoided. What I need from the clinicians is we get an adequate tissue course, because as we are seeing that so many steps and so many testing modalities are required for coming down to estimation of the biomarkers, a minimum of 5 cores of good length is needed, because 30% of shrinkage of the tissue occurs in fixation. So when I mean adequate tissue course, this can be addressed at the time of ROSE when the clinician is taking a tissue. He can go ahead with an imprint cytology, give it to the pathologist, and make sure that the lesion is showing viable cells and we are not taking only the necrotic areas, because many times it happens that the cores are of good length, but when it comes onto the slides, it is entirely necrotic. So this can be avoided by doing an imprint cytology. Wherever possible, the biopsy has to be paired with cytology. And fluids, when we are sending it for testing, we should make sure that the fluid are sent with an upfront request for making a cell block, IHC, and molecular studies. So the WHO is also changing the concepts of classification of lung. We can see that in 2004, it was based only on morphology, that is H&E slide. In 15, it has incorporated the IHC, and in 2020 and in further ahead, it is incorporating the NGS as well as the findings of liquid biopsies for the classification. This is my last slide. We can see that how the future of lung oncopathology is moving. The current scenario is there is single assay, single tissue, and in this process of doing multiple assays, we are losing a lot of tissue. But with the advancement of technology and availability of NGS and the utility or testing of liquid biopsies, all these assays can be done into a single platform. Like you can see on that side corner, NGS, it can be taken up for EGFR, ALK, ROS, and other biomarkers. We can do mRNA sequencing studies. So here where I'm using multiple slides, there it will be a limited number of slides being used. So the loss of tissue is limited and the rebiopsy can be prevented. I acknowledge my colleagues and the histopathology department. Thank you.
Thank you. Thank you, Dr. Pulakshmi Garu. I think we do accept that adequate tissue must be sent for the pathologist to give a proper diagnosis, and further studies can be done on that. We do accept that, and we'll try to send the adequate tissue in future. Thank you for highlighting.
Thank you, ma'am, for such an in-depth information. Now, moving on to our next topic. I invite Dr. Kalyan Ram, Managing Director, Gene Power RX, to discuss regarding precision oncology, the ultimate gambit in lung cancer management. Please join us, sir. Thank you.
Good morning, everybody. So good morning, everybody. Thank you, Ashoda and Dr. Nikhil, and thank you, the team, to giving the opportunity. So I'm Dr. Kalyan Uppaluri. I'm a general medicine physician and clinical genomics expert. So first of all, it was a very good talk, Dr. Pulakshmi ma'am, and I can say that out of all the samples we get, samples from Yashoda have very little tumor heterogeneity, and the samples are preserved very well. Thank you very much. So today's topic I'm going to discuss is about the lung cancer and how it is evolving, and more importantly, where we are going. So in a way, I should give a big applause to all the medical oncologists practicing, because I think After even 20, 30 years of practice, the most education right now are getting are the medical oncologists because of ever-changing paradigm of medical literature. So coming to that point, today I'm going to discuss about very few topics pertaining to lung cancer. And also I would like to highlight from Dr. Abulashmi ma'am, first slide. So the incidence of cancer is significantly increasing because today is World Cancer Day. And I think because of too much of CT scans done because of this COVID, I think there is a sudden increase in the incidence because that also implies what kind of screening modalities that we really need to adapt. By doing more CT scans, we are finding more cancers. So even Dr. Bulashmi ma'am focused on this one. Initially, it used to be easy back in 90s, cut the tissue, send it to pathology for histopathology, but it is not the case anymore. So there are too many markers and too many treatment options, and what are the molecular markers which will really change on the outcome of the patient. And there is a gamut of testing happening in multiple clinical trials. And just today morning, I did see how many clinical trials are going as of today only for lung cancer. So how many drugs are in phase 4? So there are 189 drugs in phase 4 which are going to be either approved or by FDA in the next 3 years. So all these drugs, these are new markers are coming into the market. So these are the mutation markers that we usually patient. This is what is recommended, and all of these mutations will have an targeted therapy available. But today I want to more focus on what are the technologies and what are the limitations of each and every technology, because I think on each and every of these genetic markers there is a talk about what is the importance of EGFR, what is the importance of ROS1, and I will talk more about the technologies. What are the technologies available, what are the limitations, and what are the quality checks and the technologies that we need to really ask our partners to ask the right questions. So this is the paradigm, how it is changing EGFR mutation, ALCROS1, BRAF, V600, NTRK rate, and MET amplification, so on and so forth. So EGFR, if you'll just look at EGFR, in non-small cell carcinoma, there is a study published. It is only 15% incidence of all non-small cell lung cancers in US, but in a Chinese study, apparently the incidence is 62%. We do have initial evidences that we are between 22 and 60% when it comes to EGFR positive mutations specific for Indian population. And in our experience, it is around 38% of all the lung cancers. EGFR positive is 38%. We did almost, this is on 100 samples so far. So these are the alterations that we use, and these are the drug therapies which are approved in, some of them are resistance markers, especially EGFR T790M, T is threonine, M is methionine, so AUG is a start codon, so I will not go into details, but it is a start codon. So this is considered as a resistance marker, especially after giving chemotherapy, and if you find this marker, the treatment has to be adapted as such. So coming to the testing, NGS platforms and technology. So right now, even the NGS technology is rapidly evolving. So right now, the monopoly is through a company called Illumina. Illumina is a short sequencing rate. So Illumina is a gold standard right now. Most of the reference genome is based on the data which is out from Illumina. And there is a long sequencing, Nanopore and MGI. There are multiple people coming into the market at this time. And there is an Ion Torrent, which is a Thermo Fisher company. So the difference between Illumina and other companies is usually Illumina is the only technology which do cross-reading. So the predictability and the matching is alignment is almost 99%. So if you want to ask me straightforward what is the best machine available as of today, it is Illumina. Is it going to be there forever? I don't think so, because I think long sequencing is going to take over this short sequence reading. But coming to the analytical validation, uh, I do not know how many of, I think a lot of young people, but I don't know in medical school how many of you used an hemocytometer, the one that we used to sit in pathology department, and then you count the number of neutrophils, number of eosinophils to do a differential and write on a sheet of paper and then calculate and give a differential. So yeah, so NGS technology is at that stage right now. So it is very technician dependent. So there has to be multiple quality checks when you are doing this procedure. So getting from the right tissue sample, you have to look at are we really taking the DNA out of the malignant cell, and we have to see when you do the sequencing or you do the library prep, is the target that you want to really enhance, is it enhancing? The post-PCR check about all the targets that you want to look in the specific tissue sample are they enriched? And then the next thing is before sequencing itself, you have to have the final quality check in terms of all the number of alignments which are in place. And then you do the sequencing. The sequencing is straightforward. You put in the machine and then it does read sequencing. So ideal one, if you want to really look at all the markers with confidence, is around 2000x. So you have to enhance it at least 2000 times so that the false negatives are eliminated. So 2000x, it is a fancy word, but what it means is you have to enhance each read by 2000x. Some of them might be normal DNA cells, some of them might be cancer cell. So that is when the medical oncologist will understand this better. That is when we come to variant allele frequency ratio. So we need to understand how many of these layers have variant allele frequencies, which are around 5% to 10%. We consider it is somatic. And most of the non-small cell cancer is, as of now, are still considered somatic, which means they are not germline. So just a trivia, germline means we are born with it, somatic means which happened after we are born. So coming to the analytic validation, so you want to be on the leftmost corner. You have to be precise and accurate. So if you just take any DNA sample and then you do the library preparation and put it into sequencing, it shows out something. But is it something which is really precise and really accurate is what the analytical validation is all about when you're doing DNA sequencing. So usually what we need to do is before we do it, accuracy meaning what we follow is we usually do 50 samples randomly picked up from usually from any research institute, and then we do the sample, and only on one sample we do 3 different times through 3 different types, and then we compare. It has to match at least 99%, so that we say we are accurate and most likely precise. And then the same protocol should be repeated again and again whenever you are doing the tissue sample. And then I just want to make sure that I do this analytics when it comes to IHC, when it comes to FISH, when it comes to NGS, what are the advantages and what are the disadvantages. So IHC is an amazing test, and most of the testing can be done through IHC, especially the low-hanging fruits like already established medications which are available. IHC is the best test. The limitations are we can only test one sample, one marker at a time, and then the increased depletion of the tissue, as Dr. Bhulashi mentioned very clearly. We need to have that process from the operating table to the pathology department. The chain of command and the timing and how we fix the tissue will become the key when you are doing the IHC partner. And then you cannot detect any fusions with IHC. And then for fusions, it is very less validated. And coming to the FISH, also you can only do one marker at a time. And then there is also the issue with depletion. And the fusion partner and position is very difficult to identify. Only if you are test for one fusion partner, only you can test through FISH. And again, FISH is something very technician dependent. The protocols has to be very stringent. It is like fluorescence is only temporarily available. You have to look at when the fluorescent enhancement is at the highest. If you look before that and after that, the test may be screwed. And then when it comes to NGS, the results times are really varied, and the cost of sequencing is still an issue when it comes to our population, especially because of multiple patents with the sequencing technology. We are not able to bring the cost down and the reagents, and I am hopeful that there are multiple companies coming up in India which are going to have ingenious reagents which they are developing, so the cost might come down in the next couple of years. And there will be a significant drop in the sequencing cost as well, and it is going to be standard of care when you are treating with any cancer patients. So this is what I want to just discuss upon when it comes to each and every marker testings. So tissue PCR sequencing is almost obsolete. Right now what we are doing is tissue allele specific PCR. This is what EGFR testing is. So if you are looking at EGFR, HER2 mutation, MET amplification, BRAF mutation, and these things, tissue allele specific PCR is very good test, all the places that you see, but these things don't work with ROS rearrangement and ALK rearrangements. And when you go to the tissue NGS has very similar advantages over PCR testing. It also gives all the ALK rearrangements as well. And then when it comes to ctDNA or ctDNA NGS, and these things have very, they are not more specific or more sensitive than the tissue NGS, but they are comparable, especially if you do not have the tissue. And then tissue RNA. Tissue RNA testing excuse me, has very good positive predictive value, and it is a very good test. And it only depends on the quality of the tissue, and always tissue is an issue. So when you are talking about RNA sequencing, the ideal one, where most of the tertiary centers in US where practice, even in MSK or MD Anderson, what they practice is they just take this sampling directly from the OR in saline and then extract the RNA within 2 hours of the surgery. So that is the ideal case scenario when you are doing RNA-seq. And then usually what we do in formalin fixed is we extract the RNA, and then it is almost 60 to 70% sensitive. Most of the reagent companies claim that they are the best in the company where it comes to RNA extraction and assessment. But still, if we get a tissue directly from the OR, and within 2 to 3 hours, we isolate the RNA and fixed it. That is the ideal case scenario. And we can do the RNA sequencing as well, given the tissue is fixed within the first 8 hours. Even 72 hours, the tissue degeneration, the RNA is very short-lived. But it has very specific sensitivity when it comes to rearrangements. And these are some of the examples of how the nomenclature and how the EGFR is documented. So we need to have what is the chromosome and what is the exon number, and what is the change. Is it deletion, and if it is a deletion, how many codons are deleted, and then what is the variant allele fraction of each and every one. So that when you want to give it to any pharma company, they need to ask all these questions when they are approving this drug, because they don't want any of this drug to be given to the patient empirically. So they want to know what is the molecular marker, so that it is easy for them to track the patient to document the output, because most of these medications, the phase 4 is continuing as well. And this is how you document any fusion. So you need to have where is the break point and where is the attachment point. So the ENS is the global terminology that everybody is accepted. We need to know where is the intron, and what is the chromosome, and what is the position in the chromosome, and what is it the 3' area or the 5' area, where is it cut and where did it attach. And then we have to show that it did enhance the chimeric protein. That is where. So I will skip through the NTRK fusions, because just by having NTRK fusion doesn't mean the drug will work. It has to have a chimeric protein. And ctDNA analysis and tissue biopsy. Always in case if you don't have a tissue sample, rather than, because it is a lung cancer and surgeries are really invasive, there is always an option of going for an liquid biopsy where in cases of identifying the right mutation, we can definitely look for cell-free DNA and then isolation and then go for sequencing. So this is what the advantages that I want to tell about. It is used for prognosis and initial therapy selection and also for surveillance. And if there is any late stage or recurrence, again, a patient is not agreeing for another open heart surgery or a biopsy. In those cases as well, we can take an liquid biopsy and then see if there is any change or any new genetic marker which can be targeted. So all these tests are available and validated. And once again, I don't want to take much of your time, and thank you, Yashoda team, and Dr. Nikhil and Dr. Bharat for giving me this opportunity. Thank you all.
Thank you, Kalyan Rao. Nice presentation.
Thank you.
Thank you, sir, for a detailed and interesting presentation. Now we move on to our panel discussion. I invite our moderator, Dr. Vishweshwaran, sir, to join us on the dais. I request our panelists to join us on the dais for the discussion. Dr. Bhulakshmi ma'am, Consultant Pathologist, Yashoda Hospital, Somajiguda. Dr. Harish K, Consultant Medical Oncologist, Yashoda Hospital, Somajiguda. Dr. Shrikant Peddi, Consultant Pulmonologist, Yashoda Hospital, Somajiguda. Please join onto the dais. Thank you.
Good morning once again. So now we, we have a case-based panel discussion with our tumor board specialist also here. So I'll first brief you about the case, and during the course of the case, we'll try to understand from the experts like how they really handle such scenarios. So she's a 66-year-old female with a BMI of 26, hypertensive, diabetic on treatment, homemaker, no addictions, and presented with complaints of dry cough for 3 months, which increased for the past 1 month, and shortness of breath for 3 months, which increased for the past 1 month, loss of weight, and loss of appetite. And as you can see from the X-ray, which is down the slide, like there is a presence of a pleural effusion. So pleural fluid aspiration was done. It was a hemorrhagic in nature, and it was an exudative with a protein of 5.48 and low ADA. ADA was 14.4, and predominantly lymphocytic, which was 95. And cytology is negative for malignant cells. So from here, the patient was then referred, and the general physical examination vitals were stable, clubbing was absent. There's a decreased breath sound in the left intrascapular and interscapular region. All the other organ system evaluation is normal physically. And with the lab report, there is a mild anemia with a hemoglobin of 11.5, and other organ function systems in terms of creatinine and liver function test are within normal limits. So this is the CT scan we have of the patient. And I would like to hear from Dr. Shrikant Peddi sir, like what all the things that he notes in the CT scan, being a pulmonologist, when he sees such a patient.
Good morning, sir. Sir, CT scan is likely showing multi-loculated effusion along with some mass lesion in the left lower lobe, sir.
Okay.
Probabilities would be, first thing, Cytology, as cytology is negative, ADA is negative,
ADA is on the lower side, yes.
ADA is in negative, and exudative. So probability of malignancy in the first probably. And second thing would be any infective tubercular thing should also be considered.
And how common do you see tuberculosis effusion with a low ADA in your account? And what is the ADA cutoff which you take while starting these patients on ATT?
Sir, above 40 to 80.
Okay, you take around.
around.
So your cutoff for starting tuberculosis therapy is 40.
40 to 80.
And I would like to hear from Dr. Harish, like in his opinion, how many cases of patient who presented with a ADA of around 40 with a lymphocytic, you have seen them turning out to be malignant? Is it that common, or are we sure enough to say that when we have an ADA of 40 with a lymphocytic and exudative pleural effusion, we are confident enough that it is only tuberculosis in India?
No, sir. I've seen cases with the high ADA and lymphocytic and turned out to be malignant, because there are two types of ADAs, type 1 and type 2. Unless until assess the both them separately, sometimes even falsely high ADA can also be malignancy. And again, 20 to 30% of the cases can be still malignant.
So you feel, so in a country like India, despite having a high ADA, you still feel like there is a role of
The type of ADA we measure, sir. The
Type
type
of
of ADA we measure decides that. ADA 1 generally, more favors the malignancy. Unless until you don't measure separately, I cannot be sure about that.
And I'd like to hear from Dr. Bhulakshmi ma'am, like since we as pulmonologists keep sending samples, but we never ask for categorization of ADA, like we just get a plain ADA values in most of our reports. Is it being done in India, and is it being routinely done, the differentiation between ADA 1 and ADA 2?
As such, we are not categorizing them separately as ADA 1 and ADA 2. In our practice, we are just doing ADA. So.
Okay. And what could be the false positive reasons for high ADA, ma'am? Because many a times it so happens that we get a high ADA value, we are very confident in starting these patients on TB medicines, but still we don't find response, especially in an elderly subset. So what are all the false positive for high ADA values?
I think there are a lot of interferences in the sample itself which results to ADA, because the testing modality is not very sensitive and specific. The type of test what we are using is a very, what you can say, a low standard test. So that's the reason we, apart from ADA, we look at the rest of the parameters and then come to a conclusion.
Okay, so the point to be noted for the audience here is just a mere presence of a high ADA is not sufficient enough for you to start an ATT, though let's say that if you are having a very young patient who has got a lymphocytic exudative and a high ADA, then probably your pretest probability of malignancy is quite low and you are justified in starting these patients on ATT. But we have seen patients, especially elderly, having a high pretest probability of malignancy, like be it a smoker, and they present to you with a massive effusion, you do a pleural fluid analysis, you have a high ADA, then still these patients require a further evaluation, because these patients can have an underlying malignancy, and putting them on just an empirical ATT without further evaluation is not, which is advised even by the panelist. So now I'll move on to Dr. Srikanth Patel. So what would you recommend next in this patient? Would you like to go for a medical thoracoscopy, bronchoscopy, EBUS, or a CT guided biopsy?
Initially, as the CT is showing a lung lesion in the left lower lobe, probably initial CT guided biopsy would be better in this case. Further.
You want a CT guided biopsy from the left lower lobe nodule. Why not a medical thoracoscopy? Because you got an effusion, you got already a low ADA value. So why not?
As it is showing multiloculated pleural based lesion, a medical thoracoscopy would not be sufficient in this case for all the loculations to be drained completely.
Okay. So you wanted to go for a
initial would be a CT guided biopsy would be better for that.
And is there any role of not going to all these invasive measures? Why not we just send for a cell block? And is this something which you routinely do in a patient?
Cell block we usually do routinely, sir. But this is already she underwent a diagnostic tapping outside.
Yeah.
So resending a sample would be better, but biopsy would be much more confirmative if it turns to be malignant.
Okay. And I'd like to hear from Dr. Bhulakshmi ma'am, in case, because cell block is something which we routinely send for any of our patient who presents with a massive effusion. So what is the minimum quantity of fluid that you would require for you to comment whether it is a good quality material for a cell block, and what would be the turnaround time for the results for a pleural fluid cell block?
Minimum would be around, I can say, if it is very exudative and we can see a coagulum, even 1 or 2 ml will be sufficient, because that is having a coagulum and I can convert that into a cell block. But if the cell count is very less, we have to cytospin the fluid and then prepare a pellet. So it entirely depends upon how thick the pellet is coming, so that I can embed it into the tissue.
So in general, if
If around 10 ml would be sufficient for us, but as such we have not looked at the cutoff, but I think 5 to 10 ml should be sufficient for us to get a proper cell pellet.
Okay.
And then once the this thing fluid comes to the lab and we are preparing the pellet, the overnight the pellet is kept for preparation of cell block. So that is for preparation of cell block, and next day it goes for tissue processing. So the third day is around what we can get these slides to look at.
So what generally happens in most of the centers is, let's say that we are tapping 500 ml, we send the entire fluid to you for processing. So do you process the entire 500 ml to create a cell block, or you take only a portion of it to make a cell block out of
When
it?
such large volume of fluids are coming, if they're coming in a single container, then I look at the coagulum, and that coagulum is then smeared, and we do cytocentrifuge smears. So we look at the coagulum also, and we look at the fluid which is cytospin. Whichever is showing the representative cells, that tissue or that sample is processed for cell block. If the coagulum is coming to maybe say around more than 5 centimeter in size, then we keep some of it in a fixative and process the rest of the thing for the cell block preparation, and look at all the sections which we are preparing from that cell block. On an average, we make sure that we are making around 2 to 5 blocks, and if the entire 5 blocks are negative, then we go back to the remaining of the cell block pellet which is remaining and process that.
Yeah.
Make sure that the entire pellet is negative and then call it as negative. So this process will take little longer time, but otherwise the first provisional report can be communicated as this many blocks are negative.
And I would like to hear from Dr. Harish, like how confident are you, is merely a cell block is sufficient for you to go for advanced testings like molecular testing as well as an NGS, or you also wanted a tissue before you go for further evaluation?
Definitely larger tissue will be more helpful because inadequate tissue will always help in outputting and more markers if you separate you could do the single gene assays. If in NGS we can get away with a small tissue, and cell block more of helps in maximum up to EGFR based assays only, and rest all and IHC based. If I want to test for more markers, and probably I have to end up in taking more tissue.
So the point for the audience here is, like, tissue always plays a very important role in diagnosis of cancer, but in circumstances where you don't have a facility for an invasive testing, then that is where probably cell block can be an alternative. But let's go through the case to understand further. So they have done a bronchoscopy. There they have found irregular mucosa in the left main bronchus. In the same setting, they have also stationed the lymph node. And this is what the image that was seen in the lymph node. And now I would like Bhulakshmi ma'am to comment like what she is really seeing in those images.
I can see some cluster of atypical cells. So definitely looks malignant to me at this image.
Yeah.
So I would proceed with doing a cell block and immunocytochemistry or IHC.
So how confident, again the same question comes, ma'am, because many a times we do EBUS and we get more of a sample which is similar to that of an FNAC. So is it possible, and certain, we also send it for clot core, like we send the core blocks also for analysis. Is it sufficient enough to process for other testing like NGS as well as other molecular testing, or in most of the cases will the sample be insufficient and you want them to subject it for a further tissue processing?
Yeah, like as Dr. Harish has already said, doing a single marker or single molecular testing, cell block can be used. But if you want to do so many markers on an NGS platform, definitely we need to have multiple representative clusters in the cell block to do it. And other problem with the cell block would be that we are using an external medium for preparation, so even that hampers the extraction of the DNA as well as RNA, which can be again a challenging effect. So it would be better like if we take directly from the lesion and send it for molecular studies. So usually in the routine practice, the cell block is not preferred to send for molecular testings unless we don't have a choice.
Yeah. So just to overcome these inadequacies in the EBUS, now we have something, we do something called as an endobronchial ultrasound intranodal cryobiopsy. So instead of passing a needle, we pass a cryo probe, and through that we get a big chunks of tissue which can be sent for analysis. So another thing what all the audience should, who are doing these sort of endobronchial ultrasound should remember is, your role as a pulmonologist doesn't end with just taking the sample for cytopathology smears. You need to take adequate core tissues, and these core tissues should also be sent for the pathologist, because once a diagnosis of malignancy is made, unlike previous era, now we need to know what genetic markers are there in these patients and what tumor markers are also positive in these patients. So then the EBUS cell block was done, and that was suggestive of an adenocarcinoma, and followed by that, then they had ordered for a PET-CT evaluation. I would like to hear from Dr. Harish, like, what is the stage of the stage in this stage of malignancy in this patient, and is PET-CT always indicated in staging of a lung cancer, or are there certain conditions where you can avoid a PET and maybe just the mere presentation, like in this case, a presence of a pleural fluid should be sufficient enough for you to call it as an advanced disease?
No, pleural cytology itself makes a stage 4 disease as such, and PET-CT I usually order for the most of the patient to scan for abdomen as adrenals, liver metastasis and bone metastasis. And rest all symptom directed, I'll look for MRI if at all needed based on the symptoms of the patient. And PET-CT in one go, it being a hybrid image, it will give the number of sites of metastasis, any extrathoracic metastasis, because it all influence the prognosis, number of extrathoracic metastasis and burden of the disease, and they all help in planning the treatment. And sometimes it helps in taking the biopsy more non-invasive way. I can get away with a bronchoscopy, I can get away with any thoracoscopy. If I'm having any node in the neck, clinically palpable, or if something in the large lesion in the liver, so I can get away with ultrasound biopsy, minimum invasive way, good amount of tissue, of course.
So the point for the audience here is, PET is not only involved in staging of lung cancer. The role of the PET extends beyond that. First, you can even order a PET to choose a site from where you need to take a biopsy from. For example, many a times we have seen that patient is having a huge lung mass, you take a biopsy and it comes out to be just a necrosis. Probably you are not hitting into the active tumor site, and probably you are hitting into the necrotic site. So in such cases, your PET can clearly say that what is the site you need to biopsy. And it can also help in, as Dr. Harish had already said, like it can help us in prognosticating the patient. For example, a patient who is going to have a lot of metastatic sites, then probably it helps in prognosis as well. And finally, yes, it does have a role in the staging. So in this case, the patient was having an adenocarcinoma with metastasis to the pleura with the involvement of the station 7 mediastinal lymph node. Now I'd like to hear from Dr. Harish, what would you recommend next? Is a mere PET sufficient enough for you to stage this patient, or you would still go for an MRI brain? And what is the role of the molecular test? And do you want to do a talc pleurodesis at this stage? And is there a role for a chemotherapy? Like, how do you plan further this patient?
So MRI brain, as of now, I'm doing only on the symptoms based clinically directed way. And current guidelines recommend to do an MRI brain upfront also in the era of targeted therapy to see whether any brain metastases are there, and to assess for the intercanal response with the targeted therapy available. So I will change my practice from now onwards to do order MRI brain whenever considering adenocarcinoma and using targeted therapy. And or else simple CCT head also will give also some idea about number of meds if they are large enough. And molecular test, I would like to do NGS reflexline upfront these days. And if the patient is sick enough, I'll do both together, like single gene assays like for EGFR, as well as I'll send another core biopsy for NGS simultaneously. So the turnaround time for EJAF will be around like less than 7 days. So if I can all get the reports early rather than waiting for 3 weeks. Sometime based on the patient profile, I'll order NGS first. If patient is sick enough, I'll order EGFR along with. And talc fluorosis, definitely yes, if patient is having gross effusion and requiring multiple taps. Palliative chemotherapy, even before waiting for the results, sometimes I do start in those patients have maximum burden of the disease and causing crisis like situation like recurrent effusions, and we don't have any tissue as of now, or taking NGS result to take more than 3 weeks time.
Yeah. And Dr. Srikanth, like, let's say that you have this patient who has got an effusion along with, we have proven it to be malignancy. Would you be enthusiastic enough to go for a upfront pleurodesis in this patient, or would you like to see for response for therapy with medication, and in case if that fails, you would go for a pleurodesis?
Initially, tapping and pleurodesis would be better for better outcomes for chemotherapy.
I'd like to hear from Dr. Harish. Is it so like once you drain the fluid, your chemotherapy acts much better? Or if in, let's say in this case the patient doesn't seem to be disablated by the symptoms related to the pleural effusion. So would you like to wait to see for response with the medication, or you feel like tapping it would make your chemotherapy drugs to act much better? Is there any evidence for it?
No, nothing like that, sir. If you have anything, patient symptoms basically, patient is symptomatic, his performance is going down because of the SOB, then definitely TAP will help. Or else patient is have maintenance saturation, not hypoxemic, and you can definitely wait for your chemotherapy or targeted to act upon.
Yeah. Okay. So in this patient, the MRI brain was done, and MRI was suggestive of heterogeneously T2 hyperintense lesion with a perilesional edema and the post-contrast enhancement. So the point of putting up this is like your PET is not a very good marker to identify the brain mets, because you have a lot of physiological activity happening in the brain and your PET may miss the brain mets. And the current guidelines, as Dr. Harish has already informed, like clearly states that if you have an adenocarcinoma, then it is better to do MRI brain to identify the presence of the brain mets, because you can treat the brain mets separately in addition to what you are treating for, be it your molecular marker or the chemotherapy you are giving for your other metastasis. So isolated brain lesions can be treated with the help of advanced radiation procedures like an SBRT, which we generally do it at our centers as well. So now moving on to Dr. Harish, what's the M stage of the lung cancer in this case? It's a stage M1A or stage M1A pleural disease, or M1B or M1C? And does it really make a difference in staging the M? Because the current guidelines also gives divisions for the metastatic stagings as well. Does it really make a difference in your clinical practice with the new revisions in the guidelines?
Definitely yes, sir. Simple M1A pleural disease, and basically thoracic and extrathoracic mets and number of extrathoracic mets. If the number of extrathoracic mets are more than 2 or equal, the prognosis will be definitely lesser than compared to someone having only pleural effusion, or only single SOL in the liver, or only single bone metastasis, or someone having brain metastasis. So visceral mets and the number of visceral mets, number of extrathoracic mets, they always have impact on prognosis.
Okay, so this is a very important thing, because here comes the potential role of your PET as well, because you try to pick up, and the current staging would become incomplete if you don't order a PET, because you will not be able to find out whether your patient is having a purely an intrathoracic lesion metastasis, or it is an extrathoracic, or if it is solitary or multiple, because that is also going to determine the prognosis of your patient. So I would like to, since we don't have a radiation oncologist in this space here, now I'll go to Dr. Harish again. Like, what is the role of an radiotherapy in this patient? You have a patient who has got a pleural lesions, he has got a station 7 lymph node adenocarcinoma with an isolated brain mets. How do you position the radiotherapy in this patient?
So with my knowledge, I can tell if the patient comes out to be EGFR positive. Then I'd like to start off with the osimertinib, so I can avoid the radiation if patient is asymptomatic altogether with a single brain metastasis with size of 1.3 centimeter. So we have drugs which have good intracranial activity and good intracranial response. So it's asymptomatic and single lesion not causing any symptoms, we can start away with the oral targeted therapy which have CNS activity without addition of radiation. And
So-
someone having symptoms, someone having more 3 lesions and above, and clinical presentation, then definitely SRS is preferred over WBRT.
And would it be always a decision that is made exclusively by you, or or such cases are routinely put to the tumor board along with your colleagues? You make this decision for the patient.
All
your-
of the cases are just definitely have to go through the multidisciplinary team management, because sometimes the radiation role can be only be decided based number of number of metastases in the brain, and any other metastasis which also needs radiation, like palliative radiation to the bone as well. So someone having excruciating pain or compressive myelopathy. So all the cases with having painful bone mets as well as brain mets, which are based on the number of the brain mets as well as symptoms of the patient and the type of technique to be used. So all we can take the cases to the MDT to discuss the plan of the management.
So the point for the audience here is the management of lung cancer is never a domain of a single specialty. It is always a team effort, and it is always the decision of the tumor board that remains final. Because unlike most of the it must be true for all tumors as well, but especially for the lung cancer, the evolving evidence that keeps coming on day-to-day basis, it's very hard to catch up for a single specialty to decide what could be the course of the treatment. So whenever you have a patient with a lung cancer, ideally they should be put through a tumor board, which should comprise of a medical oncologist, the pulmonologist, the radiation oncologist, and the surgical oncologist, and finally the entire decisions are taken in the best interest of the patient. So in this case, the patient's tissue was sent for molecular analysis, and EGFR 19 deletion mutations come positive, and PDL1 is negative, ALK is not there, and ROS is not there. I would like to hear from Dr. Srikanth, like whenever you do a tissue, without consultation with your oncologist, do you send all these samples for testing, or you speak to the oncologist or the referring oncologist to understand that what are the investigations that to be ordered, and how are you going to triage your samples of biopsy?
So initially, after the diagnosis is confirmed whether it is malignant or not. After the diagnosis, if it is malignant, we'll discuss with our oncologist and send samples accordingly, whether it is IHC or any other special tests to be needed.
And Dr. Harish, have you faced with such scenarios where a patient comes from a periphery, he gets a biopsy done, you just have a diagnosis of non-small cell carcinoma, and the patient does not have the tissue block with you? So how would you proceed in such a case? Like where the patient already had a biopsy, he has evidence of malignancy, but you don't have the tissue for subjecting them for further analysis. So would you go for a rebiopsy of such lesions, or would you like to start these patients on routine chemotherapy in the current era?
Definitely, I would go for a rebiopsy whenever possible, and there are no biopsiable lesions, very rare occasions. Then I'll like to go for the upfront chemotherapy based on the available report. But 99% of the cases, I would like to go the rebiopsy, because that's going to change the entire treatment plan actually.
Yeah, and in this case, you got a EGFR positive. What would be your next line of management?
For this case especially, I'll go with the oral targeted therapy with osimertinib.
So you choose osimertinib because you got a brain mets in this patient?
Yeah.
Or is it an upfront therapy, or you want to put osimertinib for all patients with EGFR positive?
As of today, I would like to go with the osimertinib for all my patients. If patient is availability issue, I'll go with the first line DK, like erlotinib and gefitinib, irrespective of the brain metastasis.
Yeah. Thank you. In the interest of time, we will close the case-based panel discussion here. And I would like to thank my panelists, Dr. Bhulakshmi ma'am, Dr. Harish, and Dr. Srikanth Peddi. And now I'd like to hand over the mic to Dr. Nikhil to take over the proceedings.
Thank you, sir. Thank you, ma'am. That is the end of our first session. Now we will be having an inauguration ceremony. I request Dr. Pavan sir to join us on the dais for the inauguration. Dr. Vishnu Reddy sir please join us on the dais. Dr. Karthivelan sir and Dr. Nikhil sir, Dr. Sachin Mata sir, please join us onto the dais for the inauguration. Sorry. I request Nalini ma'am and Dr. Kiran sir to join us on dais for the inauguration ceremony. I thought this will finish. Yes, sir. One sec. Pause. Yes. I request everybody to stand in respect to the prayer song. Sir, I request Dr. PNS sir to join us on the dais. Dr. Balasubramaniam sir, please join us on the dais. Dr. Bharat sir, please join us on the dais. Thank you, sir. I request Dr. Pavan sir to address the gathering today.
Thank you all, and welcome all the delegates. On Saturday also, you're taking efforts. Indian doctors, I think, are the hardest working people in the world. In US, nicely, we used to have 1 week on, 1 week off, or at the very least, weekend was off compulsory. But even on a Saturday, you're coming here. But I'm sure you'll go home much more enriched because I think Dr. Nikhil and all our team here in Somajuda has put in a wonderful effort to get the all-star crew here. So, like everything about lung cancer, just like pulmonology, I think nowadays lung cancer is increasing and awareness about lung cancer is increasing too. And, you know, on this occasion of World Cancer Day, I think it's just a moment to reflect on like previously, I think like 50 years ago or so in India, cancer was just like a rarer diagnosis. The common ones were fever like malaria, typhoid, TB and all of these things. I think younger people must have forgotten what malaria looks like. I don't know when was the last time you have seen malaria, typhoid and these kind of things. But unfortunately, I think as people are living longer, other things are taking their place. Cancer is, I mean, yes, because people are living longer, cancer is a disease predominantly of old age, but also incidence of cancer also probably may be increasing because of our lifestyle, like food, not like on one side, like pesticides and all these kind of things, and everything is genetically modified now. Even if it's not like a real genetically modified, I think all these things, like tomatoes at one time apparently were green in color. Now we cannot imagine color, tomatoes green in color, and all the fruits and everything is tasting good like mangoes, bananas and all. But unfortunately, there is a price we pay for all these things, and obesity itself, I think maybe you have a session on this too, Nikhil. I think because I think we are eating calorie intake is more, fiber intake is less. Like cancer incidence probably is increasing because of the like energy excess also, I think. You know, in addition to whatever the latest advances in science, like commonly done therapy for cancer, at least in Russia. First time I realized in New York was there was a patient who came to the ICU because somebody diagnosed Hodgkin's lymphoma, and he was on a 0-calorie diet for 40 days, like absolutely no food and all. Only water, because the theory being just cancer cells are metabolically active. So I think if we decrease the energy intake, maybe it works for some kind of cancers like Burkitt's lymphoma and this, maybe Hodgkin's lymphoma too. But I think 40 days after that, I think wife got a little concerned and gave some carrot juice, and he ended up in the ICU with all the refeeding syndrome and nystagmus and everything though. So that was the first time I realized like people practice fasting for this cancer. And in literature, I think you can see like if you wanted to decrease incidence in other things, maybe 5 or 10 day fasting every quarter or so, which decreases a little. If you're genetically predisposed to cancers also, it may decrease. But that is the extreme of these things. Like, but nowadays, lots of advances are there in the diagnosis and treatment also. Like cancer is not a death sentence anymore. Like previously, if somebody was diagnosed in cancer when I was in MBBS, it was almost like patient was dying only. Just the diagnosis of cancer was enough for their psychological thing. Anyhow, like even if CHF, advanced CHF prognosis was 6 months, patient was okay. But cancer diagnosis, from the day itself, they were down and everything. I think I remember Sachin has organized a great event about 1 year ago, Sachin, or slightly more, 1 year ago. Yes, that was a wonderful session. I think your book is still available on Amazon. Okay, great. I think people, I believe, right? Sorry. I'm really sorry. I am unstoppable. I recommend people, you know, medical, non-medical and all. It's a great, wonderfully written book by multiple people, and like it gives confidence to the patient right from the diagnosis. It's a multi-step up, not only the medical treatment, but spiritual, psychological support, and all these things are important for optimal prognosis. And I think people can order on Amazon or request Sachin for a copy, autographed copy. It's a nice book, was written about a year ago. I think advances in lung cancer, like a good thing is one or two cancers like small cell cancer, I think we rarely see anymore. I think that cancer is decreasing, but unfortunately, a lot of other cancers are there in its place, like adeno cancer and all this is increasing. But treatments have also advanced quite a bit. A lot of first of all, early diagnosis, as you all know, is a key. So late stage diagnosis, not much can be done. I mean, there are treatments there also, and palliative care is advanced, but early diagnosis, a lot of stress on there. And India too, I think protocols will come standardized, like smoking 20-pack year and all. US, everybody gets a automatic CT scan, 55 years, and then follow-up and all. But these things probably will pick up here too. I think we have to be aware, any risk patients, we have to diagnose as early as possible, and then a lot of treatments. Bhulakshmi ma'am and all is was talking about previously, like a lot of molecular advances is there. Immunotherapy, I think, may become even more popular. Now maybe it is used only for with adjuvant with chemo, or maybe after failing chemo, but maybe in the future, I think it will be standard for all cancers. Immunotherapy is there, and other things, surgical too, lot of advances is there. Dr. Balasubramanian here is an expert robotic thoracic surgeon, and also like a real minimally invasive surgeries. Now no need to open the chest anymore, because these sick patients, it's very tough to open the chest. If you open the chest, like vital capacity drops 1/3, and you know the prognosis of patients. These people are old and sick, and also I think we have really minimally invasive surgeries. We do have advances in intervention radiology, resections, transplant, and everything. But the important thing is to have a multidisciplinary approach. We cannot do everything in silos. So combination of medical, surgical, radiation oncology, pathology, psychiatric support, and maybe other fields to general medicine and all, because patients may go anywhere. So first time with maybe blood in the hemoptysis and all, they may end up with ENT or somewhere here. So everybody should be a little aware about lung cancer. Lung cancer incidence is increasing, but we have a lot of treatment options with that too. And survival of many people with lung cancer, it's not unknown to have survival of 20-year plus. Previously it was unimaginable, but maybe by that time improvement in technology, maybe it may not even affect lifespan if detected early and in a good prognosis kind. So anyhow, I'll not take too much of your time. Forgetting my pulmonary, my background is pulmonary, so I think lung cancer is, I'm supposed to know all these stages and all, but now I forgot what is stage 1 and stage 4. Not required for me. So whatever I say, I think being a boss, I can say this is stage 3 and people may accept also. So I don't think I need to know the stages and all, but for all of you other younger people, because a lot of, there are so many medical graduates graduating every year, unless you're recognized, unless you do good things and do something different, it is a little tough competitive field. As a hospital-wise too, we are constantly upgrading, like in Somajud also, we are having a state-of-art chemo rooms shortly there, and each of our other hospitals also renovating. One is there in high-tech also. Similarly, doctors have to know about everything. Not only that, organizing conferences, attending conferences, networking. In addition to all these other things, probably you need to be active on social media and all also, just to, nowadays, how to get patients is also a complicated art. So all these people in the front row are popular because they put in a lot of efforts. From outside, it may look easy, but every aspect, from diagnosing, talking to patients, breaking news of cancer to a patient in India is completely different from US and all. US, you absolutely directly have to speak to patient, and only with their permission, maybe if they allow to their family, but here it may need to be modified. But all these things, feel free to any kind of questions, or people are there to more than willing to answer. So no need to take any experiments, and also all of our people is here. Please have a pleasant interaction and patient here, and I'm sure you'll go much more enriched after this conference. Thank you all.
Thank you, sir. Those are some insightful words coming from our director, Yashoda Hospital, Dr. Pavan, sir. Just a second, sorry. Before moving on to the second session of the day, I request Dr. P.N.S. Reddy, sir, to join on to the dais to present the mementos to our speakers and panelists of the first session. I would like to invite Dr. Bhulakshmi ma'am onto the dais. Dr. Kalyan Ram, sir, please join us on the dais, please. Dr. Harish, sir, please join us on the dais. Dr. Shrikant Peddi, sir, please join us on the dais. Thank you, sir. Now I request Dr. Sachin Marda, sir, Senior Consultant Surgical Oncology, Yashoda Hospitals, to join us on the dais to present a memento for Dr. P.N.S. Reddy, sir. Thank you, sir. Thank you, sir. Now we move on to our second session. To start the second session, I invite Dr. Narasimhan Satyamurthy, Head of Services Thoracic Surgery, Institute of Robotic and Thoracic Surgery in Malaysia, for a discussion on uniportal video-assisted thoracic surgery for non-small cell lung cancer and the surgeon's role in N2 disease. Please join us on the dais. Thank you, sir. We are waiting for our speaker to come.
Very good morning, and thank you to the organizing committee and Dr. Bala for inviting me over to discuss on uniportal VATS for non-small cell lung cancer and N2 disease, surgeon's role. My name is Nara. I'm from Kuala Lumpur, consultant thoracic surgeon, and also heading the National Thoracic Services in Kuala Lumpur. Well, as my topic goes, what is uniportal VATS for non-small cell lung cancer? Basically, uniportal VATS is surgery performed to remove the lung from a single incision of about 4 to 5 centimeters in the intercostal space, and the whole procedure is performed through that hole with the instruments that is dedicated for uniportal VATS. It is nothing new. It's been going on for about 20 over years now. It's started since 2000, and we've got a lot of studies that's been performed on the feasibility of performing lung cancer surgery with uniportal VATS. And with the recent publication of the Violet study, which shows that VATS is a gold standard of approach for early lung cancer. But it did not mention on uniportal VATS because it's reasonably new as compared to VATS. So if you look at some papers published by Yao and colleagues comparing uniportal versus multiportal thoracoscopic lobectomy, the conclusion is that it is safe and feasible. And similar to this study, there are many other studies that have been trying to compare surgical effectiveness of uniportal VATS lobectomy compared to open surgery in early stage lung cancer, and they've also concluded that it is feasible. And the most recent study in 23rd October 22, Liu and colleagues have even looked into the role of uniportal VATS lobectomy versus thoracotomy lobectomy for non-small cell lung cancer larger than 5 centimeters. And it's a propensity score match study, is not randomized trial, and he has found that it is UVATS lobectomy is feasible and effective for curative lobectomy for non-small cell larger than 5 cm in selected patients. Further validation, well-designed propensity studies required for UVATS lobectomy, so on and so on. So we are not questioning the role of uniportal VATS lobectomy in treatment of non-small cell lung cancer here. We are just waiting for a good randomized trial to be performed and to establish the fact that it indeed has got a very important role in treatment of lung cancers. As what mentioned by our Dr. Pawan earlier, minimally invasive surgery is taking the management of lung cancer to a different paradigm, especially when you're dealing with elderly patients who can't undertake thoracotomy, leading to a lot of physiological changes and poorer outcome. So what I'm trying to convince the public, the audience here is that what about in N2 disease? What we know so far, we know N2 is a widely heterogeneous group. You have occult N2, single N2, skip N2, bulky N2, multi-station N2. So you can see the spectrum of disease when you talk about N2 disease in lung cancer. And there is a definite role of surgery in N2 disease. And there are many randomized trials being performed, and they have failed to demonstrate superiority of one bimodality strategy over another. For instance, chemotherapy plus surgery versus chemotherapy plus radiotherapy. There's no superior method that has been established. So when we say N2, what we are talking about is that this group of patients that is in the red square, it's 3A and 3B, stage 3A and 3B. In terms of the interest of surgical intervention, we are talking about specifically the group stage 3A only. We are not looking at 3B. So these are the trials that have been going on since 15 years ago, trying to establish, do you need to do surgery first, or you need to give chemotherapy plus surgery, or chemotherapy plus radiotherapy, chemotherapy, surgery plus radiotherapy. And none of these studies have proven that one method is superior to another. So it's either or. You can go for the surgery, chemotherapy, or chemotherapy, surgery, radiotherapy, or chemotherapy and radiotherapy alone when the patient is coming with stage 3A and 2 disease. So because of this situation, Bofa and colleagues have come up with this paper now or later evaluating the importance of chemotherapy timing in resectable stage 3 and 2 lung cancer in the National Cancer Database. And he divided the group into pre-operative therapy, either chemoradiotherapy, or surgery as first treatment, and then look at the outcome of these two groups of patients. And when in his study, he concluded that a superior approach relating to chemotherapy timing was not identified in these two groups. And further study in this area is warranted because flexibility in chemotherapy timing could be advantageous in highly selected subsets of patients with stage 3 and 2 non-small cell lung cancer. So with this in mind, why not we perform surgery first in patients with N2 disease? The patient will come fitter to surgery, and it's after a reduced time from diagnosis to treatment. And the patient will avoid uncomforting hazards of invasive staging procedures and shorten anxiety retrieve from never-ending pre-treatment workup. And this pragmatic approach will at the same time shorten healthcare expenditures. I'll come to that later when I discuss on what we actually do in Kuala Lumpur. So Zhang and colleagues have published this paper on upfront surgery as first-line therapy in selected patients with stage 3A lung cancers, and they looked at a total of 668 patients. And when they looked at the progression-free survival and overall survival, the 3-year and 5-year survival respectively were 54.7% and 43% for this group of patients, which is very comparable with the conventional treatment that we perform. So the central message that he put forward from his study was that upfront surgery could provide favorable survival outcomes for selected patients with 3A non-small cell lung cancer, especially for patients with adenocarcinoma or patients with clinically N0 and single-station pathological N2 disease. And Rocco is one of the well-known thoracic surgeons from Naples, Italy. He has published extensively on lung cancer, and he reviewed the paper on Zhang. And what he has recommended is that it is time to reconsider the role of upfront surgery in the multimodality treatment of locally advanced non-small cell lung cancer. And this has been currently investigated further, and Brescia and colleagues in the recent publication in July 2020 titled Resectable 3A and 2 Non-Small Cell Lung Cancer in Search for the Proper Treatment. So, and what they have concluded is that surgery should be recommended to patients with non-bulky, discrete or single-level N2 involvement, and it should be included in the multimodality treatment. So in the resectable stage 3A patients have been the subject of a number of clinical trials, retrospective analysis, and discussing the efficacy, survival benefits, and so on, which it should lead to the awareness that each patient should undergo a tailored therapy in light of the nature of this tumor and its extension and his performance status. This only shows that all patients with lung cancer treatment, especially if they are stage 3A, must be put forth into multidisciplinary team discussion or a tumor board meeting before a decision of treatment is made. And if the patient has got a single station N2, clinical performance, the patient is fit and can go for surgery, upfront surgery should be considered seriously. ESMO guideline, this is 2017, and it shows that surgical multimodality treatment, and the middle box at the lowermost there, it is one of the armamentarium in the treatment of lung cancer in stage 3A and 2 disease. And they have recommended that if single station N2 disease can be demonstrated by preoperative pathological nodal analysis, resection followed by adjuvant chemo, induction chemo followed by surgery, or induction chemoradiotherapy followed by surgery are the options available. So this discussion has been going on for many years, and there's no clear conclusion on which arm to be chosen as the treatment of choice. And this has to be decided in a multidisciplinary meeting. So how to consider upfront surgery? Patient has to be fit, ECOG 0 to 1, single station non-bulky N2, and if you look at IASLC staging data sets, demonstrate a similar survival between patients with multi-station N1 disease and those with single station N2 disease. So with this outcome in IASLC data sets, if you have a multi-station N1 with a similar outcome as single station N2, why not do surgery for a single station N2 3A patient? If you perform multi-station N1 patient, you go for surgery first. Outcome is similar to single station N2. Get the patient for surgery and avoid pre-resectional mediastinal dissection. This was completed by Lim et al., who is responsible for the Violet study, because you need to perform complete intraoperative mediastinal node dissection in upfront N2 surgery. So what do you mean by complete mediastinal lymph node dissection? It must produce at least 16 lymph nodes in the pathological results. That means the surgeon must be well trained to perform the mediastinal lymph node dissection, which I will share the video later if time permits us, how to achieve this target, and that is how you go ahead and perform upfront surgery for 3A and 2 disease. So in my center in HKL Malaysia, to date we have performed about 55 surgeries for stage 3A and 2, single station, and it's about 5 years duration from 2017 to 2020. The single station N2 is diagnosed purely by PET scan. We do not do pre-op mediastinal dissection. We perform complete lymphadenectomy when you bring the patient for surgery. The mean node that we could get is about 20. The lymph node ratio is high, higher than the international standard set. All true N2 receive adjuvant chemotherapy, and the rate of the true N2 is about 27%. So if you look at the table, the N0 is about 30, N1 is 10, N2 is 15, all single station N2. And out of the N0, the 30 of them, 8 were actually chronic granulomatous disease. And these patients, if you do not perform the surgery and you just perform EBUS FNA, it may not be adequate, the yield will be questioned, and eventually in the MDT, the patient will go for a chemotherapy first, because you suspect that the N2 station 7 or station 4 is a tumor metastasis but not chronic granulomatous disease. So what we have seen in our pattern in Malaysia, which I think is pretty similar to what we see in India, is that if you see a single station N2, you go for a surgery and then complete lymph node dissection to stage the patient accurately, and then treat with adjuvant chemotherapy. The outcome is still similar as compared to if you go for chemotherapy and then surgery. So yeah, again, this is to emphasize the high incidence of infective mediastinal nodes, and we do not waste time performing mediastinal staging. I'll explain in a bit further. The reason why we have to resort to this method, I was trained in a traditional method where N2 means must go for chemo first and then you decide chemo, radio, or go for surgery. So, but then in my setup, we have no OT time. I'm working in a public hospital. We only have 2 operating days a week. And it was a single thoracic surgeon center till 2021. Then I've trained 2 other thoracic surgeons and they now helping me out. So it is very difficult to balance up the time. And the time for surgery from clinic to theater was set or is set within 3 weeks. This is our key performance index, whereby any malignancies seen in the clinic must be brought to theater within 3 weeks. So that is the time frame that I try to keep up. And our oncology clinic is congested and with limited resources. The patient will get the appointment to see the oncologist within a month after the date is requested. So you see, I don't work with CT scans more than a month. And you see the oncologist after a month, I call them up, and the time they plan for a chemotherapy will be another 2 weeks to a month. You think the disease will just keep quiet and say, no, their resources is limited. I cannot progress. Let's wait for the oncologist to see me first, then I progress the next step. The disease do not wait. It will continue progressing, and by the time the oncologist see, it will not be 3A anymore, it will be 3B or 3C. So that's one of the reasons. And patients travel far away for treatment to my center, up to 300 kilometers, and they are from poor social background. The rich ones, they go to private, they get everything sorted fast. Within a week, they are planned for surgery and carry on with life. But the poor patients, they have no options. They have to end up to a public service. And when that happens, we need to give them the viable option according to the logistic background and what we can offer with our limited resources. So what I did, I need some reassurance for what we are doing in HKL is true. So I visited Shanghai Primary Hospital because they perform the largest number of thoracic lung resections per day. When I visited them for 2 weeks, per day, the lung resections that they perform about 80 lung resections in 1 day. They have about 30 over-thoracic surgeons working in the dedicated thoracic center. And in the 2 weeks, I've witnessed more cases than I perform in my center for a year. So that's how extensive they are. And when I attend their MDT, which is held every morning before the case is started, this is the typical case that we see. A gentleman presenting with lung lesion, biopsy was done, adenocarcinoma, PET CT shows 4R lymph node metastasis, or it could show station 7 metastasis. They bring the patient straight for surgery, because they just say that number is too many. You can't afford to offer 60 patients per month, neoadjuvant chemotherapy, and then go for surgery later. It's just too big, the number. You cannot afford that. So they go for surgery. And they have their studies, that all the studies that I shared earlier, that shows most of these lymph nodes that deemed N2 disease are actually infective in nature and not metastasis. So this is what I gathered, and I got reassured with what I'm doing in HKL, and I'm still doing it at the moment. So conclusion is, upfront surgery in baseline resectable disease followed by adjuvant therapy offers equal result, but appears to be simpler for the patient, time-saving and cost-effective. I'm not denying that randomized control trial is needed, but in situations where, like in Kuala Lumpur, I need to do this to carry on my service to make sure the patient survives longer. It is a practical approach in resource and limited centers, and many centers in the world have some form of limitations. And case selection is very important. It has to be single N2 station, non-bulky N2 disease. So I've finished my talk, and if time allows, I have another 2 minutes, is it? So I'll share how I do N2 lymphadenectomy. I'm not going to share how I perform uniportal lobectomy because it's available everywhere. But when you do N2 resection for lung cancer, this is R2, R4, the right side dissection of the lymph nodes, paratracheal. You need to achieve anatomical landmarks before we say that we have done an adequate lymph node dissection. So when you look at the N2 disease in the, sorry, how to forward this video? Is there any way I can do it? Okay, never mind. Well, when you look at the R2, R4, you need to achieve the anatomical landmarks by clearing the seeing the right main pulmonary artery inferiorly. Medially, you must see the border of the trachea. And posteriorly, you must also demonstrate the brachiocephalic artery up to the division to the right subclavian artery. Not going there because the recurrent laryngeal nerve will curve around, so it may endanger it. And medial superiorly, you must retract the SVC and clear off all the nodes along there until the ascending aorta arch is seen. So this is the anatomical landmarks that you need to achieve. And if you don't achieve this, that means you may leave some fat around this area, and that can contain lymph nodes that is affected by malignancy. Sometimes there may not be any lymph nodes in that area, but as long as you achieve the anatomical landmarks that you've done your adequate dissection, and then you have nothing to worry. So if the patient has got no lymph nodes, you can't go and look for lymph nodes to say that you must achieve 16 lymph nodes, but you must prove the anatomical landmarks achieved. If I can forward this, will be very good. Let me just check. Because I only have, okay. Okay, so can I just show the screen? Yeah, good. Okay, so here you can see the anatomy, the vagus, trachea, right brachiocephalic trunk is at the lowermost. It's pulsating there, and you just have to work your way above, retracting the SVC medially and proceeding with the dissection. So once it's done, that's how the whole area will look. And this is the R7 dissection. The superior on the rightmost is the zygus, right main bronchus, intermedius bronchus. The right upper lobe is already removed. So now we're going to remove the station 7. And as we go and dissect the station 7, you need to demonstrate the left main bronchus towards the end of the dissection, which I will show you. Okay, just right after this, I'm removing the last bit of the nodes around there. So here, you can see the left main bronchus, the carina, posterior pericardium, and so on. So this is for the left side. All right. Can I have just 2 more minutes? Okay. So this is on the 10L, 4L, and 7. Usually 4L, most of them will be very difficult to reach by vets because of the precarious location around the pulmonary artery, arch of aorta, and esophagus. So this is after a left upper lobectomy is performed, and I'll just demonstrate how the 4L lymph nodes is reached, which can be done quite clean and safely. So from here, you need to achieve the landmark. You have to separate the pericardium and push the esophagus posteriorly. And all this can be done quite safely with good counter traction and using the arch of aorta as a fulcrum to retract the tissues away. And all these nodes along the left main bronchus can be dissected cleanly up to the carina. So once that is your station 7, once that is removed, just follow the left main bronchus up along the trachea, and the left main PA is there. Separate the arch of aorta from the pulmonary artery. And from here, you can access the 4L, which is hidden by the left main pulmonary artery, which you need to retract the pulmonary artery medially and then dissect the 4L lymph node out. And you need to be worried about the recurrent laryngeal nerve, but in this plane, the recurrent laryngeal nerve will be anterior to the entire dissection area, so you don't have to worry. Just stick to the paratracheal space and remove the nodes around there, which is your 4L lymph node. So here's the left main bronchus. The trachea is following upwards, and the lymph node within the left main bronchus and paratracheal junction is where your 4L is. So Well, that's all. That's pretty much. You can see more videos if you are interested to know more on the dissection in my YouTube channel. It's there to see the rest of the procedures that can be performed by uniportal access. Most of my procedures are by uniportal access, and that's the way to go. I feel we just have to wait for a good randomized trial, and most patients will start benefiting from this approach in treatment of lung cancer. Thank you.
Thank you, sir, for such a wonderful presentation. We move on to our next topic. I invite Dr. Balasubramaniam, sir, Senior Consultant Thoracic Surgery, Yashoda Hospital, to discuss on robotic lobectomy in non-small cell lung carcinoma.
No. Morning, everybody. So I'll be presenting on robotic lobectomy for non-small cell lung cancer. So we, as the thoracic surgeons, we have been at the forefront of embracing new technology and also expanding surgical innovations. And as Dr. Nara showed, the adoption of VATS now going on to uniportal VATS represents a paradigm shift that enabled us to go into minimally invasive procedures. So is robotics a new technology? The answer is no, although we feel that it's come into prominence now. Even in the 1990s, there was work going on with robotics between NASA and a company called Computer Motion predominantly for the development of a robotic surgical arm. So that led to the development of the ESOP, which was the first commercially available robotic arm, which you're seeing here on the top, followed by the ZS, with the second picture, and followed by the FDA approval for the first Da Vinci robotic system developed by Intuitive Surgical in 2000. Immediately in 2001, within a year, we have the first successful robotic lobectomy performed way back in 2001, and that's the early experience in 2002 by Franca Melfi et al. In 2002, where they reported 12 cases and done 5 lobectomies. Now, so let's look at the adoption of robotics as far as lobectomy is concerned. Here we see robotic lobectomy is a level 3 operation when compared to the other operations like a thymectomy, which is level 2, or a lymph node removal. So the learning curve here, I shown in this graph here, the learning curve is around 20 lobectomies. Robotic lobectomies are recommended for surgical proficiency, and a mastery is achieved by the time you have done around 60 robotic lobectomies. Around 10 lobectomies are done in the US on the robot. It was in 2016 2016, but when we come to the Society of Thoracic Surgeons General Thoracic Database of 2021, they showed that the rate of robotic lobectomies have gone up from 1% to 15% in 2015, and post introduction of the Da Vinci Xi robot in 2014, which went on to introduce the robotics A+, the rate of robotic lobectomy has increased to 33%. So the number of centers offering robotic lobectomy in the world has also increased by around 90%, with around 400 surgeons performing robotic lobectomies in the US alone. So why robotics, and you already have VATS, you only portal VATS, the robot comes with its own specific advantages. As we going through a few of them, the first one being the 3-arm advantage. A robot, as you can see here, has 4 arms. One is for the endoscopic camera, so it means that the robot actually empowers the surgeon to have a 3rd arm. So we can use the 3rd arm to jam a bleeding while you're operating simultaneously. You can use it for an extra retraction instrument. Superior visualization, 3D visualization, 10x mag, you start seeing more than you can be with your naked eye. Most importantly, endoscopic camera here is under the surgeon's control. Now, unlike in VATS, it makes a more efficient operation. And the superior visualization compensates for the disadvantage of robotics, the lack of a tactile feedback. Enhanced suturing capability, one of the tremendous advantages you have on the robot, and you go on to do complex sections like sleeve lobectomy, where you have instruments having, say, 11 degrees of freedom, 360 degrees of rotation, something like the human wrist. It's called as EndoWrist technology, and that really helps you to suture, perform complex procedures like a sleeve. Now, a host of patient safety features like locking of instruments in position when the surgeon's head is not in the console, using something called an infrared ray brake technology, locates instruments when they move out of the visual field, intelligent alarms for enhanced patient safety. These are all an improvement on VATS and specific to robotics. Now, going on to a small case where I'd like to demonstrate what happens in the robotic OT. It's a 62-year-old female, instantly detected right lobe mass lesion. Now, the preoperative workup is similar to any lung cancer case, with a CT chest CT FNAC showing adenocarcinoma, a PET CT showing a CT1C N0 M0 EPUS negative for malignancy, and a PFT showing mild restriction. Echoes pretty normal. And as you can see here, we are planning to take off that right lower lobe robotically along with lymph node dissection. So what exactly happens in robotics? First, we go on and make your 8 mm stab incisions to put your port cannulas in. And once your port cannulas are in, you introduce the camera in first. You using camera visualization, you put on additional ports, dock the arms onto these ports, and introduce your long instruments. So all these instruments are pretty long and slender to reach every nook and corner of your pleural cavity. The surgeon moves from the OT table to the operating console, and adds the robotic arms moving according to how the surgeon's hands are moving on the console. So as our OTT setup, where you can see here the surgeon in the corner of the room on the console with the robot docked over the patient. So once your docking is over, we proceed to a robotic lobectomy. You can see 2 instruments, specific robotic instruments, which shows articulating movements, whatever the wrist of the surgeon is doing, the instruments are reflecting that, replicating that. The inferior pulmonary ligament is dissected off. All the lymph node stations you see on the way are cleared because it's lung cancer. That's the station 8 coming out the upper esophageal lymph node. And we do a tissue dissection to enable us to loop that inferior pulmonary vein. And we also go ahead and clear this subcarinal station 7 there. And after clearing the station 7, we have easy access to loop and go around the inferior pulmonary vein. So you can see that was at station 7. And going ahead to loop the vein there. And that's the advantage of the newer XI robot, where you have the robotic staples with the surgeon himself can control. If you are using a manual stapler, the surgeon who is at the bed, he is the one who is going to fire the manual stapler. So XI has introduced robotic staplers which the surgeon himself can control. The artery is handled. All the lymph nodes in the relevant stations are removed, and it really enhances the ease with which you can loop and handle all the vascular structures. Then that's the artery being looped. The artery is being stapled off, and that's followed by fissure completion. And as the lower lobe bronchus is remaining there, you can clearly see the middle lobe bronchus too extending upwards into the middle lobe. The lower lobe bronchus is clamped. The anesthesiologist is asked to inflate the middle lobe and the upper lobe just to be sure your middle lobe bronchus is not caught in your stapler. And that completes the lower lobectomy. So there you can see the middle lobe bronchus very clearly there, and this specimen is bagged and removed. So just to look on a few articles here showing the outcomes of robotic surgery, especially for lung cancer. There's a pretty recent article came out in Surgery in 2021, which is probably the largest meta-analysis we have out there. It included around 1,80,000 patients, with 48% in open, 43 in VATS, and 8.4%, around 16,000 robotic patients. They compared robotic VATS to open, and they showed that the 30-day mortality per pulmonary complications and the overall complications were superior for robotics and VATS when compared to open, and that robotic results were almost equivalent to VATS. Now, the total number of lymph nodes harvested and the lymph node stations dissected were higher on robotics when compared to either VATS or open, probably because of the articulating instruments, which makes lymphadenectomy a bit more easier. Remaining significantly shorter hospital stay, decreased intra blood loss, decreased rates of perioperative blood transfusion, and decreased the 30-day readmission rates when they specifically compared robotic lobectomy to VATS. And they also studied the pain factor, which showed 1 and 2 month intervals. Pain factor significantly less intensity of pain in robotics when compared to VATS. Now, going on to another meta-analysis, which is specific for robotics versus VATS. Then there's around 7,500 patients divided into almost exact 2 groups, where they surprisingly showed that robotic lobectomy is superior with a decreased 30-day mortality of 0.7 to 1.1% in VATS, and a decreased conversion of rate to open surgery from 10.3 to 11.9. So robotics is found to be equivalent as far as postoperative complications, operative time, duration of hospitalization, and the days to tube removal. Now, what about the pulmonary recovery when you compare robotics to open? This particular article in 2021 by Lacroix et al., they compared the PFT evaluated immediately after surgery, 1, 2, and 6 months later. Immediate post-op both showed a drop, but the robotic patients, they showed a significant normalization within a month. It took the open patients around 2 to 6 months to come back to their previous level or come back to the robotic level. So it clearly demonstrates a faster return to recovery for robotics. They studied obese patients who had lung cancer, and they showed that robotics had fewer complications in obese patients with a shorter length of stay. Now, oncology results, there's a multi-institutional retrospective review of 325 patients who underwent robotic lobectomy at 3 institutions, all for early lung cancer, and they showed overall and stage-specific and disease-free survival similar to VATS and open modalities. But the ability to perform more complex cases were observed to be more in robotics than in VATS. And although the total costs are higher when compared to VATS, the costs were found to come down with increasing volumes and experience of the center. So in conclusion, robotics is here to stay. No debate about whether it's safe. It's an oncologically sound operation for lung cancer. The future looks pretty fantastic. It's a single port robot, 2.5 centimeter port, 1 camera, 3 instruments coming out through a single port. No prospective RCTs exist comparing robotic lobectomy versus open or VATS lobectomy, but we do have a lot of multiple peer-reviewed studies and meta-analysis showing equivalence or even superiority for robotic in a few aspects. So robotic platform costs, although presently higher, we expect it to reduce as the volume of cases go up and as more centers go on to accept robotics. Thank you.
Thank you, sir. Now, we move on to our second case-based panel discussion. I invite Dr. Sachin Madhav, sir, Senior Consultant Surgical Oncology, Yashoda Hospital, to moderate the session. I request our panelists to join us on the dais. Dr. Bala Subramaniam, sir, Senior Consultant Thoracic Surgery, Dr. Purushottam K, Consultant Surgical Oncologist, Cancer Clinics, Dr. Narsimhan Satyamurthy, sir, to please join us on the dais for the panels as a panelist. Thank you.
Yes. Again, welcome all. we will, after this illustrious beginning and a lot of insightful lectures, let's move ahead with the surgical panel discussion. Myself, Dr. Sachin, I will moderate the session, and I welcome Dr. Balasubramaniam, Dr. Nara, and Dr. Purushottam here. We have, very highly experienced surgical panelists here who will, go through our cases and will interact with them about the cases and the complications, how to go ahead. And I think this is one of the best occasion to celebrate the World Cancer Day, sharing the knowledge and getting insights and newer frontiers in lung cancer discussion. So aptly, we identify differently, but we agree wholeheartedly. So let's move. This is all, we all know that lung cancer is increasing and all other things. Let us move to first case. I'll restrict this for half an hour because of time constraint, and we'll discuss 2 or 3 cases, specifically surgeries and little more about the complications and how to manage the complications. So here's a case, 65-year-old male smoker with chronic cough. Chest CT shows a left lower lobe mass and an ipsilateral enlarged interlobar lymph node measuring around 11 millimeters in short axis. This is the image. We can see left lower lobe lung lesion, and there are few uptake in the mediastinal nodes. So I'll ask Dr. Purushottam how you will go ahead with this case.
First, I would like to do pulmonary function tests and other routine investigations so as to see his fitness for surgery.
Yes.
And my decision would always be to go ahead for biopsy first.
Yes.
And then based on the biopsy report, we'll think about the next thing.
Correct. So what biopsy? It would be a CT guided or EBUS guided?
So this would easily be amenable to CT guided biopsy because in the periphery of the lung.
Correct.
Regarding taking doing EBUS for the mediastinal nodal stations, I feel it is actually very important to be done, even for infraradiological lymph nodes which are not visible during the PET scan.
Yes.
So I routinely do EBUS for all the cases irrespective of the PET scan report.
Yes. Because we know that PET scan is a lot of false positive because of infective and all. Correct. So after this, okay, how you will evaluate for the, we all know the staging, so I'll not go into the staging of the lung cancer. Already it has been, and there is some modification in 8th AICC thing. As you told, pre-op assessment to define the fitness of the patient, which modalities and how exactly you will do the workup, just for the sake of audience.
We'll do a pulmonary function test.
What you will see into that pulmonary function?
The FVC is greater than 60.
Yes.
Well and good. If it is 30 to 60, I would need further investigations to see whether.
Yes.
Ask my pulmonologist to see what to do.
Yes. So there are 2 things: respiratory mechanics and lung parenchymal function. So most of the time we refer our patient to the pulmonologist who will give us the fitness and about the restrictive airway disease, or if there is anything he can modify. Moreover, we have to prepare a patient. We have to tell them to stop smoking at least 1 month before when we are planning. And then if this FE1, I mean there is a chart here which we can see patient requiring lung resections, whether they are fit for limited resection like a lobectomy or bilobectomy, or whether pneumonectomy is required depending on their lung function test. So as Dr. Purushottam rightly told, spirometry with FEV1 60, more than 60, yes, they are fit for surgery even for major resection. 30 to 60, we have to again do some more tests and evaluate, and definitely less than 30 who have coronary heart disease or some other comorbidities, probably they may not be a candidate for surgical resections. So very important is pre-op fitness for the lung surgery. Next, now we are planning for surgery. So I'll ask Dr. Bala how you will consider a patient for anesthesia and what modification you will ask for the anesthetist, and also positioning of the patient. You have shown us some videos with the position, but you can illustrate about it.
So we go on to have the patient in the OT and do a double lumen tube intubation.
Yes, very important point.
The key to any minimally invasive, whether it's VATS or robotics, is to have a fantastic lung isolation. If your lung isolation is not proper, you obviously will not be able to proceed with the procedure. So the anesthetist has to be is such a key man in the whole surgery. So he has to do a proper one lung isolation with a abdomen tube. We position the patient with a flexion at the hip area, predominantly to get the intercostal spaces opened up, and we make sure the double lumen tube is clamped on the side you want to operate as soon as we position the patient. So routinely we don't use CO2. If we clamp the double lumen tube side pretty early, you find that by the time you put your incision and you enter in, you find that the lung is really shrunk.
Sure.
So CO2 is not used routinely, and then you proceed for other.
Yes. Do you take arterial line or central venous line for both or one?
So when we do a lobectomy, because you are dealing with vascular structures, and because you are you may have a occasional pulmonary artery tear and all that, because you are dealing with vascular structures, I prefer a central line, I prefer an arterial line.
Okay. And do you always keep blood reserve for surgeries, and how much it would be?
2 pints of PRBAC are routinely reserved. If it's a rare group, and we reserve an extra pint.
Yes. So absolutely. See, before any embarking for any major surgery, what are the prerequisites? I think very well explained by Dr. Bala, that the anesthesia consultation, pre-op fitness, then positioning, double lumen tubing, arterial line, venous line, and then positioning is very important. So all those things are in place, then probably our journey for the surgery would be smooth. So next question to Dr. Nara. Now, patient is fit for on table now. Suppose we are planning VATS or robotics, or maybe open sometimes. What incision or port placement you will take, and also brief important aspects about the dissection. Key points.
Right. Well, I need to emphasize that the approach to surgery is immaterial. Most important is the oncological principles are kept.
Yes.
You must make sure that the lymph nodes are dissected, margins are clear. And if you can achieve this by uniportal VATS, uniportal RATS, multiportal VATS, or open, then by all means, please go ahead. It's not that you must perform VATS, must perform uniportal VATS. No. Having said all that, making sure the oncological principles are adhered to, then the way to go to minimize the morbidity of the patient is by going for minimally invasive procedure. And if it's available in your center, the experts are there, by all means, please use these methods. And for multiportal VATS, the port placement, there will be a working port in the anterior aspect in the 5th intercostal space.
Yes.
And at the axillary line, there will be a single, at the 7th intercostal space, there will be normally a camera port is inserted. And at the infrascapular region, there will be another port assist in the retraction. So most of the dissections will be performed in the anterior working port.
Yes.
And the staplers may be inserted from the posterior or anterior, or the camera can be moved anterior and the stapler come from below. So that is if you use multiportal VATS. If you use uniportal VATS, all the work is performed by the single working port that is made at the anterior 5th intercostal space, about 4 centimeter in the length, and the instruments are used with the camera through the same uniport. And the dissections are done on both, the dissections are done similarly. either you do multi-port VETs or uniport VETs, the dissection must adhere to oncological principles. The only difference between multi-port and uniport VETs is the view. Whereas for uniport VETs, you'll have an end-on view, similar to how you perform an open surgery. Only thing is miniaturized. Whereas for multi-port, you have a view from a tangent, where the camera comes from the 7th space and you're working from the 5th space. So you'll have to reorganize your image in your mind, the 3D image. If you perform multi-port and then you move to uniport, you need to get used to the end view when you perform minimally invasive techniques.
Yes. And then once you start surgery, what are the key important steps? Mobilization, looping the vessels and firing the staplers, and just a brief important steps.
It's difficult to put it brief, but basically the principle is that you can, by oncological principles, you go to the vein first, followed by the artery and the bronchus.
Yes.
But when you perform minimally invasive surgery, whatever comes first that is easiest to take, we go ahead for that. So when you dissect the vessel, it's important to dissect the prevascular fascia, bearing the vessel nude, and then looping around without leaving any tissue around the vessel, so that the chances of injuring the vessel, especially the pulmonary artery, is minimized. If we start dissecting the vessel without denuding the fascia, then the chances of injuring the vessel for unnecessary tension at the junction of the main PA and the truncus, for example, or the posterior ascending artery is high. So you can injure that junctions, and that is how the PA gets torn. The vein is normally more robust. It can take some beating. But you just follow the same principle, it should be safe.
Yes. So, of course, both of the surgeons, they have shown few videos about the surgical aspects. Unless you see, it's very difficult to imagine. And being these cases are not routinely performed at even in a good tertiary care center, I think we have to get that's exposed, like Dr. Nara has visited the high volume center and in China. Similarly, probably any of us have been inclined to do thoracic surgery, they should visit these high volume centers, get experience, get trained, and then do. So these are already he has explained few important steps of the vascularity, vascular ligation, stapling, and isolating and stapling things. So coming about, okay, you have done now the lobectomy or bilobectomy. Important as all oncology, for all organs, only removal of the organ is not important, but also we have to address the nodes. So what are your thoughts for systematic node dissection or sampling, and how you go ahead, Dr. Nara?
As I've mentioned earlier in my talk, the lymph node dissection is very important. In fact, if it is not more important than the lobectomy itself. Lung cancer surgery is not about removing the lobe alone. It's equally as important as removing the nodes systematically. And systematic meaning the anatomical landmarks of the lymph node region must be achieved during the dissection. So if you could appreciate in the video I showed, the anatomy, meaning the trachea, the brachiocephalic artery, the SVC, arch of aorta, and if you notice, all these vessels are major vessels.
Yes.
And if you injure them wrongly, it's catastrophic complication. So it simply means you need to have good training, good exposure, and good mentor to guide you along, to be there with you when you're doing the dissection and stop you when you perceive that it's going to cause injury. So it is very important to perform these dissections in a stepwise manner. Don't straight away jump to do the left 4L lymph node dissection. It's very difficult. Go ahead with the 2R, 4R first. It's relatively easier. Then move on to the station 7, station 7 on the left side, and 5, 6, and then adventure to the 4L if the PET scan shows positivity and EBUS is suspicious.
Yes, absolutely. Very, very important words from him that it's not that sampling is just berry picking or taking 1 or 2 nodes and sending. It has to be a proper systematic mediastinal node dissection by identifying the structures, the boundaries, and do it. So Dr. Bala, how many minimum nodes, already he has explained, but minimum nodes or minimum stations you have to address. Suppose a upper lobe tumor, what do you do, and lower lobe tumor, what do you do?
So ESTS guidelines specifically say 3 lymph node stations
Yes.
and 6 lymph nodes. So anything less than that, the pathologist is going to say it's NX. So we need at least 3 stations done with 6 lymph nodes.
Yes.
You usually, if you do a systematic dissection, your lymph node range will be from 16 to 24. Normally, if you have covered all the lymph node stations systematically. So when you do an upper lobe, minimum would be a 2, 4,
and
hilum 10, and the subcarina.
Yes.
When you are doing the lower one, you will be doing 7, 8, 9, and the hilum.
Yes.
So although having said that, if you have, if you can do a systematic lymph node dissection of all the stations, it will be excellent.
Yes. And what is your experience about skip metastasis? And just because many of time we are all afraid about the complications. So what precaution you should take already has explained, but any other further few minor points you want to tell about the skip metastasis and complications of lymph node dissection?
So one common complication we see is the lymph ooze that we
Yes.
see after the dissection. So as by there is always a controversy whether they should do all the stations or stick to only 3.
Yes.
Because you do all, your brain is going to be seroma for a week. So I personally would like to dissect all the lymph nodes because as your pathological staging is complete.
Yes.
And as Dr. Nara told you, we are doing 3A2 into lymph nodes, where you can't say you're going to do only 3 stations in that area. You have to do all the systematic dissection. Minimum requirement there is 16
Yes.
lymph nodes
Yes.
for your full pathological staging.
Yes. So it's a must. How it helps? Of course, accurate staging happens if we have adequate lymph nodes. A lot of tissue is there to study. And also, some patients, some selective group of patients, there is a survival benefit also. Not for all, but there are some selective patients. So these are the lymph node stations for all our students. You can go and read about all. But as he told, 2, 4, and 2 are very important in subcarinal. These are minimum lymph node dissection we have to do, and it has to be done in systematic way. And sometimes upper lobe, lower lobe, there could be change into the dissection stations, which Dr. Bala has already told. And these are the samples. As it is end block dissection, it should not be a berry picking or random sampling. Identifying the structures and taking out all the fibrofatty tissue along with the lymph nodes and send it for final histopathology. Already Dr. Bala told about the systematic lymph node dissection, survival benefit, and what has to be done, minimum how it should be done. Yes, the conclusion is all the patients should undergo lymph node dissection, and it doesn't take more than 30 to 40 minutes in an experienced hand and without much complications. Sometimes there could be some ooze around the subcarinal area, minimal because that area is little rich in vascularity, and the venous ooze can be there, which can be managed easily unless any major structure like artery or vein has been injured. And this is the proper sample for any lobectomy with tissue along with the margins of bronchial margins. So it has to be sampled. Again, the pathologist can be give more answer about it. And the lymph node stations have to be separately taken, mentioned, and sent to the pathologist. Minimum 3 stations and 6 to 16 notes should be sent for the adequate examination. So that was about lymph node dissection. Then surgical approaches, already our eminent panel have described about the open, VATS and RATS. Open as a conventional, still it is a gold standard where the facility is not available, but now even all the most of the centers, they are moving towards RAT, and very few centers who are moving towards the robotic surgery. And already Dr. Bala and Dr. Nara has shown various studies, trials about the comparison of open surgery versus video-assisted thoracoscopic surgery versus robotic surgeries. You can see here the comparison. Oncological safety has been established in most of the cases. Lymph node dissection, they say it is easy with the robotics because of the manuring, the endorist and picking up the tissue. Of course, it takes little more time, and in VATS, the mobility little gets difficult, so the lymph node it would be little less, but even in experienced center and a surgeon like Dr. Nara, they can do a very good job. Apart from the cost, which has been already told, because a few centers are there, so the cost of robotic surgery is little more, but as the surgeons, experienced centers will come more, probably it will come down. So these are performing lobectomy. Open is still gold standard. I am not saying you should not do, and that message has to be, as Dr. Nara told, the fundamental aspect approach is not important. How oncological safe you are doing resections with good margins and with good lymph node dissection, with R0 resection, that matters for the survival. So that was all about the different approaches about open, VATS and RATS. Now, okay, you have done the surgery, now patient has been shifted to the post-op critical ward. So what post-operative management, Dr. Purushottam, you will take about the pain management, fluid and ICD management?
Yeah. So regarding the pain management, previously when we were in the era of open thoracotomies, we used to do a nerve block.
Yes.
Yeah, now, but, and now before, even after our VATS also, we ask the anesthetist to give a small nerve block. That helps a lot in the patient in taking the respiration also post-operatively, and it decreases the complications, even the pulmonary complications.
Yes.
Other than that, I prefer not to give opioid pain like fentanyl patch and all for these type of pain.
Yes, because they cause respiratory depression.
Yes.
Do you give epidural to your cases?
Yes, thoracic epidural.
Thoracic epidural.
There is a word of caution. If you have an epidural, thoracic epidural, it is not like for cost cutting, you can't send the patient to the room and give the epidural. There is a chance that sometimes if it is not placed properly, there is a chance of severe hypotension which can occur, and it can be it can be the treating physician in the ward would miss it, and then you will get a call in the night.
Okay.
That's one thing.
Okay. And fluid management, how you start oral and how you balance the fluids?
Fluid management is like in the first day until the patient recovers from anesthesia, will be on IV fluids. But if there is less in a day or two, we actually start off orals and all.
Yes. And what about ICD management? How?
ICD, yes. So regarding that, as Dr. Bala said, if there is a lymph nick, that is a little bit troublesome for us, and it increases the days of hospital stay. And another thing which we feel a little bit apprehensive is bronchial air leak.
Yes.
So once a bronchial air leak comes, it causes a lot of multiple problems from an young surgeon's perspective. I definitely know that.
Yes, that slide is there about the air leak management. But the ICD management, what are your words, Dr. Bala? I think you promote as early removal.
Yeah, so we, our strategy would be to get them back to a normal physiology as early. So we'll be starting oral as early as 4 hours after the procedure. We won't be having them at all. So recovery from OT, 4 hours you are on oral fluids. I'm like the next day. They are eating normally, eating by next day. Fluids, we tend to restrict fluids.
Yes.
Maybe 1 to 1.5 ml per hour, and once they are on oral, they start oral, and if they are maintaining a good oral, we can completely stop IV. If they are young patients, they are in the room by evening.
Yes.
If they are elderly comorbidities, we feel we need to home observe them. They may be in the ICU overnight. Drain management, because we are in India and they don't want people to come back with loculated effusions. I tend to have a threshold of 100 ml.
Okay.
It may be a bit too low to go up to 100, but in India, I feel staying a day or two extra is better than coming back after an early tube removal and having a local full effusion.
Okay.
So all those entities are there who remove when the drain is 200 ml and serous. They immediately remove the drain. So it all depends on what center you're practicing.
Yes. So all of us agree now. Today we are moving towards the ERAS protocol, that is early recovery. So early removal of the tubes, early removal of the catheters, starting orally early, and promoting them ambulatory. So that as early as they can resume to their normal physiology, as Dr. Bala told. So next, we all worried about the complications. So this is the list of the complications in all thoracic surgeries. Mortality around 1 to 2%, morbidity around 10 to 20%, but most common complications are reopening for bleeding. Most of the time, the bleeding would be intercostal, and then the other things are major vessels. Prolonged air leak, which we will discuss, pneumonias and atelectasis and ARDS, these are chest-related complications, will be always there. So promoting chest physiotherapy is also important. Then atrial fibrillation is a heart-related complication, is also we experience many times. Empyema, chylothorax, and very rarely nerve-related injuries, phrenic nerve and recurrent laryngeal nerve. So these are in brief the most common complications about it. But as Dr. Purushottam told, that very important is persistent air leak and how to manage and how to prevent. So just can you share all of, just quickly one about management and prevention of air leak? Yes, Purushottam.
Don't compromise on the stapler.
Yes.
During surgery. If you compromise over there, you are bound to get air leaks afterwards.
Okay.
That's one thing.
Okay.
I understand that cost is an issue, and but do not compromise on the staplers over there. And good surgery decreases the chance of air leak to a very large extent.
Yes. Dr. Nara?
Yeah.
All right. Well, air leak is always a problem that haunts thoracic surgeons. And in the way I look at it is, when the air leak happens, as a surgeon, you can predict where it's coming from. Because you know when you did the surgery, which part that you had a second thought. When you cut that, should I go and reinforce it? And then at that point, you'll say, it's okay, there's no leak. And you just leave it. And that's the one that come back haunt you.
Yes.
So when you have a second thought whether to repair or not, always repair.
Repair.
Always repair. Especially when you do the carinal dissection and you thought you shaved a little bit of the membranous part when you removed that densely stuck node, and you thought, it's okay, I don't see any air leak, just leave it. And when the patient is reversed and they start coughing, that membrane will burst and it will not hold. So that will cause prolonged air leak. So when you have that second thought, when you do the surgery, always take a suture and repair it.
Yes.
And I agree with Dr. Purushottam, don't compromise on the stapler usage. You have the last bit to take and you thought you can just put a harmonics and just open it up, but that is dangerous.
Yes.
So either you clip it or take another stapler and fire.
Yes.
And maybe I can tell Dr. Bala to see when
Yes.
do you intervene again when the air leak is consistently there.
Yeah. So in the OT, we make sure we repair our air leaks to a point that the ventilator, on the ventilator, they have less than 100 ml of air leak.
Yes.
So on the ventilator, if it's less than 100 ml, on spontaneous aspiration, they won't have air leak. No, normally. So you don't really have to go and repair every single tear.
Yes.
100 ml on ventilator, I'm okay. Then day 1 or day 2, if your lung is completely expanded, all your air leaks normally stop
Yes.
on its own. Unless it's grade 2, 3 and 4, if it's grade 3 or 4, I'll immediately be back in the OT and I'll be
Repair.
seeing for early can be repairing. At grade 2 and 1, I may tend to wait for 48 to 72 hours and they invariably stop.
Yes, so there are few important preventive aspects: bronchial stem buttressing with the muscle flap, pleural tenting, suture, closure of identifiable risks intraoperatively, buttress stapler. You can have that stapler buttress staplers are available. Fissureless operation, try to mobilize from the hilum and then come to the fissure. Sealants are also there, regenerative agents are also there which can block, and as early as chest physiotherapy and all those things. Pneumonia, one other complication is mucus plug and pneumonia. So these are all aggressive chest physiotherapy, mobilization, adequate pain control, smoking cessation, and good antibiotic is important. Sometimes the mucus plug become an issue, then we call intervention radiologist, and just suctioning or aspirating that mucus plug through the bronchoscope makes patients easy. And chylothorax, as Dr. Purushottam mentioned about, when we do more extensive node dissection, sometimes through the lymphatics it can leak, but sometimes the thoracic duct also can damage and there will be a leak. There are various options. If it is small, more often we encounter this complication in esophageal surgeries, not in lung surgeries. But if the leak is contained, conservatively we manage. If it is more, then we can go ahead, and there are medium triglyceride dietic supplements modifications we do. And because of time constraint, I think we are rushing, so I will not take many. There are 3-4 cases which are different of presentation, but I'll not take further cases. Just these are few important rare cases which we want to discuss. I mean, just to show. This is one young patient around 30 years. He presented with lung lesion and pancreatic lesion in our hospital, and I'm sure Dr. Nikhil remembers this case. His name is Thakkar, and it came as extraosseous Ewing's, extraosseous Ewing sarcoma, which was rare, and we managed with the surgery. And there was one pancreatic lesion, metastatic lesion, that also been taken care with the chemotherapy. After that, he developed tuberculosis, which also managed. This is one case, a young boy with the pulmonary blastoma. I don't know how many of you have seen, very rare, like hepatoblastoma or nephroblastoma, Wilms tumor. Pulmonary blastoma, easier, the classical CT presentation and resected nicely. And this is one incidental case. I don't know, Bulakshmi is not here, Dr. Bulakshmi. Patient actually came for thyroid surgery, papillary carcinoma of thyroid, but in a CT scan there was a big lesion here, which was little confusing, and the pathology came as inflammatory lesion, which very closely mimic with malignancy. They may not differentiate, but now with the immunotherapy, markers, molecular markers, we are able to differentiate those things. And sometimes endobronchial lesion like NET, neuroendocrine lesions are also there, which we do either reminectomy or maybe separate resection and anastomosis, tracheal and resections, and those things also do. This is one more case, huge lung lesion, which came out as a teratoma, in the lung teratoma, which we resected. So thank you very much, the eminent panel. Definitely, surgery is one thing which is, for a surgeons, it is enthralling experience, especially the thoracic surgery. It's time to time, or second to second, or minute to minute, the plan changes. Immediately, intraoperatively, suddenly there is a ooze, or suddenly there is a bleed, or a air leak, and all those things we have to manage simultaneously. Of course, a good pre-operative evaluation, as Dr. Purushottam told, with the good physiotherapy, and then intraoperatively meticulous dissection, keeping attention in detail during every step of the procedure, having our team intact, taking confidence, the anesthesia person, critical care specialist, ICU specialist, and also promoting the early recovery for the ambulation, chest physiotherapy, and proper antibiotics, and all those things. I think we can deal away very good surgical results. So thank you very much, Dr. Bala, Dr. Nara, and Dr. Purushottam for having this wonderful discussion. Thank you.
Thank you, sir. I request our moderator and panelists to remain with us on the dais. I request Dr. Kiran Kumar, sir, Senior Consultant Radiation Oncology, Yashoda Hospital, to please join us and to present mementos to our panelists and the moderator. Dr. Sachin Marda, sir. Dr. Bala Subramaniam, sir. Dr. Narsimhan Satyamurthy, sir. Dr. Purushottam K, sir. Thank you, everyone. With this, we come to the end of the morning session. We'll break for lunch now, and the next session will commence by 2 o'clock. Please join us back. Thank you.
If bank.
Good afternoon. Welcome back. Now we'll move on to our next session. For the next session, I request Dr. Prem Kumar Sir, Senior Consultant Radiation Oncology, Omega Hospital, to join on the dais as a chairperson, and Dr. Nalini Ma'am, Senior Consultant Radiation Oncologist, Yashoda Hospital, Somajiguda, to join on the dais as chairpersons for the next session. For the next topic, now I invite Dr. Kaushik Bhattacharya Sir, Director HOD Radiation Oncology AAG Hospitals, to discuss regarding curative approaches with radiation in lung cancer management. Thank you.
Thank you. This light's just falling on my face. Not possible to change this. Okay. Can I run the slides by myself from here? Can I run the slides myself? Yeah. So, good afternoon. And I see that most of the people who came to the audience here, they came for the lunch, they've taken the lunch and vanished. So people who have stayed back, well, they are the true searching in the true search of knowledge. That's why they have stayed back. So kudos to you. And also thank the organizers, because I started my work in Hyderabad in Yashoda Hospital. That time Somajiguda did not exist. Oncology department didn't exist. And so it's nice to be back here again. Okay, so this is a blank slide. It's not wrong, it's a blank slide. While this is blank, I wanted to know, tell me how many of you are oncologists here? Any type of oncologists? Any type of oncologists? Oh, they're about 15%. Good. So I will moderate and modulate my presentation accordingly. Now, when I say that role of radiation in curative treatment of lung cancer, I think the word cure and lung cancer has to be seen in a very critical way, because if you see the 5-year survival rate of non-small cell lung cancer, the small cell is in a smaller chart, and ignore that. Is it coming? In the non-small cell lung cancer, the American Cancer Society SEER data shows that only 28% of people will live after the diagnosis for up to 5 years. Of course, that depends on stage to stage. And when I say localized, who will live up to 64%, that means the disease is only limited to the lung. And by the time they have gone to regional, which means they've gone to a lymph node, only 37% will live for another 5 years. And once it has become metastatic, the chances of 5-year survival is only 8%. So whenever you say cure in lung cancer, it is not that everyone is going to make it. And in 8%, if you say this data is from 2017, and if you ask me what is the 5 years change, the maximum change is actually in the stage 4 disease. And that is because of the huge amount of new drugs, the molecular pathology and the molecular intervention that has come in. And that, I think you're going to listen to this after this presentation, after this session. Now, since you have no background in oncology, you have to understand that all oncology cases are divided into T, N, and M stage, and lung cancer T, N in particular is very difficult. So I will try to simplify it for you. When I say that the role of radiation as a curative, that comes after surgery. And anything that is less than 7 centimeter and not involving the pleura, not involving the major vessels, not involving the trachea, bronchus, pericardium, or the diaphragm is operable. And operation should be the first thing to be done. So that is when insofar as the T stage is concerned. And regarding the nodes, anything that is on the ipsilateral side is the N1 has to be operated. Anything that is in the middle, either the mediastinal nodes, they can be operated with some caveat, which is if it is subcarinal, the surgery will be much more difficult, and therefore the surgeon has to take a call. And anything that is on the opposite side of the hilum, or if it's a supraclavicular, you don't operate them. So these are the 3 fundamental things when it comes to the role of surgery. Now, why this is important to know? Because the complex arrangement of the stage grouping can be very, very daunting even for an oncologist. So I'm trying to make some sense out of it. From this, all the stage 4 is out from my discussion. And also the N3s and the T4s are out. Rest, whatever is remaining, all the T1s and the T2s and the early T3s, where it's only limited by the size, all the N1s and some of the N2s has to go to the surgeon. So radiation oncologists have no business in this. We come in here. So they go for surgery, and we come in here. So where is a role of radiation oncologist in a curative treatment? Well, if it is a T3, which is not operable because of involvement of the structures, or a T4, if it is an N2 because it is subcarinal when the surgeon cannot operate, or if it is an N3. So these are the stage groups, which is essentially the stage 3B and a select group of stage 2A. This is where the radiation is effective in a curative setting. And radiation not alone can do the work. It is almost always associated with the chemotherapy. So chemoradiation is a radical and curative treatment for a stage 3B and some stage 2 and some stage 3A diseases. And very slowly, very, very slowly, there is another group of patients which are coming under the ambit of curative radiation is a very, very early stage lung cancer, which is 2 centimeter, 3 centimeter size and no nodes. And these are treated with a technique called stereotactic ablative body radiotherapy. Now, all my discussion from now on will be basically elaborating on this structure. And even if you leave the hall now, you have known whatever I have to tell. And you might see that the stage 3A is present both in my surgical side as well as the radiation side, because these are the areas where gray areas, the surgeon can operate in some cases they cannot. And the subcarinal nodes are the main reason that they're in both places. Now, since you have no radiation oncologists here, or vastly people are not radiation oncologists, let me tell just a few words about it. Basically, radiation oncology is nothing but use of very high energy X-ray. And when it passes through the tumors, it induces certain changes in the DNAs and the molecules, and the cell dies. And the cancer cells are more susceptible. That's why they die. But when I say that it's X-ray and the radiology and the radiation oncology words are very similar, please don't confuse us with a radiologist. Well, radiation oncology is possibly the most complicated subject when it comes to present-day medicine. At least it is the most expensive for sure. The cheapest radiation oncology machine is about 24 crores, and the price can go up to 250 crores. So treat us with respect and sometimes fear, but then fear not. When you treat a simple lung cancer with simple parallel opposed radiation fields, what happens is that you end up treating a lot of canicles of water. You end up treating a lot of normal tissue in it. And what are the main normal tissues? It is basically esophagus, it's basically the trachea, a lot of normal lung, and that can give rise to quite a few side effects. And that is one of the reasons that radiation oncology has been often misunderstood and feared by people who are not into oncology practice. So pneumonitis and esophagitis is a real problem. However, to mitigate those problems, there has been a lot of efforts done over the last 20, 30 years. Now, this is a classic clinical situation where there's a tumor which is around, let us say, the esophagus. This is the esophagus, and this is the tumor around it. And if you treat in a conventional way, what will happen is that you treat everything. There's no way to run around it. But if you keep on involving the technique slowly and slowly and slowly, we move on from the conventional techniques to 3D CRT to what we call as an IMRT, by which you achieve a dose on the target without exposing the organ at risk to a higher dose. Now, this is what radiation oncology planning is all about. I'm not telling much more than this because my next speaker will possibly talk on a bit of this. But I could not resist the temptation of adding these two slides. These slides are possibly, these patients were treated possibly 17, 18 years ago when I was in Yashoda Hospital. And Nikhilesh told me to tell this, I'm telling you, this bears my login even now. And this bears the login of Dr. Prashant Upadhyay, who was my DNB student at that time, and he's a senior consultant in Apollo right now. So this IMRT patient of lung is possibly the first IMRT patient in Hyderabad for lung. So thank you for giving me the chance to share this slide with you. Now, when I said that a simple X-ray is given from the outside to the tumor-bearing area, what sort of dose you give? The standard dosages that have been described are in the range of 60 gray to 70 gray. And there's always been an anxiety about at that dose, what happens to the esophagus, what happens to the heart, what happens to the lung. There are some recommendations as to how much of the tolerance should be there for the lung and the esophagus, but I will go back to it in slightly greater detail later. But let me first tackle the question of what dose. Now, as we have shown that at a certain dose, beyond 60 gray or so, the toxicity can be sometimes significant. There has always been an attempt made to reduce the dose. And how do you do it? Now, there are many trials, and one of the major trials is the RTG 0671, which is a 2x2 factorial where they used high dose 74 gray versus 60 gray, and the other two arms were cetuximab added to paclitaxel versus only paclitaxel. And that trial very conclusively showed that 60 gray is actually better than 74 gray. And adding cetuximab has got no role in chemotherapy of concurrent chemotherapy of lung. So with this trial, actually before this trial also, there was a tendency for all the Americans to bring down the lung dose for radiation. But this trial is kind of the final thing that said that beyond 60 gray, there is not much of a benefit. That being said, I will be very glad if anybody in the audience can ask questions on this trial, because a lot of questions on these trials. I'll be glad to answer that. So I will see how much you are listening or you're sleeping or not. I'll give you one case as an example. This is a case of stage 3B, because you can see multiple nodes as well as on the opposite side. There are N3s are there, therefore it's different to 3B. And there's a big lesion here. So it's a 57-year-old male who is actually a father-in-law of a neurosurgeon in the city. Was a smoker, came up with a squamous carcinoma, diagnosed as 3B. The patient received 60 gray in 30 fractions with concurrent Pacli and carbo, which is currently the standard. He developed grade 3 esophagitis. He recovered from it. And when you do the radiological assessment or a PET-CT assessment, you see that the resolution in both in the primary and in the trachea. However, there are two things that at that dose, when you have N3 disease, esophagitis is a major issue. So you have to deal with it. Second thing is that when you look at a disease like this is bound to fail, and it did fail in 1 year in the brain. So the next lecture, I will talk about it, how to do that. The learning from this is that you may have good response, but still they will fail. So we have to ready about it. So it's not just because one PET is negative, we're happy with it. Other thing is that what really determines toxicity in stage 3B lung cancer. Now, there are plenty of trials, and I have decided to discuss one trial, which is a meta-analysis of individual patient data by David Palma et al. They found the key thing that matters, there are two key things. One is use of carboplatin and paclitaxel. There's an odd ratio of 5.52, which means it's very, very important as compared to cisplatin and etoposide when you use carboplatin and Pacli. Although I understand the medical oncologist can tell me, anyone is still using cisplatin and etoposide? So when do you choose carboplatin and when do you choose cisplatin and etoposide? Any pointers? Because there is no trial telling that this is better or that is better, isn't it? The TC2 is a better outcome. So on a randomized trial, PACLI. Yeah, so that's what. So the point is that just because, so this is one of the points of RTO 0617. Just because the trial had used paclitaxel, that doesn't mean that that is the only drug you can use. If you think that concern is there for the toxicity, you may pretty much go back to CC2, even though it's cheap, even though it's not so sexy anymore. You can use Veneralbin, there are so many other options are there. All the options are valid options. The next thing from the radiation oncology point of view is what we call as a V20, which basically means that how much percentage of the lung is getting 20 gray dose. Now this is a very, very important factor because at that level you have 1% mortality. And once you go beyond that, by the time you're in 40%, by the time you are in 40% V20, you have 3% mortality, which is kind of unacceptable. So fortunately, you can use this planning systems which can tell you that how much of risk is involved. The other question that is very important as a paradigm shift in the way radiation is done is to treat the node or not to treat the node. And there are plenty of randomized trials. And I have decided to just show one propensity score matching study which shows that there is absolutely no benefit of giving nodal radiation electively. If you have a node, you treat it. If you don't have a node, don't go and treat the radiation. So that changes a lot of things when it comes to toxicities. Now, while this is all true for stage 3B, I told you there's another area, which is very, very early stage disease, which is like stage 1, 2 centimeter, 3 centimeter diseases. And for quite some time, we have known that if you can give a very, very focused dose, very high dose to a very small area under a lot of image guidance and making sure that nothing is going to affect it, you can actually get very, very good outcomes in a patient where, in spite of this patient being an operable patient, for some reason not very good. It could be medical inoperability, it could be any reason. And in fact, you can even treat them on the basis of radiological diagnosis. It is not necessarily that you have to have a biopsy all the time. There are many radiological criteria by which you can tell with a very high degree of concordance that this is a early lung cancer, this is a T1 lung cancer, without actually having a biopsy. So there are plenty of trials that were there, and very ambitiously, there are two trials that were started. It was the STARS trial and the ROSEL trial. One is based out of Netherlands, one is based out of USA. Unfortunately, the trials were the recruitment was in the hand of the thoracic surgeons. So they made sure that no person is actually getting recruited in the trial. And after languishing for many years, they decided, well, these trials are not going anywhere. Let us put together and see whatever is there and we'll analyze. And the data that came out of the joint STAR and ROSEL trial is really, really disruptive. They showed that actually stereotactic ablative radiotherapy for early stage lung cancer is far superior to lobectomy. Now, there has been lots of criticism of the trial because it was two incomplete trials were clubbed together. But what it pointed out is that at least they're not inferior. And in medically inoperable, you should definitely do it. Still now, it is not a part of high-level recommendation as an alternative to surgery for early stage. But for a medical operable, it is definitely the case. So I will just show last case. I need 3-4 minutes maybe, 2 minutes maybe. So this is one gentleman who, 80-year-old gentleman, was found to have a pleural-based nodule. The patient was found to be having this during the COVID period, during COVID screening. The tumor was PET-avid, and it was fitting in onto the radiological criteria. So we did a SABR for this. Actually, post-COVID, our SABR rates have gone up. We used to do very less SABRs early, but during COVID, there were so many early lung cancer detected. Incidentally, they have done quite a bit of it. So we gave 55 in 5 fractions for this patient. The respiratory motion was managed by a technique called deep inspiration breath hold. You have to have rigorous quality assurance for this. Patients had steroids and physiotherapy to make sure the management is there completely. And at 9 months, the patient got a little bit of irritating cough, and the patient was advised to undergo a CT scan, PET CT scan. Now, it is not the ideal time to go for a PET CT scan post-SABR. Ideal time is at least 12 months, but it underwent anyway. There was no uptake, or very minimal uptake, minimal residual on the CT, and there's a little bit of fibrosis seen. So for all practical purpose, this patient is cured. So to summarize, the mainstay for inoperable lung cancer is chemoradiation. And immunotherapy has come up in a big way now. There is specific trial and all that, which I'm sure in the next discussion we'll do. There's a bit of a focus on de-escalation, and practically everybody is now sticking to 6 degree. There is some deviation from that thought, but for all practical purpose. You have to have IMRT, IGRT, and gating. Without that, if you don't have full access and full skill on that, Don't faff around. Don't treat curative lung cancers without these facilities. Safety is paramount because toxicities can be significant. The very first patient that I treated with concurrent paclitaxel died. And you have to have intensive quality assurance. SABRE is coming up very nicely for the early stage diseases. It's a rapidly developing tool. It's possibly equal to or even better than surgery for selected patients. And of course, there's a steep learning curve for that. So thank you. Thank you very much.
Thank you very much, Dr. Kaushik.
No questions asked.
Yeah. It was a lucid presentation. You made it very clear. So maybe it's just SABR or concomitant chemotherapy.
Yeah.
So I think, yeah, if you
Thank
have
you.
any questions, please, you're welcome. Anybody? Postgraduate students?
Thank you.
Thank you, sir. Moving on to the next topic. I invite Dr. Pradeep Kumar K, sir, Consultant Radiation Oncologist, Yashoda Hospital, Somajigoda, to join us for the discussion on recent advances in radiotherapy in advanced lung cancer setting. Kindly join us, sir.
I think this is a vast subject. We have so much in modern radiotherapy with our new armamentarium, with IGRT, 4D, gating, and cone beam CT. So all these things with PET CT planning, all these have contributed to very good target delineation and also target delivery of the prescribed dose with precision. So Dr. Pradeep Karumanchi, I think we'll talk about it.
Thank you, ma'am. Good afternoon, everyone, and thanks for coming here to know the recent updates in lung cancer and to widen up the knowledge base to encourage people to get to the newer modalities of treatment. And finally, our ultimate goal is to decrease the incidence and increase the curative rate of lung cancer. So my topic would be recent advance in radiotherapy and its role in advanced lung cancer. So my previous speaker, Dr. Kaushik sir, has already given nice elaborate clarification on what is the role of radiation and chemoradiation in curative approaches. And so I would be sticking to the remaining part, that is advanced lung cancer setting. So as we have already seen, treatment modalities in lung cancer are primarily surgery, chemotherapy, immunotherapy, and radiation. And in radiation, we have different types of techniques, and it has been evolving since ages, from right from 2D RT, then 3D conformal radiation, then it started becoming intensity modulation, then adding up image guidance to even get more precise techniques, and finally the frontier of radiosurgery or body radiotherapy, that is stereotactic body radiation therapy, and the new evolving trends of proton therapy, biologic guided radiation, as well as the flash RT. So what is the role of radiation in advanced setting? As you have seen up to stage 3, and we have seen there is a curative intent and there is a role for radiation, chemoradiation. But when it comes to advanced disease, that is metastatic, when the lung cancer has been spread to different parts, the only thought we all get is it's a palliative intent. And when it's palliative intent, we always see radiation has a role when there is some symptom, like relieving pain in bone mets, or neurological symptoms when the disease has been spread to brain, or spinal cord where there is spinal cord compression or brain metastasis, and to decrease bleeding when there is involvement of bronchial, and this can be seen in endobronchial tumors. And coming to the other things, there are symptomatic dysphagia or dyspnea due to local advancement of the tumor. But is that the end of role of radiation in advanced cancer? So just we'll go through a typical case scenario. There is a 64 female active smoker with difficulty in writing and right foot weakness, which are indicative of involvement of brain. So MRI brain has shown 2 lesions. And PET CT has already shown there is a local lesion in right lung with nodule. And biopsy has been proven as non-small cell lung cancer. So this person has been given for palliative setting of SRS to brain metastasis, then followed by chemotherapy, and there is stable disease in lymph nodes, but there is a progression in the lung nodules. So this has been taken up for local treatment for lung nodule with SBRT and followed by chemotherapy. The good thing is there is no evidence of disease in the body or brain, and the person has been having it improved overall survival. So this gives us a scenario that radiation is not limited to palliative setting in advanced cancers, and there is some other role. What is that? So in metastatic diseases, there is a role for curative intent for radiation. So because all the metastatic disease doesn't behave the same way, because there is a wide variation in the staging now involving M1A, M1B, or M1C based on their progression. And so we have come up with a concept for oligometastatic disease, which relates to fewer number of metastatic diseases outside the primary. That is, generally there is no consensus of how many should be taken as oligometastatic, but few trials have limited to less than 5 or less than 3, etc. So as you can see on this graph, as the stage increases, the curative, surgical, and radiation, their window keeps decreasing and the chemotherapy role keeps increasing. But oligometastatic disease falls in between, where you can try for some cure if they are responding. So few trials have been done to see whether this has any role. And a meta-analysis has already been done, and this has shown that people can be divided into low risk, intermediate risk, and high risk based on the nature of the disease and the progression of the metastasis, like metachronous, synchronous, as well as involvement of the nodes. Another trial by UT Southwestern, they have done a phase 2 trial with few patients and with oligometastatic disease, and they have been taken up for either stereotactic ablative body radiotherapy or observation with or with maintenance. So it proved that addition of radiation in the ablative doses increased the median progression-free survival. Similar trial has been done by another multi-institutional trial, and it also showed that addition of radiation increases median PFS and also median overall survival. And the COMET trial has also done variety of oligometastatic cancers. This also included lung, and here also as stereotactic body ablative therapy has been proven to be beneficial with increase in median progression-free survival as well as overall survival. So these all indicate us and can conclude that radiation has some curative role or even at least controllable role even in the advanced cancer setting. And this has been now incorporated into the NCCN guidelines where if there is a metastatic disease, you can always try for local therapy to the primary and oligometastatic lesions. And this should be considered in all metastatic settings. So as we all know, advanced lung cancer, we always start with target therapies. This is the new age therapy. And along with that, we have a role for RT, and this should all be considered for all the patients who have advanced lung cancer. So now coming to what kind of radiation techniques we do have and which have been evolved so far. Initial days we do have 2-dimensional, then it has progressed to 3-dimensional conformal radiation, and it has been a great change with the involvement of intensity modulation radiation therapy. From there, we have seen we can save a lot of normal tissues and through conformal techniques. And with this, we have started evolving few as a base. Image guidance has been added to that, which gave us to be more precise and more accurate. And when it comes to lung, the problem doesn't stop with precision or immobilization. There is internal motion because it is always linked with the respiration. And so the new challenge is whether you are treating the disease accurately, whether you are missing, or whether you are involving a lot of normal tissue. Hence, new techniques have been evolved which involve 4D gating or deep inspired breath hold, etc. So to understand this, just we'll go back to 3D CRT and IMRT. Here you can see in the pictures, 3D CRT, the planning takes up a lot of normal tissue. And when you go with IMRT planning, you can certainly save better amount of normal lung tissue as well as heart and esophagus compared to the older techniques. Even using hypofractionation with SBRT or SABR in the early stage lung cancers, you can always try for risk-adapted approach based on this location so that you can finish off within smaller fractions with higher doses. So as you can compare here, 3D CRT, MRT to SBRT, the precision and conformity is very high in stereotactic techniques compared to 3D CRT and MRT. So definitely it should not be in close proximity to any other critical organs. So now we are coming to the lung, which is having a new challenge with motion. So certainly with each respiratory cycle, the tumor inside the lung tissue keeps moving with inspiration and expiration. So how do you account for this? So now we have a new technique called 4D CT, which can be incorporated into planning of your radiation. This is 4D CT or 4D gating. This can be done using surface-mounted infrared cameras, which can track your respiratory cycles. And the respiratory cycle all through CT can generate images which will help you in knowing the range of motion. So for respiratory motion management, we can have in conventional way, we develop internal target volume that covers all the range of motion. And there is one more technique called accelerated beam gating. When the patient breathes normally, beam is only on while the patient is in the certain phase where you can generate the radiation beams to target. And there is one more thing called active breathing control. Here the patient holds the breath in certain phase of the respiratory cycle. Here then only the beam will be on and radiation will certainly hit the target without affecting the normal tissue. And there is dynamic tumor tracking. Here the patient can breathe freely without any specific technique or exercise that needs to be incorporated. So there is no need to hold the breath in certain phase. So this helps especially in older people who cannot follow certain instructions. And it will be very convenient for the patient. So either way, regardless of motion management, we need to add a few margin like clinical target volume or PTV for accounting for internal target motion as well as the systematic errors. So there is one more new concept that has been evolved, that is motion-free PET-CT planning. Here we have seen 3D PET-CT as well as 4D PET-CT or 4D gating till now. Even though they are generating through a range of motion a uniform area where you can target, but they still have some disruptions because of the movement or the disruptions throughout the cycle. This can be avoided by integrating 100% of the signal from each respiratory phase into a 4D PET-CT and create one single 3D effective image called motion-free PET-CT. This can help in avoiding the disruptions even with the 3D as well as 4D PET-CT images. So you can see the images here. The purple is with 3D and green is with the 4D and orange is with the motion freeze techniques. Certainly you can see a lot of normal tissue being irradiated, and at the same time you are not missing the main tumor to be targeted. So here you can see how homogeneous and uniform as well as precise radiation planning can be done using motion freeze planning. And it also helps in decreasing the volume, the doses to lung, heart, esophagus. As from the graphs you can see, motion freeze plan is highly effective in decreasing even lung doses of V5, V15, V20. That is the amount of dose that is received by certain percentage of the lung tissue, as well as the heart, and you can see spinal cord. All organs can be even more effectively spared compared with 3D or 4D PET-CT with motion freeze technique. And after this, we have one more concept called adaptive planning. As we are seeing, every tumor doesn't stay the same volume when it is started, and radiation takes certainly long time, like it can be 4 to 6 weeks or 7 weeks based on how many fractions you are planning. So certainly if you are giving the radiation with initial planning, as a tumor keeps on getting irradiated, it definitely shrinks to certain volume, or it may change its geographical area based on its location. So to account for this, we have newer techniques called adaptive replanning or adaptive radiation therapy. This can be done in 3 ways, either with offline, where you manually do replanning, or with online, when you generate a cone beam CD on the machine itself and replan based on the differences and treat the patient on the machine itself. And there is one more concept called real-time adaptive replanning. So that is done on the machine itself and using artificial intelligence. So this can eliminate even the interfraction variations. So this is an example to show that at week 0, there is the start of the radiation, there is certain volume of tumor in the primary tumor, and after 4 weeks, you can see there is shrinkage of the tumor. So definitely, if you are giving the same radiation dose which was planned initially, you are radiating normal lung tissue also. And there is another ongoing radiation patient. At week 0, you can see there is around 6 centimeters of tumor in the lung, and after 3 weeks, it has shrunken to 3 centimeters, and volume is also shrunken tremendously, around 60%. So if we irradiate at the same volumes with high doses, definitely there will be chances of getting toxicity like a fibrosis, pneumonitis in later stages. So adaptive radiotherapy helps you decrease all these radiation-related toxicities, and this improves the quality of life. So what are the benefits of adaptive radiation therapy? It helps in decreasing the doses taken by the organs at risk. There is normal tissues, especially the lung, heart, esophagus, and spinal cord. So what are the future techniques that are being evolved? And one we are being here for a long time is the proton therapy, and the other, even more new technique, it is under trials, is the flash radiation. What if you combine both of them to treat lung cancers? Here there was a experimental trial that has been done to use proton therapy to develop flash radiations to irradiate the lung tumor. This has been done on an experimental basis. So here you can see proton itself can reduce a lot of side effects because of high pressure constraint to the doses, and there is no exit dose for the protons. And if you are adding flash radiation to it, it is even more beneficial by decreasing lot of normal tissue doses. As you can see it from the graphs, addition of flash has been very much beneficial to every other organ at risk. So take home points from all this is radiation has a crucial role in every stage of the lung cancers, and for metastatic lung cancer, radiation therapy can effectively palliate any symptomatic problems. And now there is an emerging role in the oligometastatic disease to look for curative intent. And there are newer techniques that can help us minimize the toxicity and also improve the quality of life. Thank you.
You made a complex subject into a simple one.
Thank you, sir.
I think many people may have questions. Yeah, somebody has a question. Yeah, but Ashok.
Good presentation. It was very exhaustive, considering that you had only 15 minutes and you've covered most of the major areas. I just want to make a comment on the adaptive radiotherapy in lung. It's very interesting. Unlike many other sites, the changes in the volume in lung is very apparent, and you are tempted to do adaptive. But there are two things to be considered for adaptive. First thing is that if a patient's tumor is shrinking, say at 20 gray, let us say, at that level, if you do an adaptation, there's very, very high likelihood the area that you have left behind is having microscopic disease which is not picked up on the CT scan. That's about it. Just because it is not seen on the CT scan doesn't mean the tumor is not there. At 20 gray, nothing will actually happen. It's just the consolidation that has moved out. And if you're adapting at this, say, range of 40 gray, let us say, at 40 gray, whatever lung you are sparing is already going to get fibrosed. So adaptation in lung, although it's very visibly attractive, possibly has got no clinical meaning. As a matter of fact, adaptation in any site has got no high-level data. All the hoo-ha about daily AI-based adaptation has got zero clinical evidence. So it is important to understand that just because it is showing up like that, you should not jump at it. Second thing is that if you ask me, is there any real place where I should adapt? If you have not been able to, for example, it's a very large T3, and you have not been able to achieve the V20 in your first week or second week, by third week there's a little bit of reduction in the size, and you decrease the size of the field to release a little bit of normal lung tolerance. That is possibly the only time you should adapt. Never ever chase the shrinkage of a tumor. That's all I want to say.
Thank you, sir. That's nice comments. As with adaptive radiotherapy, always there is a discussion with two schools of thought. So we have to keep watching how it can help. That's it. Yeah. Sure, sir. Thank you.
In lung, it may be problematic, but head and neck, yes, definitely.
In head and neck, I mean, this is not strictly part of this.
Especially after 40, 45. If, for example, in institutes like Perry's and Brady, they do adaptive radiotherapy
So let me tell this, sir.
to protect the parotid function.
So yes, I had the chance.
So that is a standard technique.
I will make it clear
head
for this, because there are few students here as well.
In head and neck, actually.
Yes, head and neck only. In head and neck, insofar as clinical outcome is concerned, there is zero evidence, absolutely zero. The only condition where you should adapt in head and neck is to reduce the dose to the parotid. That's all. That's
the only thing.
Only indication.
And especially if you are treating a hyperpharynx or anything,
Yes.
if the weight loss is more than
Yes.
10% or something, and you can observe that by seeing the mass. If the mass becomes loose, then do a re-CT, then
Yes,
you can
yes,
do
yes.
that.
It is only for
But
that.
in lung, it's very difficult to follow the tissue changes on a CT or anything, and we don't advise PET also because you have a lot of inflammation there. So these are all some of the problems we face in adaptive as far as lung is concerned. But head and neck, it's a standard.
Only for parotid dose, not for the tumor changes.
No, I'm telling you only for the parotid sparing, because it moves medially and it will come into the tumor, so you have to change the plan. That is in head and neck, it is standard, but in lung, it's a little bit problem. But otherwise, your slides are there, but have you seen a flash therapy?
Yes, sir. Only an experimental.
Pardon?
Only an experimental.
Where it is it? Which?
In European things.
Where
that's it.
in
I have only read. I didn't go there. I'm just following them because it's very interesting.
Okay, good. We'll discuss later on about that. Next speaker, I think.
Sure.
Is,
Thank you, everyone.
Thank you, sir. Now I request Dr. Bharat Chandra ji, Consultant Radiation Oncologist, Yashoda Hospital, Somajiguda, to discuss regarding management of brain metastasis. Thank you, sir.
Very good afternoon to everyone. I can do this. So I'll be talking about management of brain metastasis. Open full. So yes, just a brief epidemiology. 15 to 35% of all cancer patients during the course of their illness develop brain metastasis. And if you see in this graph, over the last 30 years, the incidence of brain metastasis has increased significantly. The two main factors contributing to this increased incidence is the increased use of MRI as a part of screening and evaluation. And second, improved systemic therapies, improved local therapies with radiation and surgery, which increase the overall survival of patients, ultimately increasing the chance of microscopic disease spreading to the brain. So brain metastasis is considered the most common intracranial malignancy, and each year approximately 2 lakh patients are being diagnosed. So the most common sites which spread to the brain are lung adenocarcinoma, small cell cancers, breast carcinoma, malignant melanomas, renal cell carcinomas, and colorectal tumors. So with this, there are certain recommendations when MRI brain is recommended as a part of screening in certain staged cancer patients, which is NSCLC lung adenocarcinoma stage 2 to stage 4 patients should undergo MRI brain as a part of screening. SCLC all stage patients, melanoma stage 3C and 4, stage 4 breast cancer patients, germ cell tumors with lung metastasis and alveolar soft part sarcoma patients are advised to have an MRI brain as a part of screening even when they are asymptomatic. So evaluation is key for any patient who is presenting with brain metastasis. Certain important clinical parameters have to be documented, like age of the patient, performance status based on Karnofsky's performance scale, symptoms, site, size, and number of brain metastasis. Need to document whether the tumor is in an eloquent area of the brain or a non-eloquent area, extracranial disease status, and systemic therapy options which are available. So all these clinical parameters, it's important for us to the treating physician to document. And based on these parameters, several prognostic indices have been developed right from 1997 to today. So as of today, the standard prognostic indices used is disease-specific molecular graded prognostic assessment tool, where it includes not only the clinical parameters, but also certain molecular mutations also. Like in NSCLC adenocarcinoma, age, KPS, number of brain metastasis, presence of extracranial disease, and EGFR ALK mutations have also been added in the prognostic system. And based on these factors, you rate it. If the patient's age is more than 60, it is 0. If it is 50 years and below, it is 1 point, and 50 to 60 is 0.5 point. So each of these prognostic factors have a score, and a cumulative score tells us the whole GPA of the patient. If you see patients having with GPA of more than 3.5, the survival rate is 4 years and more. So this is a very important tool which has to be used in all patients diagnosed with brain metastasis, which gives an estimate of overall survival so that we can plan treatments accordingly. What are the various treatments? Local therapies like surgical resection and radiation, systemic therapy, and best supportive care. So surgery, 3 categories of patients benefit from surgical resection with brain metastasis is: 1, patients with brain metastasis and with an unknown primary, where you need a tissue to diagnose the primary disease. 2nd, patients with a large tumor which cause significant mass effect, pressure symptoms, hydrocephalus, etc. You want to decompress the tumor. And 3rd is patients who have solitary brain metastasis. One of the randomized trials showed improvements in overall survival when there was surgical resection done followed by radiation in solitary brain metastasis. Coming to more than 2 brain metastasis, the true value of surgery is decided based on case-to-case discussion, taking into criteria of patient's preference, minimal intracranial and extracranial disease, and availability of active systemic therapy options which really cross the blood-brain barrier. So based on this, it's a case-to-case discussion. Radiation, the 3 primary techniques used in treating brain metastasis: 1, whole brain radiation; 2, whole brain radiation with hippocampal sparing technique with a drug called memantine, which is an NMDA receptor antagonist usually used in dementia patients, has been proven to improve certain neurocognition in patients undergoing whole brain radiation. And 3rd technique is stereotactic radiosurgery. Before I discuss on which techniques to use in which scenario, I'll just briefly explain you about these techniques. Whole brain radiation is a simple palliative technique where the entire brain is targeted to a certain dose of radiation, and the most important benefit of whole brain radiation is that it has a very good overall intracranial disease control. Whereas the downside, fatigue, alopecia, poor quality of life, and poor neurocognition. In hippocampal sparing whole brain radiation, hippocampal gyri is an area in the brain which is located quite deep in the temporal lobe, and primary function is learning, memory, spatial navigation, and emotions. So in preclinical studies, it has been proven that radiation to the hippocampal region causes neurocognitive decline. So newer radiation techniques like IMRT have been developed so as to spare the hippocampal region exclusively and trying to give the entire brain a similar dose of radiation. So one of the landmark trials published clearly compared patients with hippocampal sparing whole brain radiation versus whole brain radiation alone. Only criteria was all the tumors should be 5 mm away from the hippocampus. And this trial clearly showed that there was no clinical outcome difference when patients were treated with whole brain sparing versus whole brain RT alone. But there was significantly better neurocognitive outcomes in patients who received hippocampal avoidance whole brain radiation, and both the treatment arm received memantine as a drug. So yes, hippocampal avoidance radiation treatment is quite attractive here. So moving on to the third technique of radiation, which is the stereotactic radiosurgery, quite specialized technique where radiation exclusively focused only to the tumor, where you make a stereotactic mask for the patient for effective immobilization. And as you see, there is a stereotactic frame which helps us locate the tumor through X, Y, and Z coordinates. Then you contour the tumor and the critical structures around it, and radiation is focused so that the tumor gets the maximum dose and rest of the areas of the brain are very well spared. So moving on to the first area, post-operative radiation, post-surgical resection, it has been shown that without any adjuvant treatment, there is around 50 to 60% chance of local recurrence just with surgery alone. So radiation is to be given, but which form of radiation to be given? Multiple randomized controlled trials been published, but the summary of them is when comparing whole brain radiation versus SRS, patients with SRS treatments had a certainly better neurocognitive outcomes. Patients who received whole brain had better intracranial, overall intracranial disease control, but at the expense of a poorer quality of life. Important point to remember, both the arms had same survival. So valuing quality of life more than just poor quality of life, SRS alone is a preferred treatment option, especially in patients who undergo surgery with 1 or 2 resected brain metastasis, provided the volume of both the tumors is less than 20 cc. So moving on to the second scenario, which is unresected limited brain metastasis, which is 1 to 4 metastasis. One of the first trials done was RTOG trial, which compared patients who received only whole brain radiation versus whole brain radiation with SRS treatments. Conclusion, there was no survival benefit of adding SRS onto whole brain radiation. In fact, patients who had combination treatment had much deterioration of neurocognition. Then later, considering the results of the previous study, 4 clinical trials have been done which compared SRS alone versus SRS plus whole brain radiation. And here the outcomes were quite similar as in post-operative setting. SRS was giving a good neurocognitive outcomes, whereas whole brain radiation had better intracranial disease control. And the overall survival was the same. So here, based on the premise that majority of patients with same overall survival would prefer SRS and neurocognition as primary time to be living with a good quality of life. So SRS is a preferred option in limited brain metastasis 1 to 4. Then an important question comes up that with whole brain radiation giving a good intracranial disease control rate and with hippocampal sparing, there is good neurocognitive outcomes also. Why not, might not as well give just whole brain radiation with hippocampal avoidance? Unfortunately, there is no randomized control trials currently published comparing head-on SRS versus whole brain radiation with hippocampal sparing. The true trials ongoing, results might come at 2025 or so. So as of today, recommendation, limited brain metastasis, SRS is preferred. In more than 4 unresected brain metastases, multiple single-arm studies have shown that volume of metastasis matters more when compared to the number of metastases. And one of the Japanese study which compared 2 to 4 brain metastases versus 5 to 10 brain metastases in patients who received SRS, the overall survival was the same. The only key point here is to note that the cumulative volume of all tumors should be less than 20 cc to deliver SRS. So in more than 4 unresected brain metastases or more than 2 resected brain metastases, SRS or whole brain radiation with hippocampal avoidance or a combination is a reasonable treatment option. SRS is preferred in patients with a higher disease-specific GPA score, high performance status, good systemic therapy options available, tumor volume less than 20 cc, and life expectancy of more than 6 months. So where can radiation be avoided? One of the important trials published from UK is the QUAD study, which was done in lung cancer patients, which compared whole brain radiation versus best supportive care with just corticosteroids. It was a non-inferiority trial. 85% of patients of this trial had a GPA of 0 to 2, and there was no difference in both the treatment arms, even with adding whole brain radiation. So best supportive care is usually preferred in patients with poor performance status with KPS score less than 50, which is patients requiring medical assistance as well as frequent medical checkups, and or KPS less than 70, a patient without having any systemic therapy options. I'll just very briefly discuss on systemic therapy options in patients with brain metastasis. Systemic therapy obviously plays a vital role in metastatic brain disease, where chemotherapy stands still good in chemosensitive patients like small cell lung cancers, germ cell tumors, lymphomas. But newer age targeted agents, immunotherapy, have proven very good benefit in intracranial disease control, like in NSCLC, patients with EGFR mutation, osimertinib, icotinib proved a very good response rates in the lung. ALK positive patients, alectinib, brigatinib, ceritinib, I'm sure my next colleagues would be discussing on this. So multiple drugs have been developed and being showing a measurable disease response rates extending from 35 to 70% intracranially. So a lot of good systemic therapy options also available. So considering such a variety of drugs available, trying to give a good intracranial disease control, when can you defer a local therapy like surgery or radiation? All symptomatic brain metastasis patients should undergo local therapy. Only selective patients who are being planned for deferring local therapy have to go through a multidisciplinary tumor board, with factors being like asymptomatic brain metastasis, patient's preference, the tumor is not located in an eloquent area of the brain, there are very effective drugs which can cross the blood-brain barrier, and patient is willing for a close monitoring with a Q3 monthly MRI follow-up. Only after a discussion in the MDT, you would take a call of deferring local therapy. So take-home points, any patient with brain metastasis, prognosticating the patient is key. Surgical resection limited to diagnosis if in case it's an unknown primary, patients having pressure symptoms. SRS alone, yes, preferred, but we need to know there is a good neurocognitive function with SRS, but very high risk of extra, the rest of the area of the brain having recurrent with tumor. So surveillance is mandatory in all patients who are receiving SRS as a part of the treatment plan. Whole brain radiation, yes, with patients with poor or uncontrolled disease, best supportive care with very poor KPS patients. Thank you.
Very nice, very comprehensively explained. Any questions? Dr. Kaushik has a question. Very comprehensive.
I just want to know one thing. The 4 randomized trials that you mentioned where the whole brain RT was shown to be having the same overall survival as SRS. Now, is the overall survival in the SRS arm same in spite of having, I mean, you have also shown that the intracranial control was worse compared to whole brain RT. So does it mean that these patients underwent multiple SRSs, or when there's a intracranial relapse, what did you do for it?
So once there is any intracranial relapse, the time of relapse is also important. What is the time, the distance of previous radiation to the current recurrence point, and rest of the disease cranial status. Again, you would like to prognosticate the patient, and based on the location of the second recurrence and the treatment time, you can take.
So basically, the point is that even though the overall survival is same, it has come at the cost of multiple SRS.
Correct.
That's what I mean.
Correct.
So that is one of the expectations that should be fixed at the beginning of the SRS itself, that the patient may need repeat SRS.
Yes.
Because of, and that is the cost that you pay for maintaining the neurocognition.
Agreed.
That's true.
Asymptomatic brain mets. Accidentally detected during a workup of a carcinoma lung. Do you radiate? Or provided one more thing, they are driver mutations positive, EGFR positive, asymptomatic day one. On routine workup, there is a small brain met, but he is asymptomatic. Will you like to treat, or will you keep a follow? What do you?
First thing, the location of the brain metastasis. If it is in an eloquent area like the motor area, sensory area, Broca's, Wernicke's area, yes, we would like to.
Asymptomatic.
Yes, even in an asymptomatic disease, we would like to go ahead with local therapy. Second, like with a driver mutation having EGFR mutant where osimertinib is showing very good response rates in the brain, patient's preference and patient very much willing for active surveillance post or during the systemic therapy. Only then, after discussing and deciding in a tumor board, you would think of wait and watch.
I think Harish had explained it in the morning session that, in an asymptomatic patient, now the paradigm is shifting from treating versus observation, especially in driver mutation positive. When he also explained about why the MRI should be done for driver mutation patient. So, absolutely asymptomatic patient, and when we have got drugs which have good CNS penetration, these are the patient actually the current recommendation is to observe. So that is one.
One more thing is that these patients likely have patients with the driver mutation ALK and with the type 1 osimertinib types. The presentation is also somewhat different from patients who don't. They tend to have like miliary kind of metastasis. They will have 6, 7, 8, 10 small metastases, which even if you see on the MRI, you will not be able to effectively treat them with SRS. So you just keep on observing them and continuing the systemic therapy. If you have progression in any of them, then you, depending on the site and location, type of the progression, you choose.
Agreed.
That is a major paradigm shift insofar as
prophylactic cranial RT. Now, do you give it in all patients, or there was a data that still the other arm you could still monitor and keep a close follow-up? So what is, for small cell carcinoma lung, prophylactic cranial RT? Small cell carcinoma lung, that is what small cell.
As of today, for limited stage, yes, we do give prophylactic cranial for all patients.
But there is a debate going on whether to do or not in small cell. Some people, there is a controversy that you can avoid.
Provided if the patient is ready for a stringent follow-up, the Japanese study.
To prevent brain mets, the routine practice is to give the radiotherapy. But one more thing, I just want Nikhil as a question. If a patient is asymptomatic, on a routine evaluation he has come, then there are multiple mets, multiple small mets. The whole volume is less than 20 cc, and the patient's performance status, everything is good. He is asymptomatic. And then, if that is the thing, if it is a lung cancer, do you advise a biopsy of the lung lesion plus the brain lesion, or you will just go by the lung lesion alone in determining the molecule which you choose, which is supposed to enter the CNS cells?
So if I understand your question correctly, whether we need biopsies from both the places, is that correct?
Yeah. Is it?
Okay, so we would still go with its initial diagnosis, we'll still go for only primary lung biopsy. We normally refrain ourselves from brain biopsy. Having said that, there is a lot of new data which is coming in terms of liquid biopsies, right? Something which sometimes we come across some mutations which can picked up even on the liquid biopsy. Having said that, we don't do it upfront for most of the patients, but for subsequent progression, we can consider doing that. So I would currently consider doing a biopsy for the brain for now.
Because
What he's trying to,
sometimes,
yes,
sometimes it differs.
Yes. So what he's trying to point is that whether the brain metastasis is sharing the same driver mutation as the thing. I think unless otherwise proven as a clinical progression, you take it as the same.
So the situation is different when it involves the other part of the body, where the biopsy site might be accessible. But in the brain, routinely it is something which is not done.
For de novo,
For
single
example,
biopsy is good enough. If you recur.
Recently, we had a patient who was treated, he was a smoker, and he was treated for Koch's disease earlier, and subsequently he developed a lung cancer, and the adenocarcinoma stage 3B locally, but when we did a MRI, he had asymptomatic as well as the brain is concerned, but one of the lesions was about 2 centimeters, and then we did a biopsy of the brain lesion as well as this. This is a term as adeno. That came as a tuberculosis. Even in our country.
Sir, these are anecdotal or once a while cases. That is what is.
These things are.
Sir, what
you see this?
Sir, what we do is upfront. If you have multiple sites, you take it from the site which is most accessible, most safe. Can do driver mutation because it doesn't change. The problem comes once it recurs. So ideally, if there is a new site of lesion, then you do it from
It is
first
synchronous.
line. It is good enough.
Synchronous.
Sir, then it
One
is
more
good.
thing. What is the policy? You do a biopsy of the brain lesion or no? You don't.
No.
You just do
Yeah.
the.
Unless what you said, there is a diagnostic dilemma that it is TB plus. Otherwise, we don't do it. Most of the time, MRI now picks up most of the choline uptake, the ratio they take it. So more or less. But yes, if there is a doubt, then otherwise we don't do it.
Okay, Bharat. Any other question, clarification or anything?
Sir, we'll do it later because we are running short of time.
Yeah. Okay,
Thank
thank
you.
you. Take over.
Thank you, sir. Thank you, ma'am. We move on to our next panel, this case-based panel discussion. I invite Dr. Kiran Kumar K. Sir, Senior Consultant Radiation Oncology, Yashoda Hospital, to join us as a moderator for the panel discussion. Now, I invite our panelists to join us on the dais for the discussion. Dr. Yugandhar Sharma, sir, HOD Radiation Oncology, Renova Saumya, Hyderabad. Dr. Monica Malik, Associate Professor, Radiation Oncology, NIMS, Hyderabad. Dr. Deepthi, Associate Professor, Radiation Oncology, NIMS, Hyderabad. Please join us. Thank you.
Good afternoon to you all. I am Dr. Kiran, and we are running out of time. I will be very precise and just confine my topic to as a radiation oncologist. What as a radiation oncologist would like to look into the case and how to proceed the case. Yes, we have two cases. The first one is an early lung cancer, and the second case would be of a stage 3 lung cancer. Initially, I thought I'll include a lot of slides, but in the presentation given by Vishweshwaran, this has clearly explained like how to investigate a case and how to do a metastatic workup in case of early stage lung cancers. Yes. His first case, he's an 82-year-old gentleman, with a known hypertension and diabetes, on medication, is a hypothyroidism. Is a COPD for which he is on medication and had met with a road traffic accident. This is our own case which we have treated in our hospital. As a part of investigation, a chest X-ray was done and it showed a right lower lobe small opacity for which he was investigated further with a CT scan. and CT scan showed that there is a small lesion of size 1.8 centimeters in the right lower lobe. And the CT is reported as a 1.58 centimeter lesion in the right lower lobe with a irregular margin which is enhancing with the contrast. And one more node is seen, which is 1.5 centimeter in the right hilar lesion, which is lymph nodal station 10, which is non-enhancing on the contrast. So as a part of metastatic workup, the first step would be to do a PET scan to see is there any disease elsewhere, extrathoracic or not, and it has confirmed that there is a lesion in the right lower lobe. But to the surprise that the PET scan did not show any uptake in the hilar region, so which is a non-evid uptake. So the next step would be to do the EBUS, which was being discussed in the morning session. So EBUS was done for this patient, and FNAC from the R station 10 on the right side showed that it is negative for malignancy, and CT guided biopsy from the primary tumor is reported as adenocarcinoma. As a part of metastatic workup for all adenocarcinomas, we need to do an MRI brain to rule out the metastatic disease to the brain, and it's staged as T1B. So now I'd like to ask the panelist, the first one would be Dr. Yugender Sharma. So we have done all the metastatic workup, and it is diagnosed to have a stage 1, T1B. So the surgery part is also been discussed in the morning, and usually the surgical option would be the surgery is the first option. Whenever it is operable, probably the surgery, because we don't have any evidence or any data supporting that it is SBRT is a non-inferior to surgery that has been discussed by Dr. Kaushik sir. And so in order for the patient to be a fit for the surgery, patient should have a lung functional test which should be like FEV1 should be greater than 1.6 liter, or the predicted value should be greater than 60%. But for this patient, FEV1 is 0.8 liter and the DLCY is 40% of the predicted. So this guy is unfit for surgery. So what you would like to do, how you proceed clinically when you're sitting in the OPD, and what additional investigation would you like to do, and what additional information would you like to know from the patient, and what is the best treatment options other than the surgery for him? So we have 3 options. So
yeah, obviously this is an early stage lung cancer. The patient is 82-year-old. I assume that the performance status is good.
Yes, the performance is 1.
Yeah, if the performance status is good, I would straight away offer him stereotactic SABR for the patient, SBRT for the patient. So, because all the information which you have given puts him an ideal candidate, and the location of the tumor is also away from the critical structures.
Okay. Do you look into do you have any cutoff point for to give radiation for this patient, like as far as PFT is concerned?
No. For SBRT, I think PFT, the FEV1 more than 0.5 is good enough for SABR.
So absolutely there's no specific cutoff points to consider for the SABR, but it's all individualized, and even for those patients with FEV or DLCY less than 40% are usually taken up for SBRT. So how do you proceed? Like how do you mobilize the patient, and what technique do you want to follow?
So some sort of respiratory motion management is required. I would ideally...
Yes, but how do you decide like which patient is fit for what form of motion management techniques? Like usually in your practice, what do you follow? Like what motion management techniques you follow?
So I have, we at our center, we do either DIBH depending upon the tolerability of the patient, or a 4D gating, respiratory motion management.
Okay.
In our previous center, we used to do respiratory synchrony using the CyberKnife.
But what dose fractionation? Like how do you decide?
For this size of the lesion, I would say I would go ahead with 16:3.
Okay. So And this is a small, like, this was discussed by Dr. Kaushik sir. I just want to skip it. And this was 2 small trials, Rosalind Stars, and the pooled analysis had very low numbers, and that is the reason why the surgery is the first line in the management of small tumors, which are operable tumors. And this is the meta-analysis comparing the SABRE with the surgical series, and it clearly showed that for all those for all those tumors which are operable, probably needs to undergo surgical resection, and the SABRE will be always a second line. So if the patient is not able to cooperate for the deep inspiratory breath hold, and there is no option of 4D CT for the patient, for option, then what next, how to proceed for the, Dr. Monica madam will probably suppose is not able to tolerate the DABH because he's not able to hold the breath for a couple of seconds, like 15 or 20 seconds, and there are no other 4D techniques, 4D CTs available. So what would be the best option for this patient?
So 1.8 centimeter tumor, it would still be okay to give him additional margin to account for the respiratory motion and still treat with SBRT.
So you mean to say that you want to treat in a free breathing CT?
If you don't have any other options, then yes, because even with the margin, you will still be, the ultimate target volume would still be treated with SBRT, and it is not a central tumor, it is not a tumor in contact with the chest wall, so ultimately the toxicity is expected even with that would be quite low in this patient.
So do you consider any chart for this patient, like, is there, or still you want to go with SBRT only?
No, from the dosimetric, the BED and the comparative studies between conventional and SBRT, we know that SBRT definitely has better outcomes in terms of local control, so that would be the preferred option.
I think you are right, madam. But like delivering a high dose in a small number of fractionation, probably a BD greater than 100 is more superior compared with that of the chart or the conventional fractionation. So this is a trial. I mean, how was it done?
So basically, like, just wanted to add that we keep saying that there is no evidence SBRT versus surgery, but we do have one small randomized evidence which actually showed advantage for SBRT, and there is a huge amount of retrospective evidence and tens of thousands of patients who have been treated with SBRT, who have been studied and have actually shown very good local control rates, and at least in stage 1 lung cancer, even in the meta-analysis, there was no difference in lobectomy versus SBRT.
But the problem is that the trial is too small and it is not
The trial is too small. The meta-analysis, the retrospective series and everything, where there are tens of thousands of patients also, stage 1 lung cancer, no difference in SBRT versus surgery. Stage 2 onwards, yes, surgery was a better option. And these were again all the retrospective bias, even with the propensity matching, there was a lot of heterogeneity in the meta-analysis also.
Yes.
This is a very important point that you have made, Dr. Monica. All the retrospective trials, or even the single arms prospective which have been compared in the propensity matched analysis also, obviously all the patients for SABRE were the ones which were medically unfit. And what has not been addressed in these trials is the post-operative morbidity, the duration of admission, etc. That if you compare especially, and especially patients with slightly poor pulmonary reserve and age, there is absolutely no comparison between SBRT toxicity versus surgical toxicity. SBRT wins hands down. I agree with the fact that there is no high-level evidence, but that doesn't mean that surgery is superior. That is a thing that one should clearly get out of the mind. And SBRT should be happily employed. The thing is that it is a difficult thing to do. So that is the only thing. But this patient is going to be very easy.
Very small.
And in this meta-analysis also, they clearly said that stage 1 lung cancer, no difference.
No difference, absolutely.
So So it has to be individualized and customized to our patients, taking into account the lung reserves and all those things. So this is the SPACE trial, like comparing SBRT with the conventional. Always the SBRT is superior because we push more dose. The BED is more with SBRT compared with the conventional. And this one more trial, the CHISEL trial, which you compared with 54 grain 3 fraction with the conventional fractionation, which is always SBRT is superior. So the dose fractionation, as by Dr. Yugendra Sharma said, that it all depends upon the location of the tumor, the technique which we have been using it, and these tumors have been divided into the peripheral, the central, and ultracentral tumors. One which is away 2 centimeters away from the black dotted line is 2 centimeters away from the primary bronchus. If the GTV is outside this black line, probably these are the peripheral tumors where we give high dose and there are no other critical structures if you give a margin to our primary tumor. And if the margin is within this 2 centimeters from the peripheral bronchus, then we call it as the central lesions. And if the lesion is in the close or less than 1 centimeters from this main bronchus, probably we call it as a ultracentral lesions. So ultracentral lesions are usually unfit for SABR, and usually if it is a peripheral lesion, we give like 54 grain 3 fractions or 60 grain 3 fractions. But if it is in the central lesion, that is 2 centimeters away from within the 2 centimeters, then the dose fractionation would be somewhere 60 gray in 5 fractions, or it can be 60 gray in 8 fractions with 7.5 gray per fraction. But for those lesions which are very close or less than 1 centimeters from the main bronchus, trachea, esophagus, greater vessels, probably these patients are unfit for the SBRT. So there are different motion management techniques. I think this has been addressed by Dr. Pradeep, and most commonly which we use is either we use a 4D CT scan or a deep inspiratory breath hold. And this is published in Red Journal, stating that any dose beyond 100 BED seems to be a good enough dose for the local control. Anything beyond like 120, 130 is of not that much beneficial, and a minimum of 100 BED has to be delivered in whatever fractionation we are giving it in a SBRTs. Deep inspiratory breath hold, this is used for the patients who can hold, take a deep breath and hold for a minimum of 15 to 20 seconds, and the CT scan is acquired during the phase of that particular respiration, and the treatment is also delivered during the particular phase of respiration. And this is particularly useful for the lesions which usually move greater than 1 centimeter. That means for those tumors which are lower lobe tumors or whatever, wherever the location is, if the movement of the tumor is with the respiration is greater than 1 centimeter, probably the DABH is most useful for such patients. And this is a 4D CT. If the movement of the tumor is somewhere between 0.5 to 1 centimeter, and there is no need for us to really to go to the 4D CT, acquire the data and the deep inspiratory breath hold, and we can do it in the 4D CT where the time is taken into the factor, and CT scan is acquired in 4-dimension way, and we can deliver it off. And if the chest wall movement or the tumor is less than 5 centimeter, probably we can do it off in a conventional free breathing CT scan. There are no CTV margins, we only give a PTV margins, and different fractionation schedule has different OIR doses, and that has to be taken into account before we approve the plan. We need to take into account the tracheal dose and the brachial plexus, the chest wall dose, the heart and the pericardial dose. And the different fractionation schedule is 54 grain 3 fractions, and or for the peripheral lesions it's 55/5 or 16/5, or if it is a central lesion it is 60 grain 8 fractions. The follow-up is usually 4 to 6 weeks for the acute toxicity assessment, and in the first year it is three monthly once, and it is 6 monthly in the subsequent years, and the patient has to be followed for 5 years. And we'll go to the second case. It's a 65-year-old gentleman. was investigated for cough and weight loss, history of smoking. CT was confirmed with no disease elsewhere in the body. EBUS was done to confirm whether the node is positive for the disease or not. And the biopsy showed us the poorly differentiated adenocarcinoma. MRI brain was normal. Because of it is adenocarcinoma, we need to do it. And the lung functional test is like FEV1 is 2.35 liters, and the transfer factor, that is DLCO, is 60%. And so this is basic. So how to optimize the patients for radical radiation is that we need to do a PET scan. The PET scan should be done within 6 weeks before for us to plan. Like if it is beyond 6 weeks, probably we need to do a repeat metastatic workup with a PET scan. And all nodes, even if it is PET negative, probably we need to reconfirm with EBUS to see what is the nodal stage. Nodal station is a positive or not. And we need to take into account the number of other factors like lung fibrosis and autoimmune conditions. And we should never exclude radiotherapy. It's a relative indication, but based upon the PFT findings. And we should be cautious and start off some pneumocystis prophylaxis for those patients who are on lung RT if the patient developed leukopenia. And for all stage 3 patients, probably we need to add the PDL1 testing on biopsy sample. So, like now this is a case of 65 very fit gentlemen, with good PFT function and the PDL1 greater than 1%. How do you like to manage, Dr. Deepti?
Concurrent chemoradiation.
How do you justify and so you can select one of the options and so how do you proceed? Like this patient is like a fit gentleman with a solitary N2 disease. Would you like to, what you do practice?
I would like, because it is an N2 disease and patient is fit, even then I would not like to include surgery in this treatment option. So I would like to go with concurrent chemoradiation followed by adjuvant chemotherapy. Or if PDL1 is positive, adjuvant immunotherapy.
So, but the surgical oncologist is very much wants to convince you that it's a solitary N2 disease, and surgery is. How do you like justify your statement? Is there anything or any other additional things which you want to consider for this patient, Dr. Monica? Madam.
Durvalumab has shown survival benefit in these patients. So that would be one of the standard recommendations following the chemoradiation. As regards surgery, again, the trials have not shown any difference in outcomes with chemoradiation versus surgery. And so the only candidates, again, this has to be an individualized decision based on the performance status, the comorbidities, and ultimately they should be candidates for a lobectomy, not a pneumonectomy.
So your preference would be like to start off concurrent chemotherapy radiation. But do you consider any other things like is the patient, how do you justify, like you go with the concurrent chemotherapy RT or do you want to go to sequential? How do you differentiate sitting in OP that this guy goes for a concurrent chemo RT or we need to go for a sequential chemotherapy radiation?
So,
is there anything?
Yeah, so this is a T2 disease with a single station N2 node. He would be a good candidate for upfront concurrent chemoradiotherapy. The only indications where we would consider neoadjuvant is if it is a T3 or a T4 lesion or multiple mediastinal lymph node stations which are involved, in which case it is very difficult to deliver the radiation doses to within the tolerance of the lung and other organs.
Yes, so that's what we're expecting an answer from you, that if when we are starting a concurrent chemotherapy radiation, probably the OR dose, whatever the lung receives, should be within the tolerable limits so that we can take up the patient for concurrent chemotherapy radiation followed by adjuvant therapy. But the immunotherapy, the immunotherapy is only used for those patients who have been started upfront with chemotherapy radiation and not for those patients who have been on a sequential therapy. Okay, Dr. Yugandhar Sharma. Now this patient has been subjected to surgery and because our surgeon is very curious and he wanted to do surgery, and we cannot say no to him because still he's a fit as far as the lung reserves and the cardiac function is concerned. And this patient went for surgery, and it is reported as PT2N1. So what do you do? What therapy? You want to give radiation, or you want to keep a follow-up? What is your advice to the patient?
I would follow up him with adjuvant chemotherapy.
Yes, and when you will consider for a adjuvant radiation for this in a post-op setting?
Adjuvant radiation is indicated only when there are positive margins.
Yes.
Or an N2 disease.
Yes, N2 disease is somewhat controversial still, and now the recent lung RT trial, I think probably is, if you say that it's to avoid radiation in the N2 disease because it has been removed and it has been attached by the chemotherapy. There is a slight controversial, but it has to be again customized according to the patient whether he's really fit to go for again a sequential therapy. So is there any situation where post-surgery would like to treat sequential therapies, or it is a concurrent chemo RT if it is a positive margin? How do you want to proceed?
I would probably do only radiotherapy rather than concurrent chemoradiotherapy in the post-operative setting.
Yes.
With a positive margin.
Yes, you are right. And post-operative setting is always the sequential therapy rather than a concurrent setting because it is too toxic to the patient. So all these options which have been shown on the slide, like surgery followed by chemotherapy, is a decent option. Not a decent option, is one of the options which we cannot say no. And I think the chemotherapy part, the medical oncologist will talk about, and NSCT followed by surgery is also an option. It has been recommended by the NICE-2, and NSCT with with RT, CCRT, concurrent chemotherapy RT followed by surgery is also an option. And for those patients where where a PD-L1 is positive and you want to give the benefit of immunotherapy, probably those patients which should be started on a CCRT followed by the chemotherapy. And otherwise, the standard of care of concurrent chemotherapy radiation followed by whatever 4 cycles of adjuvant chemo. Sequential chemotherapy is used for those patients which are unfit for concurrent therapies, like for the patient with a performance of somewhat 2, where the performance is less than 2, probably those patients, I think, has to go for a sequential therapy. And always a management of a single station N2 disease is a complex, and there is no exact consensus. It varies from physician to physician, and it has to be customized to the patient and individualized to the particular case scenario, because no 2 patients are equal. So it's always we use IMRT or VMAT with emotional management assessment, and there is no prophylactic nodal irradiation as said by discussed by Dr. Kaushik sir. And we should have an onboard cone beam CT to see the response or to see how the tumor is moving. And this is a LACE trial, like in a post-operative setting. Adjuvant chemo is given if it is greater than 4 centimeters, and in a post-operative setting, it is only given in case of positive cut margins, and the lung RT trial states that we can avoid radiation in N2. And this is the study showing that surgery versus chemo in N2 disease, probably induction chemotherapy plus cisplatin etoposide of 45 gray followed by surgery and radiation, I think is a reasonable options if you want to really consider for our patient, any of the patients. And the thing is that for those patients where the lobectomy is done, it is superior, but not for pneumonectomy patients. So consider neoadjuvant chemotherapy and radiation followed by surgery in a single station N2 disease provided lobectomy is done. And this is a non-inferior trial comparing for those patients who are operable, probably either we can go for surgery or chemotherapy post. Chemoradiotherapy followed by surgery is a non-inferior trial, and if you want, we can consider the same. And is regarding the immunotherapy, where the 5 years data is that the overall survival is for the durvalumab was 63.1 months compared with the standard arm of 29.6 months. and when to use like sequentially, it all depends upon the tumor volume, and it all depends upon the lung reserve, and if we are really able to achieve the dose constraint which have been prescribed, then probably we can start the radiation and chemotherapy in the first cycle. Otherwise, we need to start off the sequential therapy of chemotherapy, then followed by sandwiching either at the end of the treatment, or once we are able to really shrink the tumor size, probably we can add. But always we need to add radiation at the earliest instead of waiting for the completion of 6 cycles of chemotherapy. And sequential therapy, yes, if the patient performance is 2 and who are not fit for concomitant chemotherapy radiation, probably we push off chemotherapy and add at the end of the chemotherapy of completion of 6 cycles. Outcome, it is overall survival rate is 5% to 20% at the end of 5 years. And I think we'll thank you, Dr. Yugandhar Sharma and Dr. Monica Madam and Dr. Deepti for taking part. Thank you.
Thank you, sir. Thank you, ma'am. Now, I request Dr. Nalini, ma'am, to join us on the dais to present mementos to our speakers and panelists. I would like to invite Dr. Kaushik Bhattacharya, sir, on the dais. Dr. Pradeep Kumar, sir. Dr. Bharat Chandra, sir. Dr. Kiran Kumar, sir. Dr. Yugandhar Sharma, sir, please join us on the dais. Dr. Monica ma'am. Dr. Deepti ma'am, please join us on the dais. Now I request Dr. Nikhil sir to join in the dais to present a memento to Dr. Nalini ma'am. We'll move on to the next session. I request Dr. Balasubramaniam KR sir to chair the session. Please join us on the dais, sir. I hope sir is not here now. We'll start with the next topic. I invite Dr. Shikhar Kumar sir, Consultant Medical Oncologist, Onco Cancer Care, Hyderabad, to discuss regarding recent advances in neoadjuvant and adjuvant therapy in lung cancer. Thank you.
I would like to thank Nikhil sir and the organizers for inviting me on this platform to talk about the recent developments in neoadjuvant and adjuvant therapies in lung cancer. I will restrict myself to non-small cell lung cancer. So I did not know that there will be people from non-oncology background in the meeting. So please excuse me, I will be presenting a technical talk, and those from non-oncology backgrounds are free to let their minds wander. Okay, so first I'll talk about the room for improvement as far as the current survival outcomes in non-small cell lung cancers are concerned. I'll talk about the trials which led to the status that where we are at today, that is the Checkmate 816 trial in the neoadjuvant setting. Then I'll talk about the recent trials in the adjuvant setting, that is the IMpower 010 trial and the Keynote 091 trial. I'll give my views on the pros and cons of the adjuvant or the neoadjuvant approach. And finally, the big debate, the ADAURA trial. What is the recent development from the ADAURA trial and what are my views? And finally, we'll conclude. So what is the current outcomes for non-small cell lung cancers? We know that this is a very aggressive disease. And even in early stage non-small cell lung cancers, you can see that even for stage 1B, stage 2A, which are early stage patients, the 5-year survival outcomes are not satisfactory, in fact, far from it. You can see the outcomes for stage 3A disease, that 5-year survival is only 41%. That means that 60% of patients will not survive at the 5-year time point, even if they have resectable stage 3A disease. And this is where the role of improving their outcomes via either neoadjuvant or adjuvant therapies comes in. This is the entire treatment pathway for a person who is diagnosed with early lung cancer. First, you improve the detection rates of early lung cancer by implementing screening methods, and then we'll talk about neoadjuvant and adjuvant therapies subsequently. So what is the advantage of neoadjuvant therapy is that very early in the disease trajectory, you get to know how the tumor is responding to systemic therapy by two means. One is by radiological response, which is what we have all been doing for other cancers. And the second is pathological response, that is when the tumor is resected by the surgeon, we see in vivo exactly how much response has happened to what treatment the patient has received until then. And if you add an immune checkpoint inhibition to the neoadjuvant backbone, probably you have better responses because the tumor is still in situ and the bulk of the antigens are present, so you have a better response as opposed to the adjuvant setting, and this is what is being reflected even in the data as well. So now if you see the early trials that were done before immune checkpoint therapy came into the picture for in the neoadjuvant setting, these trials, they were underpowered, they were done in unselected populations, they did not select out the driver mutated patients, and they failed to show any DFS benefit for induction chemotherapy versus only going for directly upfront surgery. Now, why I have put a picture of a unicorn is because as children, we all dream of seeing a unicorn, and as adults, we all want to be invested in unicorns, but we know that that is very wishful thinking, that's unlikely to happen, and trying to achieve a pathological complete response with only neoadjuvant chemotherapy is very unlikely. You can see that the only a median of only 4% of patients achieve a pathological complete response if you were to blast them with 3 to 4 cycles of chemotherapy prior to surgery, and these rates are not very confidence inspiring as far as only chemotherapy is concerned. So then investigators wanted to look around and see whether they can have some other endpoint apart from pathological complete response. And this was a landmark publication from the Hellman group which coined a new entity known as major pathological response, in which you have less than equal to 10% viable tumor cells after neoadjuvant chemotherapy. And what they showed is that this major pathological response, we will use the word, acronym MPR henceforth, this could be a surrogate endpoint for the clinical trials which are studying neoadjuvant therapies. So now let us look at how the trials have evolved in the neoadjuvant setting, and let us look at the neoadjuvant IO monotherapy, that is only single agent immune checkpoint in the neoadjuvant setting. This was the first landmark trial from the Ford et al. Group. It was a pilot study of just 21 patients, and only 2 doses of nivolumab were given in resectable stage 1 to 3A non-small cell lung cancers. And you can see that major path responses were seen in 45% of patients. So small study, but yes, the earliest hint came that yes, immune checkpoint inhibition in the neoadjuvant setting does work, and you have better responses than what you saw with chemotherapy alone. But of course, being a small trial, this did not find any difference between PD-L1 positive or PD-L1 negative patients in this study. What is a little bit unusual if you treat only with IO monotherapy, and this we know that is true of other cancers as well, is that radiological responses do not correlate with pathological responses. So you can see on the left-hand side, this patient who was given 2 doses of nivolumab, the tumor shrank and there was cavitation in the tumor. But once the tumor was resected, the patient was found to have achieved a pathological complete response. And on the other hand side, on the patient number 5, you can see that after nivolumab, the tumor seems to have enlarged in size and there is progression as per the CT scan. But once the tumor was resected, the patient was found to have achieved a major pathological response. Then a larger study was done with atezolizumab of around 180 patients. And here again, just 2 doses of atezolizumab were given. And here you saw major path responses of around 21% odd. So yes, the data was promising, but yes, there was more scope for improvement. So then investigators wanted to see what will happen if you combine 2 IO agents. That is one blocking the PD-L1 axis and one blocking the CTLA4 axis. And this is the only trial that I could find in this regard, which was a randomized phase 2 study. But again, it was a very small study. Arm A received only nivolumab and Arm B received nivo and ipilimumab combination. Being a small study, its endpoint was only major path response. And we saw that yes, by combining nivo and ipilimumab, you had better major path response and path CR rates than those patients who received only nivolumab monotherapy. You can see that around 19% patients achieved MPR and path CR in the nivo arm, and around 44% patients, they achieved MPR and path CR in the combination arm. So yes, the early signals had come, but now there was time for trying to do something better. And in this regard, it is the trials which have combined chemotherapy and immunotherapy, which in my opinion have provided the best outcomes to date. And this was the first trial. It was again a single arm phase 2 trial of only 30 patients. But look at the response rates. They gave 4 cycles of chemo with atezolizumab, and you have 57% patients achieving a major path response, 1 in 3 patients, that is 33%, achieving a pathological complete response. So these kind of response rates were not seen or heard till now in trials which gave only IO or IO doublets. And this was the trial that really caught everybody's attention, the NADIM trial. And it is interesting to note is that almost half of the patients in this trial, they had N2 disease. And we were just discussing in the panel discussion earlier that N2 disease should not be taken up for surgery. But in fact, all these patients, almost all of these N2 patients, they successfully underwent R0 resection. And if you see, these kind of response rates were never heard of. Pathological complete response in 63%, major path response in 83%, and those red triangles, those are patients who eventually had disease progression. And you can see that the most of the disease progressors were in patients who were not resected, or those who had an incomplete response. But if you see the dark blue and the light blue bars at the bottom, hardly anybody progressed in patients who had a good pathological response after neoadjuvant nivo plus chemotherapy. And this set the landmark, this set the basis for the phase 3 trial, which is what we are going to discuss in a little bit more detail. That is the Checkmate 816 trial. So this was a randomized trial. Its endpoint was not just pathological complete response, but also event-free survival, as any phase 3 trial should have. It took stage 1B to 3A patients, and it excluded patients who had EGFR ALK driver mutations. And the arm A, the control arm received only chemotherapy. The experimental arm received 3 doses of nivolumab with chemotherapy. After receiving neoadjuvant, patients were again restaged, and then they underwent surgery. After surgery, chemotherapy in the adjuvant setting was optional. Very few patients received chemotherapy after surgery. So let us look at the pathological complete response, which was one of the main primary endpoints. As expected, the chemotherapy arm had very poor response rates. Only 2% patients had a path CR, but 24% patients in the nivo chemo arm achieved a path CR. So this was quite impressive. Even the major path response rates improved from 9% to 37%. So the first primary endpoint was achieved, that yes, path CR rates are vastly superior if you combine nivolumab with chemotherapy, and this was all the more impressive because only 3 doses of nivolumab were used. If you see the path CR rates by the disease stage, yes, all stages they had benefit. And interestingly, this study also did ctDNA analysis, that is liquid biopsy, And patients who cleared the ctDNA prior to starting cycle 3, they had much better pathological complete response rates. You can see that the Nivo chemo arm had 46% PathCR rates in patients who were who had cleared the ctDNA. Even patients, because you had better responses, fewer patients required more extensive surgery. So fewer patients required pneumonectomies, and more patients were able to undergo minimally invasive surgery in the Nivo chemotherapy arm. The other co-primary endpoint also was positive, that is event-free survival. You can see that the chemotherapy arm had a median EFS of only 20.8 months, and this was improved to 31.6 months in the Nivo chemo arm. Again, the EFS analysis as per PathCR, again, it was as expected. Patients who don't achieve PathCR don't have good long-term survival. Patients who achieve PathCR, they had a good long-term event-free survival. What is interesting to me is that the subgroup analysis showed benefit in all patients, but as reflecting what we know in the metastatic setting, patients who had low PD-L1 of less than 1% did not derive as much benefit as those who had high PD-L1, that is more than 1%, and patients who had very high PD-L1, that is more than 50%, derived the maximum benefit with the best hazard ratio of 0.24. So what was not seen in the earlier trials of the single arm studies was now shown in the larger trial, that patients, the more PD-L1, the more positive they are for PD-L1, the better they are likely to respond in terms of long-term prognosis with nivolumab in the neoadjuvant setting. What are the current challenges with this approach? That you want to give nivolumab plus chemo in the neoadjuvant setting is that you have to test for EGFR and ALK because you have to rule out those patients. That will cause further delay, and you will waste valuable time in deciding whether to go for the nivolumab approach in the neoadjuvant or not. There are some studies which show that probably you also should test for STK11 and KEAP1 mutations because these patients have poorer responses to immunotherapy. This will cause more delay because then you will need an NGS panel to test these mutations. Early progressors, patients who were initially fit for surgery, but after you gave them IO chemo, around 6% patients progressed. So these patients who are potentially curable, now you are dooming them to palliative treatment, and this might be a concern in a very small subgroup. And we still don't know that whether event-free survival will correlate to overall survival. So this is still an open question. Oncogene-addicted NSCLC in the neoadjuvant setting, I will not waste much time in this because there have not been any major studies which have tried to tackle this question as of now. The NEO-ADAURA trial is going on, so once the data is out, we will see that. But this small trial did not show any benefit with neoadjuvant erlotinib prior to surgery. So now let's come to adjuvant immunotherapy. We have all seen the LACE meta-analysis data so far that yes, if the patient is operated upfront, then giving chemotherapy does help, but the benefit is quite small. You have an absolute 5-year survival benefit of only 5%, and that too it was probably only for stage 2 and stage 3A patients. Stage 1B patients probably do not benefit from adjuvant chemotherapy. They have been, and now unlike the neoadjuvant setting, I did not find any phase 1 or phase 2 trials. Directly 2 phase 3 trials were launched in the adjuvant immunotherapy setting. One was with atezolizumab, that is the IMpower 010. The other was with pembrolizumab, that is the Keynote 091. There are some small differences in the way these trials were designed. What IMpower 010 did is it took all stage 1B to 3A patients and gave chemotherapy to everybody after surgery. And then they randomized between 1 year of atezolizumab versus best supportive care. What Keynote 091 did is, again it took stage 1B to stage 3A patients after surgery. It did not mandate adjuvant chemotherapy, although almost 85% plus patients received chemotherapy, and it randomized them between 1 year of pembrolizumab versus placebo. So we'll see how that might have impacted the outcome data. Key flaw of these trials is that they did not mandate EGFR ALK testing. So many patients did not have EGFR ALK status known when they were being enrolled in this trial. Both trials had disease-free survival as a primary endpoint because overall survival endpoint is difficult to achieve in the adjuvant setting. So let us look at the IMpower 010 data. If you look at the IMpower 010 in the PD-L1 more than 1% population, which was one of their key primary endpoint, the trial was positive for this. You can see that at the 3-year time point, that is 36 months, 48% versus 60% 3-year disease-free survival. This was statistically significant, and based on this, the US FDA immediately approved adjuvant atezolizumab for 1 year in patients who had PDL1 more than 1%. What about the entire population? This was just borderline significant in the IM power 010 data. If you look at the Keynote 091 trial, Keynote 091 had two dual primary endpoints, overall population and PDL1 more than 50%. So unlike, there was some, as you can see, there are some differences between the primary endpoints of these two trials, but let us look at the Keynote 091 trial. If you see the overall population for Keynote 091, yes, the overall population showed that the disease-free survival was prolonged by an average of 1 year, 42 months versus 53 months. But what is interesting is the other co-primary endpoint, PDL1 more than 50%, the group which is supposed to have the best benefit with immunotherapy, this was negative. The hazard ratio was 0.82, the p-value was not significant. You can see that the curves are overlapping at one point. So I could not find any reason for this given in the manuscript other than the placebo arm has performed well. So there was no reason why the placebo arm has performed well, but this was definitely a negative finding. If you see the DFS analysis by the forest plot, as expected again, like in the neoadjuvant setting, the atezolizumab data also shows that the stronger the PDL1, the better the long-term DFS. Less than 1% had virtually no benefit. More than 1%, yes, hazard ratio was 0.66. But the 1 to 49% group also, when analyzed, did not have any benefit. The only benefit was seen in the high PDL1 more than 50% group. And if you see the Keynote 091 data, this is the contrast that we see, that the hazard ratio is supposed to be better in the high PDL1, but in the high PDL1, the data is negative. The recent update presented last year at the World Lung Cancer Conference again confirms the same suspicion that we had, that it is only the PDL1 more than 50% group which has an overall survival benefit. So as you can see, the historical data showed that 5-year survival for stage 3 was how much? 40%. And now at least you have a group with high PDL1 of more than 50% that you are achieving 5-year survival of more than 80%. So this is reassuring. But again, it tells us about the difference in the ethics and the difference in the drug approval policies of different agencies. FDA approved adjuvant atezolizumab immediately after the initial data set in more than 1% group. But the NICE and the EMA took their time, and now they have, in my opinion, rightly approved adjuvant atezolizumab only in those who have more than 50% PDL1. And just last week, FDA has approved adjuvant pembrolizumab in all comers, but I don't think that is the right way to go. And of course, the NICE and EMA committee will take their own time to decide whether adjuvant pembrolizumab is worth recommending or not. What is the reason for this discrepancy between these two trials? We don't know. Is it because of the nature of underpowered subgroup? Is it because of the heterogeneity of PDL1 expression? Because biopsies at a single point in their treatment time and the PDL1 expression varies, we don't know. Or is PDL1 even a reliable biomarker for adjuvant immunotherapy? We don't know. And we still don't have the mature survival data. Just a couple of minutes to discuss about the big debate which is on everybody's minds, adjuvant EGFR TKIs. So I was in Delhi last month discussing about the IMPACT trial. The earlier generation of trials with adjuvant TKI, which gave TKIs for 2 years, they showed a very peculiar phenomena that the DFS was initially better as long as the TKI was going on, but the moment you stop the TKI, the DFS curves, they drop down sharply and the long-term survival is not different. And this is again the same problem with ADAURA. ADAURA took again resected 1B to 3A lung cancers. They only enrolled the EGFR sensitive mutations, and they randomized between 3 years of osimertinib versus placebo. And the DFS was the primary endpoint. And at the recent ESMO update, we saw that the hazard ratio had slightly worsened from 0.17 to 0.23, but it was still very much significant. Subgroup analysis, there was no difference, but this is where I want to show you that now for stage 2 and stage 3A patients, the DFS curves, the moment you stop the 3-year time point of osimertinib, the curves start dropping down because of all these patients who are now off osimertinib, they are relapsing. So we still don't know whether the 3-year duration of osimertinib is correct. Is osimertinib simply delaying relapse? And if so, is this DFS benefit going to eventually translate to a overall survival data? Again, we see the CNS relapse rates are now increasing. The moment you stop the osimertinib at 36-month time point, the CNS relapse rates in the osimertinib arm start creeping up, although they have plateaued in the placebo arm long ago. And we know that EGFR TKIs are not without their side effects. They cause significant amount of quality of life issues in terms of gastrointestinal and skin-related side effects. So to conclude, neoadjuvant versus adjuvant IO decision making must take into account several patient and tumor-related factors, including the PD-L1 status. In my opinion, US FDA drug approvals are to be taken with a pinch of salt. The role of ctDNA-based monitoring will become more and more important in the future. We have seen that ctDNA is an excellent prognostic tool, and it might be predictive as well. And in my opinion, adjuvant osimertinib is still a contentious topic, and we need more longer follow-up mature data before we change our practice. Thank you. Thank you.
Thank you, sir. Moving on to our next topic, common targets in lung cancer approach. This will be discussed in 3 parts. First is targeting EGFR mutation. The discussion will be held by Dr. Srinath Bharadwaj, consultant medical oncologist. I request him to join us on the dais, please.
A very good afternoon to one and all, and thank you, Dr. Nikhil sir, for and the organizing team for giving me this opportunity and having me here. I think we chose on this World Cancer Day because the numbers are going to only increase and increase. That is the prediction, and so the mortality too. So it's the treatment selection is not moving, and it's already moved from being histology based to targeting oncogenic drivers, and we know that the EGFR mutation is the most common mutation occurring in roughly 40 to 50% in Asian population. So the EGFR gene, it's a family of ERB genes where there are 4 ERB1, ERB2, ERB3 and ERB4, and whenever they get activated through dimerization whenever they have a stimulation through one of the growth factors. So they're most commonly found on surface of epithelial cells and overexpressed in a variety of tumors. Most commonly described mutations are exon 19 deletion and L858R point mutation exon 21. They constitute 90% of the EGFR mutations in lung cancer. And as my friend Dr. Shikhar discussed, even EGFR testing is mandatory even in the adjuvant setting before using any EGFR inhibitor. So now we're moving away from the adjuvant to a stage 4 setting and a curative to a non-curative setting. And methods of detecting the EGFR mutation, FFPE block is the most preferred tissue. Of course, ctDNA is still evolving. And real-time RT-PCR is what majority of the institutions are using right now, and Sanger's sequencing after tumor enrichment is also one of the methods that can be used. And NGS, most of the mutations performed on cell-free DNA use this method, and I think the cost is one of the factors right now which is not allowing all of us to do it in every case right away. And the rarer EGFR mutations are the exon 19 and exon 19 insertions, L861Q, G719X, S7681I, and others constitute around 10% and are also sensitive to TKIs. T790M is one of the mutations which develops after starting first or second generation TKIs and is the most common pathway of resistance to therapy. But if it is present upfront prior to any TKI use, the NCCN guidelines and the data advise germline testing, and any germline EGFR T790M confers high risk of lung cancer irrespective of smoking status. The EGFR exon 20 mutations are again a heterogeneous set of mutations, not really sensitive to TKI therapy, but with few exceptions, they also respond. EGFR exon 20 alterations like FQEA and LQEA variants seem to be sensitive to TKIs, and afatinib has the most data in these uncommon mutations, though osimertinib is a reasonable alternative. So these are the approved anti-EGFR agents. I have not displayed agents approved in China. I'm only displaying agents approved by US FDA. The first generation erlotinib and gefitinib, second generation afatinib and dacometinib, and third generation osimertinib. This is a busy slide, quoting the management. We'll go into it in detail in the next few slides. So the first therapeutic options for first-line EGFR mutant non-small cell lung cancer is EGFR TKI monotherapy now. This is the standard of care, and we can go for upfront EGFR TKI third generation, that is osimertinib, or first or second generation TKIs, followed by osimertinib on progression. The other options being EGFR TKI and anti-angiogenesis agents combination, and chemotherapy combinations with EGFR TKIs. So sequencing options again are the same as we discussed. So what should be the preference is what we'll see now. So this is one important slide which I'll keep referring to in this presentation. I've just summarized all the studies with ORR, progression-free survival, and median overall survival. So the highest seems to be osimertinib, which is around 18.9 months of progression-free survival. So 1/3 of all the EGFR mutated patients treated with the first or second generation EGFR TKI are only able to receive second line osimertinib, and it's not possible to do a rebiopsy in majority of the patients, and very few patients actually who receive first and second generation TKIs are able to receive osimertinib in the second line. And brain metastasis at diagnosis, again osimertinib by far has shown the best intracranial penetrance, and the FLORA trial included patients with stable brain metastasis in whom also the benefit was observed, and all the other TKI trials safely excluded brain metastasis. So all these factors make osimertinib the go-to drug in EGFR mutated NSCLC in the first line. Alternatives to osimertinib, as we discussed, a combination of TKI and anti-angiogenesis agents. The global relay trial showed superior PFS for a combination of ramucirumab and erlotinib versus erlotinib alone in patients with previously untreated metastatic EGFR mutated non-small cell lung cancer. The median PFS was 19.4, which is as good as osimertinib. And erlotinib plus bevacizumab also improved progression-free survival to the tune of 17 months, which is again as good as osimertinib, though it's a cross-trial comparison, which we shouldn't be doing. Chemotherapy plus TKI, we have our own Tata Memorial Hospital trial, adding gefitinib to carboplatin and pemetrexed, also showed improved PFS of 16 months compared to chemotherapy alone or gefitinib alone. So the mechanism of resistance, once we use osimertinib in the first line, the MET amplification seems to be the most common mechanism of resistance because it covers up T790M already in the first line. If we use first and second generation TKIs, T790M mutation seems to be the most common mechanism of resistance. So what happens is once the EGFR pathway is blocked constantly, the tumor might progress by bypass signaling activation and sometimes transformation into a small cell variant. So EGFR exon 20 insertions, when present upfront, they carry a poor prognosis. So we tend to start off with chemotherapy, but we have certain options which come up now after progression on chemotherapy. Amivantamab is a bispecific EGFR and MET antibody approved after progression on platinum-based chemotherapy, as it showed ORR of 40% and 74% of the patients remained progression-free at 12 weeks. The median PFS is around 8.3 months and overall survival 23 months. Again, mobocertinib is one of the TKIs which is approved for the same indication. After osimertinib, what is the ideal second line? Post-progression on osimertinib and rebiopsy showing no actionable mutations. Addition of atezolizumab to the combination of paclitaxel and bev improved progression-free survival in the IMpower 150 trial. So what are the common toxicities which we encounter with EGFR inhibitors? Rash is one toxicity which we see with all the EGFR TKIs. It's typically called the acneiform rash, and we shouldn't be using anti-acne treatments here. That is the learning point here, because it's the skin is already dry and we don't want it to become more drier with using anti-acne agents. We have to we have to use only the moisturizer, which is the main treatment for this. Diarrhea is seen in majority of the patients, but it's quite manageable. Pulmonary toxicity with ILD has been reported in very few patients. Hepatotoxicity and ocular toxicity occasionally have been reported. And immune toxicities after initiating osimertinib within 3 months of immunotherapy. So as Dr. Shikhar mentioned in his previous presentation, after durvalumab, we have to at least wait for 3 months in case of a progression to start osimertinib, because there is data that osimertinib can cause severe immune-related adverse events. Erlotinib seems to be the preferred TKI in this setting. A word of caution: we have discussed all this in EGFR mutations, and none of this what we have discussed holds good for EGFR amplifications. Thank you for the patient hearing.
Thank you, sir. For the next speakers, I would like to request them to adjust in a shorter time frame as we are running short of time. I request Dr. Naresh G, Consultant Medical Oncologist, Cancer Clinic, Hyderabad, to deliver his talk regarding targeting ALK mutations. Please join us on the dais.
Thank you, organizers, for giving me this opportunity. Good afternoon, everyone. So, my topic will be on ALK inhibitors in NSCLC. So, this would be my scheme of presentation. So, coming to incidence of ALK mutation, so it is the second most common genomic change after EGFR mutation. So we could see in various studies the frequency ranges from 5 to 10%. So it is typically occurs in the adenocarcinoma histology, and typically they are non-smokers or light former smokers. Tend to occur in younger patients, and the median age would be around 50 years. And we have sensitive and specific diagnostic techniques to detect the mutation. And we know that ALK and EGFR, they are mutually exclusive. So this, you could see this ALK gene, which is present on the chromosome 2, and the most common fusion partner is EML4, and you also have other non-EML4 fusion partners. So you could see is the main abnormality is it's a gene rearrangement. ALK and EML4, they are located on chromosome 2. So it's an inversion type of gene rearrangement which occurs in this fusion. So we have multiple techniques to detect this mutation. We have IHC fish, which are most commonly used, and now we have NGS modality. So we have moving from one mutation, one test to the one patient, one test. So through NGS platform, we can detect multiple mutations at one go. So coming to the evaluation of care in ALK translocation adeno advanced NSCLC. So you could see, so a decade before, there was only a standard was chemotherapy with pemetrexed and carboplatin based therapy. So as you move after 2010, we have multiple TKIs like crizotinib, which is the first generation TKI. We have alectinib, ceritinib. We have brigatinib, which are second generation TKIs, and we have a third generation TKI, lorlatinib, which is now approved in first line. So this is a brief table. So you could see the different trials. So as we move from first to third generation TKIs, the efficacy, the selectivity of ALK inhibition increases, and also the CNS efficacy increases. So this is a first generation, the crizotinib is the first generation TKI. So in crizotinib and ceritinib arm, the comparator arm was the chemotherapy, as you could see here. Whether with alectinib and other TKIs, we have the comparator arm was first generation TKI, that crizotinib. So you could see the median PFS is around 10 months with crizotinib, with the chemotherapy is around 7 months. And as you move with ceritinib, it was around 16.6 months. And they have seen the Asian subgroup population, which was around 24 months in ceritinib arm. And alectinib, we have three trials, Global Alex, Alasia, which included the Asian population, and JLX, which included the Japanese population. So the median was around 25 months. So the recent upset showing around 34 months with median PFS with Global Alex. So compared to North region Alasia, and JLX also showing around 34 months. So with brigatinib also, it was around 2 years. Inacetinib, it was the recent, but it was not approved by FDA. So these trials, they include around 25 to 30% of patients with CNS mets. And the overall response, it ranges from 70% up to 90 with alectinib arm. So this is a recent trial which has compared lorlatinib, which is a third generation TKI, with the crizotinib. The population included was stage 3B for ALK positive NSCLC with no prior treatment. So they were randomized into lorlatinib and crizotinib, and the primary endpoint was PFS. You could see the 1 month, the 1 year PFS was around 78% with the lorlatinib arm compared to 39% with the crizotinib arm, with a significant hazard ratio of around 0.28. So almost all subgroup were benefited, and in Asian subgroup it was around 0.47, the hazard ratio. So the response is around 76% with the lorlatinib arm compared to 58% with the crizotinib arm. So we have a recent 3 years update follow-up data. You could see the PFS is still maintained with 3-year PFS around 63% versus 18% in the control arm, with a significant hazard ratio of around 0.27. So, so as we've seen that the third generation lorlatinib, it was not directly compared with the second generation TKIs. This is a systemic review and network meta-analysis, which is showing a significant 0.54 hazard ratio of benefit of lorlatinib with compared to the other second generation like brigatinib or alectinib. So we know that ALK, they most commonly they have brain mets. So we need to have a better CNS efficacy. So in this trial, you could see the patients with measurable brain mets, they have about 80% response rate compared to the 20% in the control arm, and with the CR rates of around 70% compared to 8% in the crizotinib arm. So this intracranial time to progression was significant with hazard ratio of 0.07. This is an Alex trial. We could see the incidence of CNS progression was 9% when compared to 41% in the crizotinib arm. So this was a competing risk analysis done. You could see when you compare the CNS progression as the first event, it was reached with the lorlatinib with around 0.06 hazard ratio, and the next was 0.16 with Alex trial, and Alta it was showing 0.3. The ceritinib, you could see the PFS was around 26 months with patients with no brain mets compared to 10 months in patients with brain mets. So coming to safety with ALK inhibitors, so the table showing these trials, the GA side effects, transaminases and GA side effects are the main side effects with these agents. When you see the lorlatinib arm, we have a different side profile like hypercholesterolemia, hypertriglyceridemia, and due to CNS penetration, we have CNS side effects like cognitive side effects due to TRK inhibition. So you could see the grade 3-4 was 70% lorlatinib. They are mostly due to the hypercholesterolemia and hypertriglyceridemia, which can be managed with statins. So coming to resistance mechanisms, the most common with crizotinib is L1196M. With the second generation, you could see G1202R, which are sensitive to the lorlatinib. We could see inhibition of almost all mutations are inhibited by lorlatinib arm. And we also have ALK-independent mutations with post-TKI. So it is necessary to do a rebiopsy on progression to know these ALK-independent mechanisms like EGFR, MET, and NF2. So coming to sequencing of ALK TKIs, so we know that the NCCN, it mentions all the like alectinib, brigatinib, and lorlatinib, all the TKIs are mentioned. So you could say the patients with CNS mets, a diagnosis, So we can have an option of lorlatinib, first option, followed by chemotherapy. And also we have alectinib, last slide. But in the cost-effective sequencing without brain mets would be the ceritinib. As we have seen, the PFS was 26 months, and also we have a lower dose with 450 mg recommended with ceritinib. So to conclude, we have multiple first-line TKs approved. Lorlatinib would be the preferred TKA based on these data. Post-lorlatinib progression treatment would be challenging, and cost is a major limiting factor to select these TKAs. Thank you.
Thank you, sir. Now I request Dr. Harish Kanchala, sir, Consultant Medical Oncologist, Yashoda Hospital, to join us on the dais to discuss regarding targeting ROS mutation. Thank you.
Good afternoon, everyone. So, in the next 10 minutes, I'll be discussing about one of the subset of NSCLC, where we'll use targeted therapy in the stage 4 setting. And the last 1 decade, it's a golden era for lung cancer. There are several advancements were seen. The most important was making it more of personalized therapy rather than blanket therapy. And one of them is ROS1. And in this ROS1, we have recently approved, along with the recent approved drugs, only 2 drugs are currently available and useful for, in a metastatic setting. That is crizotinib and entrectinib. ROS1, basically, it is a proto-oncogene which was seen in the normal tissues as well. And exact role of the ROS1 gene is not known. Probably it involves in embryogenesis. And it is seen in 1 to 2% of all advanced NSCLs, adenocarcinoma histology. And along with it has several partners. Being a rearrangement, it has several partners. And most commonly, we see as CD34, that is 74, and as well as azarin and syndican. And the role of finding out these rearrangements is partner genes is not much of value in the recent times. Only some studies suggest that one of the common partners like CD74 has more of invasiveness and more of metastatic potential, and otherwise doesn't have any prognostic value as such on the survival. So clinical characteristics of these particular ROS1 gene mutations have, as seen along with the EGFR mutations, more commonly seen in young subjects and more of women and never smokers or light smokers. And they do have typical, most of the times lipidic and SNR and solid histology with a signaling cell. And they do have a heightened risk of thromboembolic phenomena and DAC as well. The reasons were not known. And they do have high frequency of brain mets at presentation as well as on therapy. At presentation, they do have more than other subsets, like more than around 36% at baseline. And at the time of progression, around 50% were reported to have high brain mets. And most commonly, we use as a screening tool is ISC to detect this ROS1, which is more of a sensitivity reaching up to 100%, and specificity reaching up to 70 to 90%. And because of being present in the normal tissues, it do have more of background noise and more of false positivity. So that's why we use screening test as only in ISC, and this reflexively we have to confirm with FISH, break apart FISH test, because other atypical arrangements or complex genome arrangements sometimes can be missed. And along with these 2 tests, NGS is the current one. We can detect the Q mutations as well as more of atypical arrangements, any other EGFR all present along with the ROS1 mutations and resistant mutations. First line, the first drug approved in 2016 was crizotinib, and this drug was mainly introduced as MET inhibitor, and later was tested along with ALK and ROS1 together because of the homology between these 2 subsets. And being one uncommon subset, there are an expansion cohort of the Profile 101 trial. Around 53 patients were analyzed, and in this 53 patients, the overall response rate was seen was at 72%, and median treatment response was up to 8 months. And in this trial, there was reported outcomes were like median PFS of 19 months, and overall survival at 1 year is 80%, and 50% were living at the end of 4 years. And there are other retrospective and phase 2 trials were reported the similar results in, with crizotinib with ROS1, and the other drug which was recently approved in the upfront, as well as especially those with have brain metastasis upfront, is entrectinib. It is basically treated as NTRK inhibitor with has good activity along for ROS1 as well as ALK rearrangements. The advantage of this drug is it is more potent than crizotinib in the preclinical studies as well as in the phase 2 studies, and it can cross the blood-brain barrier and more of heightened CNS responses. And current approval was based on the pooled analysis of 3 phase 2 trials, StarTrek 1 and 2 and ALCA 372, where this drug was used both in TK naive as well as who are received one line of TK, that is crizotinib. And among the patients, among the 53 patients, there are patients who received at least 2 lines of chemotherapy as well, including 40%, and around 43% do have CNS disease at baseline. And overall response rate was around reaching up to 80%, and those who have CNS disease at baseline also reaching up to 73%. Median duration of response was 24 months in the overall population. It was off in CNS meds, those with CNS meds. And with the median follow-up of 15 months, the median PFS was 19 months, and 1 year survival rate was 85%. Intracranial response was 55%, and median duration of intracranial response was 13 months. And most common side effects were pretty manageable at grade 1, grade 2, like fatigue and constipation, and only two major side effects were weight gain and anemia. So this is a conclusion. This is like summary of what the findings which I told you. The same median PFS was 26 months, and those with CNS meds was 13 months. And other drug which was tried as a second line who progressed on crizotinib was lorlatinib. It was an analysis of the phase 2 data of expansion of the Compassion Access program who have included. Those patients who have received TK prior, like crizotinib, are also showing response up to median PFS with 7 months, and median OS was 19 months after progression on crizotinib. So the side effect profile was pretty as reported with ALK inhibitor studies. Like there was more of grade 1, grade 2, hypercholesteremia, hypertriglyceridemia, and peripheral neuropathy. And other drug which are not yet approved but just got the fast track approval for use in the first line, second line is repotrectinib, which is more potent, 90 times more potent than crizotinib, and it has advantage as more. It was active against the 2032 resistant mutation as well, which is no other drug was active for this mutation. And it was shown to have 90% overall response rate and intracranial response reaching up to 100%, with the median PFS of 24 months in those who have not received any TK prior, and at only 1 or 2 lines of chemotherapy. It was median PFS was 12 months, those received TK prior. And side effects profiles are also pretty manageable. Most grade 1 side effects are seen in 80% of the patients. And of all these drugs available, the more newer drugs are in the pathway based on the resistant pathways we see with this mutation, with this rearrangement, more like a target as well as off-target mutations. And there are several drugs are in the pipeline targeting these these resistant pathways. And currently approved drugs are only crizotinib and entrectinib, and we can use off-label as cabozantinib and repotrectinib for those who have progressed and those who have CNS meds at baseline. Thank you.
Thank you, sir. Now for the next topic, I request Dr. Vamshi Krishna Reddy, sir, to join us on the dais to discuss regarding newer paradigms targeting lung cancer beyond EGFR, ALK, and ROS1. Thank you.
the last but one talk for the day. And I'll be discussing about targeting agents which we will be doing other than the EGFR, ALK and ROS1. So I think what we are doing most commonly is EGFR, ALK and ROS, and we do have targeted agents for these agents. And to discuss beyond these agents, we don't have many affordable agents which we can use in our day-to-day practice. So earlier I think we were treating as either lung cancer or alone, and then we moved from there to probably EGFR, ALK and ROS, and what we are doing now is seeing these agents probably where we see 50% of the patients having any of these mutations. So if 25% of the patients can have a KRAS mutation, that's quite high compared to the EGFR which we commonly discuss. But unfortunately we don't have many medicines for this KRAS mutation. And standard of care for lung cancer is to go for biopsy and see if there is any targeted mutation and try to give a matched targeted therapy. Broad-based NGS panel testing, I think it has already been discussed that it is the standard of care for all those patients who have advanced NSCLC. So including EGFR, ALK and ROS, we need to test for BRAF, NTRK, RET, MET, KRAS and HER2. And all these should be as part of the broad-based NGS panel. Why are we going to do testing for this is what I'll be discussing about. But unfortunately, most of the times we don't order this NGS broad-based at baseline because of the TAT. The turnaround time if you order an NGS panel is at least 2 weeks and beyond. But if you are going for the EGFR, ALK and ROS, we can get these reports probably in a couple of days. So most of us off late, I think we are still doing NGS later in the line, but compared to baseline where we are doing only EGFR, ALK and ROS, mainly that the targeted agents are available in this setting. The biomarkers which I'll be discussing is, the first one is the BRAF. So basic thing that we know that it's a RAS-RAF-MEK pathway where a mutation in the BRAF V600 is a class 1 mutation. We have other mutations which are class 2 and 3, which unfortunately are more aggressive and we don't have any targeted agents for this. So what I'll be discussing is mainly the BRAF V600E. This is the mutation which is probably present in 1 to 2% of the NSCLC and more in smokers. And the only drug which has proven in this setting is the dabrafenib trametinib, where the overall response rate was almost 64 to 65%. And the OS in this setting touched 17.3. All of us know that the BRAF V600 is very aggressive mutation. With chemotherapy, we don't see much response. Drug-wise, I think dabrafenib trametinib, those of us used know that it's not an easy drug to manage. Significant side effects, mucositis and pyrexia. For pyrexia, I think it needs to be controlled at times, even with the usage of steroids, which have to be used if you are using dabrafenib and trametinib. And with this, I think BRAF V600, if it is detected in the baseline, we need to go either for first line dabrafenib trametinib, or if we did not test for this mutation on progression, we need to consider this drug in the second line setting. So I think this was one patient who had this BRAF mutation after using the dabrafenib trametinib. At 14 months, we can see that patient is still in CR. So this is a good drug for those who have this BRAF V600 mutation. And the next mutation is the KRAS. We know that this is one of the commonest mutation in NSCLC. Other than the NSCLC, we also see this mutation in colon cancer. G12C is the most common variant, which is approximately 40% of the total mutations. And sotorasib is a drug which has proven now beneficial in this G12C mutation. And we also had the adagrasib, which is based on the CRYSTAL phase 2 trial. And we can see that the OS with this drug touched 12.6 months. And unfortunately, once we start using these drugs, we don't have that good targeted agents in G12C. And most of them do progress very rapidly, mainly because they have resistance acquired. And the resistance happens in various pathways. And once there is resistance in this, we need to consider other drugs, either with chemotherapy and immunotherapy, or even the FGFR inhibitors, which of late are approved in this setting. And the next mutation is the MET, and MET is the mesenchymal epithelial transition factor. And we have two types of mutations in MET. One is the amplification, other is the MET mutation, MET exon 14 mutation. So MET amplification can happen even on those who are on EGFR TKS, where we see that this mutation can happen in 5 to 20% of those patients who are taking the EGFR TKS. And the other mutation is a MET exon 14, which can present as a baseline mutation. And this is more common in those patients who have this sarcomatoid histology. So those patients who are old and they are never smokers, and probably those who have this sarcomatoid histology have this Metexon 14. Metexon 14, the drug based on the Profile 1 trial, the crizotinib is a drug which was showing a PFS of approximately 7.3 months with a response rate of 30%. And also the capmatinib has been tried in this, and this is another drug which has been studied both in Metexon 14 and amplification with a OS of approximately 13 months. Tepotinib is another drug which has been approved in Metexon 14 mutation based on the VISION trial, and it is approved by both the FDA and EMA in 2022. Capmatinib and tepotinib, we can see that if we compare the overall response rate, both of them have similar response rate of approximately 40%, and PFS is almost higher with tepotinib around 10 months or so, and both these drugs are approved for usage in Metexon 14 mutations. RET rearrangement is another mutation which is seen in 1 to 2% of the patients with NSCLC. These drugs are unfortunately not yet available in India, though they are approved in clinical trials. So we have pralsetinib and selpercatinib. So these two drugs are again approved for those with a RET mutation. The other mutation is the NTRK fusion. So NTRK fusions are one of the mutations which can be seen fusions in lung cancer. Other than this, we see in other tumors also. So this is one NTRK fusion which is being studied across various both pediatric solid tumors and even in adult tumors. And the drugs we have is larotrectinib and entrectinib, and not a common mutation which we see, mainly for the reason that it's difficult to detect based on the common genetic testing. But if you can see the response rates, they are almost 60 to 70% with this drug. And OS, we can see that with larotrectinib, it's almost touching in one of these trials 40 months. Other mutation, I think this was like I had a patient who came, internist from US, that it's a EGFR mutation, please start the drug, I'll take the tablet and go home. So still I think patients feel that any EGFR mutation can be treated with EGFR TK. This is one mutation probably for which exon 20 insertions where the conventional EGFR TKs like osimertinib and gefitinib don't work. This exon 20 needs different drugs like amivantamab or mobocertinib. These are the drugs which have to be used in exon 20 mutations. And other mutation is the HER2. So we know that HER2 is quite common in breast cancer, later in gastric cancer, but we are targeting the HER2 even in lung cancer. We have two drugs. One is the poziotinib based on the Zenith trial, which showed an overall response rate of 40 months. And we also have the trastuzumab deruxtecan, which almost showed a response rate of 60 months, with the response was almost between 8 to 9 months for this drug. So in 2023, what we are going to do in clinical practice, EGFR, we have drugs available. We use them in our day-to-day clinical practice. So if we have EGFR mutation, we are using the EGFR TKs. If affordable, we go for the osimertinib. If unaffordable, we go for the cheaper alternatives, the first generation TKs like gefitinib or erlotinib. For ALK, if affordable, we go for alectinib, or we go for the cheaper alternatives like ceritinib or crizotinib. For ROS1, again, crizotinib is available with us. These mutations, other than these which I just discussed, like the BRAF, NTRK, RET, and MET, we just have available drugs. Bit expensive, but I think we can definitely give a try for those who want to spend. Just a brief overview of the lung cancer small cell variant, because we did not discuss about this. So we have two variants. One is the limited stage and extensive stage. For limited stage, all of us know that we treat with either radiotherapy or surgery and prophylactic PCA. But for extensive stage is one area where probably immunotherapy has extensively been studied in this. And we usually go for platinum-based chemotherapy with immunotherapy for this drug based on these two trials. We have both atezolizumab and durvalumab in this setting, and which they have showed comparatively good OS compared to what we see with only chemotherapy. So immunotherapy moving into small cell lung cancer is something which is going to take over in 2023. So to conclude, for small cell, it is platinum etoposide with immunotherapy in extensive stage SCLC. We need not think about the PD-L1 status. And for the NSCLC, for BRAF, it is dabrafenib, trametinib. For MET, it is crizotinib, capmatinib, and tepotinib. And RET, we have drugs. NTRK and HER2 also, we do have drugs. And most of these drugs are approved across the world. Few of them are available with us, and few will be available shortly. So many more targets and targeted therapies are to come in the near future. So for the lung cancer, it's going to be target-based therapy in the future. Thank you.
Thank you, sir. Now I request Dr. Bharat Vaswani, sir, to join us on the dais to discuss regarding immunotherapy in lung cancer. Thank you.
Good evening with the sparse crowd that is present. I will not bore you. I have a more entertaining presentation, not much of a data. Every slide has a take-home message. Pointer nahi hai par ek minute. So, yeah, you can. So the gist, what is important is, today is Saturday, tomorrow is a holiday. On a Monday morning, if there are students, if you have to write an exam about immunotherapy in lung cancer, you cannot remember any trial. So what I will tell is you have to remember, suppose if I give immuno, how much my patient will improve in terms of overall prognosis. For me, the most important slide, and you cannot present in Hyderabad without mentioning the saliva. So a person who is getting younger day by day, and that is what the lung cancer management is all about. Now we are having what we call as personalized cancer therapy, and that is the gist of today's presentation. The first question to everyone, why should every doctor know about lung cancer? So when you talk about lung cancer, the most common cancer among males all over the world is, in fact, if you see the percentage, approximately 15% of all cancers all over the world are lung cancers. So most common cancer. Second thing, when we talk about India, again one of the most common cancer you say in India, probably you can say fourth common. But more importantly, what is there is when you see the incidence rising, more alarmingly in female. And when we talk about Hyderabad, this is the best point of it. The most common cancer among males in Hyderabad is not head and neck cancer. It is a lung cancer. So probably each of us should start, they may know about it, but each of us should look into it in a different way because this is the way the cancer goes. The most important thing, why you need additional therapies in lung cancer. Now, the alarming thing is, see the distant mets. 70% of lung cancer present in distant, and the 5-year survival is 7% in non-small cell and only 3% in small cell. This 7% you will compare when I will tell you the 5-year data of immunotherapy. This 7 goes how big? And that is the gist. If I give immunotherapy, I give it mainly to prolong life of my patient. In other words, what will be my 5-year survival if I give immuno? So it is 7 versus 3 at present without the use of immunotherapy. So overall survival in lung cancer is very poor. Less than 1/4 survive for more than 5 years, irrespective of whatever stage you take. Hence, you need to go beyond your chemotherapy. We had people who had discussed about targeted therapy, which are oral tablets. What about those 50% of patients who are non-targetable? That is the gist of today's presentation. What treatment we have? We have chemo, we have antivascular endothelial growth factor, and last but not the least, targeted therapy. This is what you know. But the question comes now is, what do we do for patients who are non-driver mutation in your clinic? So EGFR, ALK, NGS is negative. We give immunotherapy to all my patients, provided if their pocket is full, with or without chemo. So it is not that you give chemo. You may avoid chemo in subset of patients. But if you have the resources, please add on immunotherapy to all your lung cancer patients who are non-driver mutation. I'll tell you how much is the advantage. This was a scenario of lung cancer when I was doing my PG and DM and in initial part of my practice. Till 2013-14, we had one EGFR drug, but chemo for all. And we used to give either a pemetrexed, a gem, or a vinorelbine, or a paclitaxel. And the story ended there. But then the change started, and that was what probably we are looking at. The Bahubali of lung cancer, that is immunotherapy. Who are these two gentlemen? Probably you have to remember these one. These were the person who were awarded Nobel Prize in what we say physiology or medicine in 2018 for what we call as the most important, I think so, the game changer in cancer management, that is immunotherapy. And it was the breakthrough of the year 2014. So many articles, so many things probably highlighting that for the first time, you are thinking about curing a lung cancer in a stage 4. Again, this is a hypothetical term because we calculate 5-year survival. So now we are having a 5-year survival of close to 30% in the patient whose PD-L1 is more than 50. From 7, it has gone to 50, and that is what we are telling. So what was the change in management? Before 2014, we used to target the tumor cells. And what has changed is, now we are targeting the immune cells so that they can kill tumor cells. So the focus has changed from targeted tumor cell to immune cell. And why is the most important thing? Once you stimulate your immune system, they keep on getting stimulated. So see the tail of the curve. If you respond, your chances of 5-year survival is too high. So 20 to 30% of these patients respond to immuno. But when you respond, your survival will be 5 years. So that is what, once you stimulate, it is like an auto battery. Once you start, it keeps on stimulating your T cells, ultimately killing your tumor cells. A basic thing. A T cell should kill a tumor cell. But what happens is, it depends upon on what receptor it binds. So if the T cell binds on some receptors like CD28, what we say against B7, it causes stimulation. The most important thing is if it binds to inhibitory receptors, which are we call as programmed death ligand 1, there is an inhibition of cells. So what does immunotherapy do? It just prevents the binding of PD-L1 to PD-1, the basic thing. So any inhibition which is caused by inhibitory receptor, by binding to, I'll go back, just see normally this is a way the cancer cells will not kill, the T cells will not kill tumor cell. So what do these drugs do? These drugs prevent the binding of PD-L1 to PD-1. And basically it leads to killing of T cells. A basic principle of physiology now being accounted in cancer. So you have 3 groups of drug: anti-PD-1, which is nivolumab, pembro; anti-PD-L1, which is what we say our sponsors, Atizo and durvalumab. And last but not least is anti-cytotoxic lymphocyte. So you have multiple drugs, but the basic drugs are these 5 to 6. Now comes, which patients on Monday morning will you use immunotherapy? Should I use immunotherapy alone or in combination? And basically, what is the advantage? Rather than looking into the slides, try to remember what is the take-home message. Multiple studies over a period of time all have highlighted metastatic CA lung. So stage 4 CA lung. So the first thing, how do I decide which patient to be offered immunotherapy? So in lung cancer, you need to do the TPS score. So see the colored slide, right side, I don't have a pointer. So see a colored slide, this is it. So if you have multiple staining of TPS, you are sure to respond. So a high positivity, more than 50% of tumor cell positive, can give a single agent immuno. We can still use immunotherapy in less than 50, but please combine it with chemotherapy. Less than 50 single, double; in more than 50 it is single. The last part, should I give immunotherapy alone or in combination with chemo? So for this patient whose TPS score is more than 50, so the highest stimulating patient, just remember the last. See the 5-year survival of immunotherapy, 31.5%. So from 7 months, the 7% survival, your survival becomes 32%. 32% of my patients on immunotherapy are surviving for 5 years. So this is closest to cure I can get. So don't think twice. If your PD-L1 is more than 50, start immuno with or without chemo. Suppose how much it adds on. So it reduces our risk of recurrence by 50%. More importantly, death by 30 to 40%. So this is the most, if I use immunotherapy, what about 1 to 50? Again, try to look into the survival, close to 2 years. And when you look into the advantage again, 40 to 50% reduction in the risk of progression and 30 to 40% reduction in the risk of death. So you don't have to be intelligent, you have to be smart. Immunotherapy adds up 40% to your progression, 30 to 40% into your survival. This has been discussed by my fellow colleague. Suppose in stage 3, post-CTRT, I should not give chemotherapy. I have to give immunotherapy, and again you have to remember only one thing. How much it adds on? 1.5 years improvement in, I have 4 minutes here, 25 minutes you had given. So this is the main thing. 1.5 years more improvement in survival if I have given immunotherapy for 1 year. In neoadjuvant, this has also been discussed. Again, one thing I have to remember. Suppose if I add on immunotherapy, 12 times more patients of mine will have a pathological complete response. So from 2 to 24, and more importantly, 1 year improvement in event-free survival. So 1.5 years in adjuvant and 1 year in neoadjuvant. And 5 times, or I can say more survival in metastatic. The last part, adjuvant, again, what you need to remember is around 34% reduction in the risk of recurrence. So what you have to remember, everywhere immunotherapy, 30 to 50% it improves your progression-free survival and overall survival. In any of the settings, you take it. Today, with all these data, if you have money and if you have resources, you have to add on immunotherapy to your chemotherapy. Because, and so, is it a game changer? Yes. Is it a final frontier? Maybe. Because in future, you will see new approaches of immunotherapy. So anti-TIGIT, anti-LAG3, you will have so many combination of chemo, immuno, maybe with targeted therapy, and maybe these novel molecules we are adding. So future looks bad. Now, this is the way the human beings evolved, and this is the other way the immunotherapy evolved. So you started from metastatic, so full human being, and over a period of time, now you have reached the early stage. So if I have to say the evolution of immuno is reciprocal of what the man has evolved. So it started from 4th stage, and now we are having immunotherapy in early stage. Every good thing has bad thing. But the problem now is, so all immune-related side effects you can get with immuno. So if you have, it is like an autoimmune phenomena. You can have pneumonitis, colitis, diarrhea, hepatitis. Plus, please remember, it will be 10% or less than 10% severe side effect. So you have to be careful about these side effects, and more importantly, you need to teach a patient. Last slide, how do I treat? For squamous cell, add immuno everywhere. And for non-squamous, if it is non-driver mutation, add on immunotherapy in the first line. Even in driver mutation, you may add on immunotherapy in the second line. So, the last slide. Immunotherapy in lung cancer is a joy, a success, a benefit, and definitely a final frontier which has not been breached. My favorite slide always, 4 rights will never be a wrong. So a right treatment at a right time in a right person will always, I have not written always because that is what you need to understand, will always give you a right result. So if I have to summarize my presentation, till 14, nothing, only chemo and some targetable treatment. But since 2015, immunotherapy has evolved from a drug which was used in the later line. It started from multiple lines, then came in second line, and now is a go-to drug in the first line in all our patients who are non-driver. More importantly, if I use immuno and my patient response, I am thinking of a 5-year survival that is a durable response in the subset of patients. And last, I am always optimistic. Finally, there is a hope for a long-term survival in the deadly disease. And I'll end my presentation with a famous quote of Socrates. The secret of change is to focus all your energy, not on fighting the old, but on building the new. And I thank you all for a patient hearing.
Thank you, sir, for such a wonderful presentation. Now we move on to another case-based discussion. I request Dr. Nikhil sir, Senior Consultant Medical Oncologist, Yashoda Hospital, Somajiguda, to moderate the discussion. I invite our panelists, Dr. Gautam, Associate Consultant Medical Oncology, Yashoda Hospital, Dr. Nishit, Consultant Medical Oncology, Omega Hospital, Dr. Naresh sir, Dr. Srinath Bharadwaj, and Dr. Shrikar sir to join us on the dais. Thank you.
So, good evening once again. We have a few last men standing in the audience, but I am also standing in between you and your house, so you have to listen to me. And thank you so much for everyone to be here. And this is just the last part of today's entire academic session. And we already had discussed a bit about lung cancer management in a advanced setting where we discussed about immunotherapy, we discussed about targeted therapy, we discussed about how do we diagnose the patient. So we just try and understand through some of the basic cases or very simple cases and see whether we can try and make some sense so that we may have some take home at the end of the day. So, okay, we have all the, okay, who is, okay. So, we have got quite a elite, our panelists with us, all are good friends of mine. And let us start with what has happened in the last few months. We have witnessed a lot of things. So, we have a lot of disappointments. Like, we had this ongoing Ukraine-Russia war, which is unending. We lost into the World Cup. And the latest nail in the coffin is, what we all been talking in the last few days. Having said that, a lot of good things are happening, and that too, especially in the field of oncology. And despite everything happening, despite everything falling around us, as an oncologist, all of us are extremely happy because a lot of good things are happening, especially when Bharat just now mentioned that the patients are surviving longer. That is one of the most joyous moments for any treating oncologist. And that has all happened because of the newer innovations in the field of oncology, and that is something what we are going to discuss. So we are going to discuss couple of cases. I am sure we are all running out of the time, but I will just try to discuss couple of cases, and maybe we should have some basic take home over here. So let us start with the first case, and here we had a 55-year-old male, non-smoker, stage 4 non-small cell lung cancer adenocarcinoma with a multiple skeletal metastasis. So this is our basic information. So question to Harish, how will you approach this patient for further investigation?
Non-smoker and adenocarcinoma. So first I would like to go with the NGS panel to find out any driver mutations. Patient is looks ECOG1 and doesn't have any much of symptoms.
Expectedly, yes. Since we are discussing, probably we can assume that.
So I'll go with the NGS first, sir.
Okay. And what kind of NGS you would offer to the patient?
So
what do you do in the practice, and what are you expected to offer?
Sir, I'll go with the 11 gene, 12 gene panel, including the EGFR, ALK-ROS1, BRAF, along with HER2/neu and MET.
Will you do routinely MRI for the patients, for such patients?
Without symptoms, I'm not doing it, sir.
Okay. Gautam? Stage 3 and stage 4 you would advise? No, I'm not talking about stage 3 here. We are talking about a properly advanced metastatic setting. So would you recommend? I think Harish has already elaborated nicely in his talk when he's going to do that. Shikhar?
Sir, ideally, I would like to do an MRI of the brain, even if the patient does not have any symptoms, because that will help me in choosing my therapy, whether or not I'm going to offer the patient a third generation TKI or not.
Of course, we'll come down to that, because once we have a driver mutation, we can talk about it. The question why I put forward was, when you, in the initial era, when 2008-9, when we were initially studying, that was a time we used to send those only EGFR. That was the only information what we had, and that is what we used to do. And it has been the case for many years, after maybe initial 3-4 years, where we used to, when we started learning more about ALK and for that matter ROS1, so we used to do those individual tests, like we used to do EGFR by PCR, we used to do ALK by FISH, and so on and so forth. But with the current plethora of information, the very reason why I put those cups over there, just to make you understand that we have got multiple options now in terms of the NGS panel. So we have got a small panel, we have got a medium panel, we have got a large panel, and we have got extra large panel. And in a way it's good, and in a way it's also challenging what to offer to the patient. So just to make everyone understand what is the difference between all these things, something what I already had mentioned about initial single spot mutation. If you have got, let's say, many, if we can only are trying to understand only one particular gene, then this is what we usually used to do in the past. Only try to identify a single gene with whichever technique, like over here we are talking about, let's say for example, EGFR. Similarly, there were eventually came as one kind of a basket of tests, like 4 or 5 tests, which used to come together, and that also used to give us some kind of basic information, but it again used to miss a lot of other important genes which are equally important for us. So that used to happen. So sometimes we used to have couple of genes identified, and then subsequently we eventually had what is called as comprehensive genomic profiling, or NGS, where in one go one can identify multiple genes. And here is a challenge. Since we know that, I was just talking to Bharat, which particular lab you send, and he had one answer. I'm sure everybody has their own choices. So what is typically Harish, what do you do in your practice? You send a comprehensive panel, or you send a, how is it?
I do send comprehensive only, sir.
Okay. And what about Gautam, what do you do in practice?
I do send
Comprehensive panel. Shikhar?
Sir, I usually don't send comprehensive panel. I send only a limited panel of 12 genes, or at the maximum, because we have medicines to target only those genes only. So I don't think a 50 gene or a 500 gene panel would really help me to decide the treatment in that scenario.
What about?
We do the basic EGFR, AL cross and PDL1 in-house, sir, and then send for a comprehensive panel.
So what we have been doing all these days was we are trying to find if someone can give us some kind of support for the patient for testing, and that is exactly, even still now we do follow. Whether we are right or not, that remains a question. But you know, now there are, as you can see over here, this is one hotspot panel which do offer a lot of genes, and we don't know what to do with a lot of many genes. That is again an issue over here. Again, if similarly when you look at the Oncomine, again Oncomine will give kind of some test which you may have some kind of target which we are really looking forward to, because that is the way you are going to treat the patient. At the same time, we'll also come across a lot of information like a gene copy number and fusion drivers. Now, in a real world, or I would say in an ideal scenario, yes, we probably are right to advise maybe a test like a Foundation One, or I would say equivalent OncoRx, all those tests which are like a 300, 400 gene signature. The problem remains what exactly we are going to do is what it remains a question. Bharat. So, since Bharat asked whether it's a DNA or RNA, what will you prefer in your practice?
Sir, important is both, sir, actually, but especially when you go for the NTRK. RNA is, some of the mutations, RNA is more important than DNA sequence.
Especially the fusions and all are more
evident
on the RNA.
Correct. So fusions, some uncommon in the DNA might miss few, but the RNA probably is expected to pick up, and that is a very clear understanding in the recent times. But this is exactly what we have evolved over a period of time, where we had seen patients who were EGFR negative by PCR and still been picked up by NGS, and these are always those small % of patients sometimes we definitely came across. So as we understand, there are panels, there are small panels, there are big panels, there are massive panels, and there are patients who sometimes really ask for a specific panel, and something what we often do in our practice. The point what I am trying to drive home for audience is that the molecular testing is of paramount importance in the lung cancer patient in an advanced setting. Nobody should be treated without a proper investigation. So gone are those days when you only see a histopathology and start treating, so that should not be the case anymore. So this is something what we had discussed, and we also know there are certain challenges in this area why we want to, sometimes we want to do small panel, like when we work in a rural setting, sometimes like where I do in a rural setting, we have challenges to offer patients NGS for all patients. And there are times when there are cost constraints, the tissue is quality is real problem at times, and there are other challenges. At the same time, diagnostic use in tumor which are molecular heterogeneous. So these are again important points over here. Sometimes when the tissue is not an issue, then you can opt for a bigger panels and something what can be done from patient to patient basis, and when there is cost is not an issue. And as I've mentioned, this is a real challenge again in India. Every company tells us that this is what we are going to offer and how we are different from the other companies. And since every company gives a different set of, somebody offers DNA, somebody observes give RNA, somebody says I am giving 390, and others say I am giving 393. And this typically is what is happening, and this exactly is happening in the real life, where everybody is trying to convince the doctor that how they are better, how they are different, and that remains a challenge for all of us. So with this, I would just, in the first case was only to highlight the importance of testing, molecular testing in the lung cancer management. I will just come to one more case, which is just to make our audience understand that how typically we try and approach our patient of lung cancer in general in our day-to-day practice. So here is a 65-year-old male smoker who is diagnosed as stage 4 non-small cell lung cancer, squamous carcinoma, P40 positive, TTF1 negative. Patient's PDL1 was 60%, and patient had lung mass, pleural effusion, and multiple skeletal metastasis. So what are the treatment options we are having? I will start with Harish here.
Sir, PDL 60%. So options available for this gentleman are single agent immunotherapy, and if not affordable, then chemotherapy alone.
Okay. Any other opinion? Shikhar, Shrath? 5% will have EGFR ALK ROS. So do you routinely do for all squamous carcinoma patient?
I do only for non-smokers.
Non-smokers.
Squamous, if it is.
Exactly. Any other, Shrath, anyone?
So we can always combine pembrolizumab with chemotherapy.
Okay.
We can
50% we can.
So
Yeah,
have
we
you,
can
have
still
you
combine.
any one of you had seen the TMH data about EGFR in squamous carcinoma by any chance? Dr. Kumar's data? Okay, we'll come on to that. So these are some of the options what one can consider over here. I think right now, just now mentioned by Harish, Pembro alone remains a very appropriate choice with, I would say, PDL1 more than 50%. Pembro chemotherapy options, CM9LA, where combination of immuno with chemotherapy. And of course, chemotherapy followed by second line and so on and so forth. These are all checkmate studies. And any other what I specifically mentioned, what the very reason was, I just wanted to bring home the point that is it important to do molecular studies even in the squamous carcinoma. So for this patient was started on, as per the KN, let's say 407 regime, let us say for whatever reason. Patient received 4 cycles, patient had a partial response, patient continued on pembro maintenance, and eventually after 8 cycles, patient had progression. So I'll start with Shikhar. What would you do now?
So although the REVEL trial did not include patients treated with upfront IO combination, but then you can give them docetaxel ramucirumab as per that, or either single agent docetaxel. The point of doing a biopsy here is not very clear because it's a squamous carcinoma, so I don't think any driver mutations will be picked up at this point, but that is always an option which can be done either now or after progression on docetaxel ramucirumab.
Gautam, anything you want to add over here? PS is 1. All, since we are discussing, PS has to be taken as 1. Same. Harish? Chemotherapy docetaxel. Now this was not my case. One of my friends had sent this case to me. That's the reason I am discussing this. The patient was subsequently started on next line therapy, but as Shikhar mentioned, smart medical oncologist asked for a biopsy for the patient, and it was sent for again for NGS, and this is what exactly it came out as. It came as MET exon 14 mutation. So the problem is, this is exactly what is happening, and there are times when we don't know what to do, and still we feel that no, it's such a challenging situation, we don't know what to do. So how would you approach, Harish, this patient, now that we have got driver mutation identified in squamous carcinoma, which was not expected, and yet we found one?
Then definitely just already start on chemotherapy, we'll continue chemotherapy, and if it again relapses, I'll try the driver targets.
Okay. What about Gautam? So the point which I wanted to bring forward over here is that lung cancer at times can throw you some some kind of, I would say, erratic results. And that is something which all of us had seen. The more you see the patient, the more you realize that these patients probably don't follow any particular pattern after maybe, so you should always be willing, if the patient's performance status is good enough, to challenge them one more time with one more biopsy, and patients or relatives are motivated enough for subsequent lines of therapy. Sometimes you come across this information. And that was something, sorry, I'll just skip this slide, this one. As I mentioned previously, that it's important when you look even at the guidelines also, when you look at the squamous carcinoma over here, and again you can realize that even NCCN guidelines do recommend genetic analysis even at the baseline. So one should not miss on to that information. The reason is, if you look at TMH data, they had kind of picked up 5 to 7% of EGFR mutation, not EGFR amplification in squamous carcinoma. And these patients were actually treated with anti-EGFR TK with almost, I would say, comparable outcomes as compared to our adenocarcinomas over here. So I think we might skip this case. Okay, we'll just quickly touch base this case. Okay, so here is a 55-year-old male diagnosed as stage 4 non-small cell lung cancer. PET CT, right lung mass, bone metastasis again. ALK was positive by IHC, NGS was not done for whatever reason. This is the only information what I have for the patient. So I think one of our previous speakers has kind of described about the ALK various variants. So do we routinely do in the first line, Harish?
No, sir, not in the first line. Definitely, we do for ALK. We'll do definitely in this case. ISC is okay. It has 100% sensitivity, and only in the when it is progressed on the first line TK, then at that point of time we can see for variants and other mutations or co-mutations.
So which company is doing it?
No, I'm not doing it. This is just
no, I think Foundation is doing it. Sometimes they do come across, if at all you really ask for it, but something which even I have not done many times in the practice. But at times, if you want to get that information, it can be made available. It can be really be searched for. And whether we should be doing it really in the day-to-day practice, probably still, I would say there will be two schools of thought. One school of thought may say, anyway, we have got a pan-ALK inhibitor, why do you want to do it? But there will be some mutations which may not be as well covered with lorlatinib, so that remains a challenge. So anyways, this patient was started on, let's say, alectinib, tolerated well, PET CT after 6 months had a partial response, patient was doing well, and at the end of 15 months, patient had a progression one more time. So what will you do now? Let us start with Shikhar.
So this patient has progressed on alectinib, and we need to know what type of progression is it. Is it an on-target mutation? Is it an off-target mutation? Is it a small cell transformation? We don't know any of these things. So to answer all these things, we would need a biopsy and then submit it to an NGS panel.
Absolutely, absolutely. Gautam, anything you want to add here? So biopsy is something which we try and do all the time. So this is kind of second take-home message for everyone. One initially was more about how to do molecular studies. This is more about how to do rebiopsy. These are quite important steps. Having said that, this patient was eventually was planned for subsequent biopsy, and this was his biopsy report. And here, as you can see, this patient had again another ALK variant which was noted, which was 1171A, which was again a missense mutation, and of course the AML for ALK was identified. The challenge is when you try to search on information that 1171 mutation is common resistant mutation in ALK positive, and these patients while on alectinib are sensitive to ceritinib, and we are already thinking about using lorlatinib. So what will you do now? Harish, will you use lorlatinib or will you use ceritinib?
If it is sensitive, we'll definitely try with sensitive. So because after progression on alectinib, lorlatinib, there are responses, but not much good, like around 20%. So probably with the available information, we'll try with ceritinib and assess after 2 months.
Yes, that's a quite important point. What about you?
Prefer lorlatinib, sir, because quite some data that ceritinib would work after alectinib.
No, there is a data. If you go by some case reports, we'll always come across some reports where you'll get some but I do agree that when you use lorlatinib, you have got slight comfort of use of more of a pan-ALK inhibition where you can actually slightly comfortable in that zone. But these are the real challenge and the real cases what I'm showing, because I already showed you the result also. So these are real challenges, these are real treatment dilemmas what sometimes we come across. But having said that, as far as possible, try to identify what are the mutation. This is something kind of, it's like a, I won't say it's a AI, it's about our own intelligence, which we keep on improving over a period of time as we keep on doing more and more tests over a period of time. Having said that, this patient was treated with lorlatinib and patient continued to be in some kind of control over a period of time. A quick word about oligoprogression, Gautam. In oligoprogression, especially in the era of TKI, do you consider any local therapy for these patients? How do you manage? Or you try and change the treatment? Local therapy with radiation. Any, Harish, anything you want to add over here?
So the oligoprogression, definitely I don't change therapy. If it is single brain metastasis, I would like to go SRS and continue the therapy which is already on. Single bone metastasis or whatever. And because I would like to keep the options for next line of treatment, I don't want to use all the armamentarium. Right.
So for the patients who are, let's say, on our TKIs, like a tablet oral therapy, are you more, will be concerned about a symptomatic progression, only radiological progression? How do you do in your approach patients in your practice?
So symptomatic progression, and definitely if it is visceral sites, even asymptomatic progression also I'll take it as progression, I'll treat that.
Okay. Shikhar, anything you want to add here?
I agree with Harish sir that if the patient has symptomatic progression, then it warrants an immediate change in the treatment. If it's asymptomatic progression limited to sites which are amenable to SABR, then yes, maximize the PFS with the previous drug and try to delay the next drug as much as possible.
Okay, I think that was probably my last case. There is one more case, but I don't think I will be able to take it. Just one quick word about this particular slide, which is quite important. Here is one of the data by TMH. These patients had, let's say, patient who had got dual, let's say, EGFR and ALK. What would you do? And what they did in this study was they actually combined both. They used anti-EGFR as well as anti-ALK treatment. And in conclusion, what they found that the patient who received dual inhibition had a better outcome. Of course, the numbers are quite small. You can make out in terms of the way the curves are looking, I'm sure. But at the same time, this is some bit of a data which is available that they have got thrown some data where combination can be used in some patients. So these are points to drive home. As I mentioned previously, genomics is the of utmost importance. Without genomics, this entire lung cancer oncology, lung oncology completely is a totally different ballgame. We do have PD-L1, but at least at the same time we do understand it's a robust marker for in some occasions, it's a confusing marker for some other occasions. So we are still in a search of better biomarker in particular when you talk about immunotherapy. Rebiopsy is something what we discussed quite emphatically, and it is quite important that whenever it is possible to consider for rebiopsy. Targeted therapies and immunotherapy, we already touched base in our previous talks, and these kind of form the major pillars for the current treatments in addition to chemotherapy. So just the way Bharat had mentioned, 4 rights, I think I mentioned 3 rights over here: right patient, right target, right drug, and of course right, I would say, approach towards the patient, and that is kind of going to make our patients' outcome the best possible in terms of their longevity. So with this, I stop here. I thank you so much. I thank you all my panelists for their discussion, and I will hand over to Firdaus for the. Are you going to conclude, or shall I conclude? Okay. So I think since I am the last man standing over here, I am not sure if Mr. Karthi is around, but I just wanted to thank everyone, each and everyone. I am sure we had a lot of audience till afternoon, and I am sincerely thankful to each and everyone. I am also thankful to all my colleagues from medical, radiation, as well as surgical department, and all the other affiliated departments who had helped us. I want to sincerely thank all my other faculty members who had come despite their busy schedule. I'm sure some of them are traveling tonight and some came by metro, I think. But thank you so much. I really appreciate each and everyone. I thank you. I'll just hand it over to just 1 minute. And also, I would like to thank you, my team members, Dr. Firdos and Manisha, and of course our marketing. His name is Senthil, by the way. So, thank you so much. Thank you, everyone. Last part is pending, I think, which is a bit of a prize distribution. I think you can finish it off. Yeah.
Thank you, sir. Thank you, everyone. To conclude, I invite Dr. Balasubramaniam, sir, on the dais to hand over the mementos to our panelists and the speakers of the last session. I request Dr. Shikhar Kumar, sir, to come on to the dais to collect his memento, please. I request Dr. Srinath Bharadwaj, sir, to join us on the dais. Dr. Naresh G, sir, consultant medical oncologist, please join us on the dais. Dr. G. Vamshi Krishna Reddy, sir, please join us on the dais to come and collect the your memento. I request Dr. Bharat Vaswani, sir, to please join us on the dais. I request Dr. Gautam, sir, to please join us on the dais. Now I request Dr. Nikhil SG, sir, to please join us on the dais.
We have a memento for Firdos. Just see once. Yes, come. So she has been behind all the smooth conduct for today's meeting. So a big round of applause for her, please. So here we conclude, and I hope everyone has a very great evening ahead and a good weekend ahead. Thank you so much. We again look forward to see you soon for our upcoming meetings. Thank you so much.
Twelfth,